challenges of our time. Despite remarkable progress in medicine, mission of individuals and families around the world continue to be affected by this complex disease. However, the story of cancer care today is not only about challenges, it also about progression, innovation and hope. The phrase, the next frontier, represents the existing new horizon in cancer care, breakthrough in early detection, precision medicine, immunotherapy, advanced surgical technique, personalized treatment strategies, and comprehensive survivorship care. It reflects our collective determination to move beyond conventional boundaries and redefine how cancer is prevented, diagnosed, treatment, and managed. Today's gathering brings together brilliant minds from across disciplines, oncologists, researchers, healthcare professionals, and policy leaders who are united by shared mission to explore new possibilities, exchange knowledge, and shape the future of cancer care. As an embark of today's discussion and presentation, let us remember that every advancement in cancer care ultimately serves as a deeper purpose to bring hope, healing, and improved quality of life to patients and their families. With the spirit of innovation, collaboration and compassion, I warmly welcome each one of this conference on Cancer Care, the Next Frontier. Thank you, and I wish you all a meaningful and inspiring conference.
Session 1. Now, it's my great honor to introduce the speaker of the session, Dr. C. Fiula Esther Thangam ma'am. Madam is currently serving as the principal of Nehru College of Nursing and Research Institution, Coimbatore. She brings with her over 23 years of experience in nursing education, administration, and clinical practice. She holds a Ph.D. in nursing and master degree in medical surgical nursing and a postgraduate diploma in biostatics. Madam has made significant contributions to research, particularly in cancer care, with her doctoral work focusing on improving the quality of life among women with cervical cancer. She has published several research articles in reputed journals and has actively presented papers and posters at national and international conferences. She is a dedicated research guide, having mentored more than 35 postgraduates and over 30 undergraduate projects. She has also served as a resource person, moderator, examiner, and inspector for various universities and professional bodies. Her excellence has been recognized through several awards and honors, including a Merit Award from the Honorable Chief Minister of Tamilnadu for Academic Excellence and the Achievers Award from Nehru Group of Institution in the year 2024. We warmly welcome Dr. C. Fiula Esther Thangam ma'am to deliver her session on the topic From Cells to Chaos, Unmasking the Cancer from Risk Triggers to Tumor Types. May I now esteemed principal Dr. Renuga ma'am to welcome our speaker, Dr. C. Fiula Esther Thangam ma'am, with a bouquet. Thank you, ma'am.
Slide share. Good morning, one and all present here. Not hear voices from the last. Good morning, all of you. Okay. Hope majority are undergraduate students, right? Okay. I thank the organizing team members and the management and my beloved senior and the principal of Abirami College of Nursing for allowing me to be a resource person for this wonderful conference. And the great thanks goes to an MC for an elaboration introduction about me. So the topic which has been allotted to me is unmasking the cancer from risk triggers to tumor types. So you all, first slide. So you all aware that cancer is the second leading cause of death in the world, right? Apart from the cardiac disease is the first leading cause of death. So the cancer is the second leading cause of death in the worldwide. And what is the important thing which we all supposed to understand here is the 40% of the cancer will be a preventable cancer. Am I audible? Okay. So the 40% of the cancers are a preventable cancers. So being a health professionals, what is our major role here is bringing an awareness to the society and what are the major risk factors which play a crucial role in cancer development and how can we prevent the cancers. So only the 60% people will be suffering with the clinical manifestations and the other complications. So the 40% very well you can manage the cancer and you can prevent the cancer. That is what your National Cancer Institute of India is emphasizing. So now there is a hashtag and everywhere the slogan is being passed stating that majority of the cancer, especially the breast cancer, cervical cancer and your prostate cancer, these are the common cancers which you can notice it that is completely preventable. So being a health professional, our role is we must aware of what are the common triggering factors as a risk factor and that how can we control it and what awareness we must be given. So these are the areas I am going to deal it today with you all. Next slide. So before that, a small introduction about the people who may not exposed into the curriculum of cancer. So the small introduction about what is the meaning of cancer. The cancer is a word which has been derived from the Greek word, called as karkinos. This is otherwise called it as crab. So all are very much interested. The non-vegetarian likes crabs more, right? Yes or no? Yes. So why they have compared the crab? Who invented this karkinos word? He is the father of medicine called as Hippocrates. Around 400 BC, he invented the term called as karkinos. Karkinos is called as a crab. So if you see the crab, there is a center part is a heart tumor part and there will be a projections around the center parts. It's like a legs which is been spreading over the areas. So what is the meaning out of it is the tumor is present in the center. It is a hard mass which is being present in the center and there is a swelling of the veins, the swallow and veins which is being surrounded. So when the cancer is being spreading, it will spread through these veins and it will be spreading to other organs. That is the meaning of your cancer. So cancer as a word is derived from the word called as karkinos. That is what the study of cancer which we called it as oncology. Karkinos, onco. So this is the word which is being derived. Next slide please. Can you put off the light? It's not possible. Off. So that is it visible? The slides are visible to you. The people who are sitting in the last, is it visible? Can you tell me? Yes. Excellent. So let us move on to the incident. ஒரு தடவை போட்டேன். Okay. 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 So the next is, let us move on to the incident. Why are we bothered so much about cancer? Shall I continue? I think this is enough. Video recording. Anyway, it's okay. So if you take the global incident, the global statistics in the year of 2026, 10 to 20 million new cases will be detected at the end of 2026. At the same time, more than 10 million people will be die at the end of 2026. Crucial, which is an alarming thing, which being a health professionals we must understand it. So for the past, next slide ma. So if you see the 10-year statistics, so the linear diagram, the line diagram illustrates here the past 10 years from the 2012 to 2026. So the incidence of your new cancer globally, see gradually it is increased. So you could see here there is new cases from 14.1% and it is expected to be 21.1% at the end of 2026. So it is a number which is highly alarming to the health professionals. At the same time, if you see the mortality rate, the cancer death rate for the past 10 to 15 years, it starts from 8.2 to 10.5 deaths, you can see it. There are slight decline in the 2022, 9.7. Again, it has been increased. So again, it is an alarming sign. Being a health professional, we must notice it. So next is, what are the common cancers? Next slide. What are the common cancers are being a warning sign, warning thing for the health society? See, first stands in lung cancer, second placed in female cancer, breast cancer, third in colorectal cancer, fourth in prostate cancer, fifth is stomach cancer. See, till 2025, breast cancer was a leading cancer. So this year, lung cancer was come in the top position. It's become the first position of the cancer. See, hardly 12.5% of the total cancer, the lung cancer is taking place. That is 2.5 million people are being affected with it. And the least is the stomach cancer. That is 9,70,000 people are being affected in the 2026. When it comes to the status of, next slide, when it comes to the status of India, Indian incidence, see, it's a very horrible thing. Every 1 in 9 Indians, out of 9 Indians, 1 person is being at risk of developing any one of the cancer. Developing any one of the cancer. Out of 9 people, 1 may develop a cancer. It can be any one of the cancer. And the census of year 24-25, the 8 to 9 lakh of people were died Maybe it has declined compared to the previous year, but still 8 to 9 lakh of people were died because of the cancer, and the new cases which is being detected as around 15 lakh of people were diagnosed newly in 24 and 25. So this is again an alarm sign. So the number of cases are increasing it. So what is happening? Maybe the death rate is coming down. So you all must notice it here. The death rate is coming down. The number of new cases is increasing. Why the death rate is coming down is maybe the advanced medical management. People are getting awareness and they are adhering to the medical facility. They are able to compliance is more for the people. So those reasons people are able to, we are able to get the mortality rate down. At the same time, maybe the different reasons, the risk factors are more, that's the reason the new cases are being increased. So it is again the thing which all must be noticed. Next slide. Next slide, Paul. So if you see in India, based on the demographic, for the men, women and the children, what are the common cases, common cancers which is being affected? For a female, the major 3 cancers, breast cancer, cervical cancer and ovarian cancer. They are standing in the top positions. Those 3 are standing in the top positions. And for the men, lung cancer, oral cancer and prostate cancer. For children, leukemia, brain tumors and your lymphoma. So these are the common cancers as per the demographics of the population. So this is existed in India also. This is common worldwide as well as India. Next slide. Next slide. Okay. Before we could go to, so are you all clear with the incidents? So is it not an alarming sign? Is it not an alarming thing? Being a health professional, we must take an action against it, or we must do the prevention of it. So let us move on to certain terminologies. Before you could go to the condition, let us learn the certain terminologies. So benign, malignant, metastasis, in situ and tumor or mass. What is meant by benign? See, we are going to talk, maybe the forthcoming speakers may talk much about tumors, malignancy, metastasis, all these things. I am not going to talk much about it. I may be talking about the risk factors. So here these words will be definitely helpful. The benign is a non-cancerous tumors that do not spread to other parts of the body. It is not called as cancers. It is a normal tumors or a lump which will not spread to other parts. And what's meant by malignant? Malignant is purely a cancerous tumors that can invade nearby tissues and spread to other parts of the body. Definitely it will be spreading to other parts of the body. And metastasis is, what is metastasis? The cancer cell will be originate from the primary site, that is exactly which part of the body it is starting. From there it will be spreading to other parts. That is called it as again the metastasis. In situ, what is meant by in situ? The tumor is in situ. This is what we use the word. What's meant by in situ means exactly the tumor is being present only on the primary site, which is being not moved into other parts of the body. That is called it as an in situ. And what's being called as tumorous is there is any abnormal lump of tissue. It is formed by rapid and uncontrolled cell division. There is a formations of cell division. You all would have been learned it. Mitotic and meiotic cell divisions. So 2, 4, 8, 16 like that. So that kind of cell division will not be happening. It's the immature cells will be proliferating and they form a group of immature cells. That is called it as your cancer. So these are the common terminologies. Maybe your future speakers may use these words. Next slide. So let us move on to the definition of cancer. Can you put off this fan? So cancer is the disease distinguished by the unregulated proliferation and dissemination of anomalous cell. So what is the thing is which you have to notice here is unregulated proliferation. Unregulated proliferation is the sudden increase in numbers and size of the cells which is being produced continuously, and it forms as a cluster. And what does this anomalous cells are? It is not a useful cells. It is not a matured cells. The matured cells only will be able to do the functions properly, which will be able to carry the oxygen and nutrients to the other cells and other parts of the body. But the anomalous cells which may not be in a position to do their function properly. So this is by the National Cancer Institute. And what is the thing which we should understand is, it will be damaging the surrounding tissue. When the cancer has been started, it will not only affect the particular primary site, it will be affecting the surrounding tissues and the other organs also. And there should not be any myth, only cancer will affect only this particular organ, this particular part. It will affect any part of the body. It affects any organ of the body. So it can occur anywhere in the body, and it can occur to anybody. It's not that I will not get it, she will not get it, you will not get it. Anybody, if they are being with risk factors, definitely we will be in a position to develop a cancer. So such kind of myth must be eliminated in the society. The next slide. Excuse me. This also can be turned. Okay. So you all aware of what has been by cancer? Clear? Are you all clear with what is cancer? Yes. So what are the characteristics of cancer? So there is a normal cell and there is an abnormal cell. So what I said is, the abnormal cell has been getting proliferating and it is forming a tumor, isn't it? So what it has certain characters. We are going to see the three main characters of cancer. So definitely you will understand this is what cancer cells. All must listen here. See, you have spent a lot of money and you came over here. Listen the concept. This is not the place where you can enjoy it. This is the place where you can enlighten yourself with the knowledge. So the uncontrolled division of the cells. The first point is uncontrolled division of the cell. See, you cannot control it. See, usually what will happen is when a cell is being occurred, so there will be a mitotic cell division. One cell, from there again 2, 2 from there 4, 4 from there 8, 8 from there 16, so like that there will be a mitotic division will be taking place. But here in a thing of cancer division, see, you could see that what's happening here. See, from one cell, this is a cell, this is an immature cell. From there are so many cells are being formed. That is all with immature again. Again from the one cell, again there are so many nucleus, so many cells are being there. So this is how there is a cluster of cell is being formed which cannot function as a normal cell. That we must understand. What is the normal cell function? It carries oxygen and nutrition to the other cells and delivers oxygen to the part of the body. Here that may not be possible because there is a sudden proliferation of the cells by increasing the size and increasing the numbers. So automatically it can lead to an immature cell and it forms a tumor. This is how the first characteristics of cancer. Next slide. Second is by seeing the shape of the cell. The cancer cell, the physical changes, what you can see it is, very well the comparison is being done here is, you can see there is here the proliferation. That's what I said. The first thing which you can notice is sudden proliferation. There won't be a formal cell division which will not happen here. Sudden proliferation. So many cells will be formed. So continuously the proliferation will be taking place. And every cell, if you see the normal cell, one nucleus and inside there is an cytoplasm, chromosome, all these things, there will be a formal way and there is a shape, there is symmetry, all those things will be there. But in case of your cancer cell, it will be various in size, it will be various in shape. See, you could see the size and shape of the cell is being different. The third concept you can see it is here the nucleus, where I am showing the light. The nucleus is larger than the normal cell. Nucleus is larger than the normal cells, and it will be darker than normal. And see, you can see that the chromosomals are arranged in a disorganized manner, and more amount of chromosomes are being present in this, and those cells are being formed as a cluster. Here there is a well-defined boundaries can be seen. Here there is no well-defined boundaries. When you doesn't have a well-defined boundaries, you will not be able to carry the messages or communication to other cells. So that is the major drawback of your cancer cell. Next slide. The third character is communication and sensitivity. They lose the ability to communicate to the other cells. That means they will not be able to pass the information. What information? Carry the oxygen, carry the nutrients. They will not be very sensitive. So they lose the sensitivity, like I need an energy, how will I get the energy? So that sensitization will not be there for the cancer cells. The normal cells will be able to sensitize the areas, but in the cancer cells it will not be possible. So what are the three major characters? Anybody? What are the three major characters of excellent, excellent. Next slide. Okay. So the common cancer types which India is making it as an alarming thing. These are the areas we must be concentrated. Bladder, breast, endometrial, leukemia, pancreatic, thyroid, lung, melanoma, kidney cancer, lymphoma, prostate, colon and rectus. These are the common cancers. Indian government, National Institute, Cancer Institute is saying that we need to take care of these areas. We need to prevent, we need to give an awareness of all these areas. This is what the India has emphasizing it. Next slide. Okay, so I told you the first slide, 40% of the cancers are preventable. So, before we could prevent it, I must know what is the risk factors I have it. Listen, how should I prevent those risk factors? So, what action I must do it? So, you must know the triggering factors. It is called it as risk triggers. It is called it as risk triggers. So the risk triggers are being classified as under 4 types. First type 1 is biological and genetic factors. Second is environmental and infectious factors. Third is lifestyle and behavioral. Fourth is hormonal factors. So we are going to see one by one. Are you all listening with me? Are you all with me? Yes. Next slide. Okay. Under biological triggers, age. Everyone will be happy when you cut the cake as a birthday, isn't it? On the day of birthday. But what the Indian Cancer Institute is saying that once your age is progress, every year you are at risk of developing cancer. Keep it in mind. So when your age is increasing, we are at risk of developing cancer. So most of the people above the age of 65, we are at risk of developing cancers. Next slide. Second biological factor is the hereditary, genetic. See, always our genetic informations will be carried by DNAs. So the DNAs will be transferred from one generation to another generation. It carries all your genetic materials from your parents, from your grandparents. Your parents would have been received from the parents, you would have been received from you, your children will be getting it. So we transfer all the genes to every generation. So what's happening here is, so certain cancers, like especially your breast cancer, commonly, that's what I had written here, BRCA1, BRCA, breast cancer antigen 1, breast cancer antigen 2, that is 10 to 15% of the cancers, it's absolutely the next generation will get it. Please try to understand. If one of your parent, maybe your mother is having a cancer, means breast cancer, you must undergo at the age of before 30, it is not after 30, you need to undergo a screening and you must undergo mammogram. Whether it's not that I will not get it, only my mother will get it. You are carrying the genes of your mother, so definitely we will be getting it. So this is called it as your genetic or an inherited one or a familial thing. So from first generation relatives, first degree relatives, we call it as, maybe your sibling, one of the sibling is having the problem, own your sibling or your mother is having it. So first degree relatives, when you have blood relatives, definitely it may transfer the DNA to another generation. So this is very common in breast and ovarian cancer. So it is an alerting sign for females. So all the female must undergo a mammogram at the age of, before the age of, previously till last year, government was announcing it is at the age of 30. Now the government has changed. Every day government is decreasing the years, not increasing the years. Before 30, the government is announcing it. Next slide. So the next is immune system dysfunctions. So when you are being with weakened immune system, the continuous exposure to any viral infection from the childhood, continuous infections to any bacterial infections, you are not being treated, you are not being, you are being neglected with the particular diseases, your immune system will be diminished. So such cases, these people are prone for developing certain cancers. So you all are very well aware, maybe the faculties and the PG students, your HIV infections, the common cancer, Kaposi sarcoma, that is a cancer when you are being infected with an immune diseases. So whenever you are being affected with the immune disease, immune deficiency syndrome, definitely it may lead to any one of the cancer. See, maybe the small children, second years, if you are sitting, I am not making you to get scared, but being a health professional, we all must understand, we all must aware of it. So how to maintain the health. Next. So the first thing, biological factors, what are the three components we had seen? Are you all clear with me? Yes. Let us proceed into the environmental and infectious factors. So under that, the first classifications are, classification as chemicals and toxins, or we call it as carcinogens, right? So certain chemicals, see commonly every day we expose ourselves to chemicals, every day-to-day life, by seeing, with the new paints or asbestosis or any kind of floor cleaners, whatever it is, every day-to-day life we are exposed with lot of chemicals and the toxins. So especially the common thing is asbestos, benzene, arsenic, formaldehyde and certain pesticides which farmers used it for cultivation land. And what are the common cancers which we expected people may develop is lung cancer, leukemia and bladder cancer. These are the common cancers because of your chemicals or other carcinogens. Next slide. See, this is the thing which I made it in a slide because every day-to-day life we come across all these areas and what type of occupation. The occupation, this is all comes under occupational hazards also. So lot of carcinogens are being there in areas where people are working. The mine areas, in the factories, industries, chemical areas and paint companies, so many areas people are exposed with different carcinogens. So what different types of cancers, it's all very well clearly given. If you want it, the content may be given to you. Next slide. See, if such kind of carcinogens, see we can say that I can avoid all these things. Is it possible for us to avoid all these carcinogens? Because every day-to-day life we are living with these carcinogens. So being a health professionals, what we must do it. See, when a person has been, when a company has been with paints, what are the health measures, health preventing measures, and what are the what kind of insurance they have it is, what is the vaccinations, what is the protective measures they follow it, whether they are being issued with a goggles or a barrier technique, whatever, what is the measures the company is been issuing it. And these things you must inquire when you see people working in such kind of areas. And the second thing is air pollution. 15% of people are being affected with lung cancer. The people who are affected with lung cancer, 15% has been because of your air pollution. Every day we are exposed with a different kind of air pollutions such as nitrogen dioxide, sulfur dioxide and polycyclic aromatic hydrocarbons. So these are the common air polluted substances. When it is entered into the tracheobronchial tree, definitely it may lead to lung cancer. Definitely it may lead to lung cancer. So we must understand that how can we prevent that kind of things. Being a health professional, what awareness you will give it to the public. See, when you go to the traffic, near to your college, Katpagam signal is there. So hardly nowadays it's very difficult to cross the Katpagam signal because most of the time more vehicles will be here. So it emits lot of gases. So how can we prevent this? See, always plantation is a must thing which we all must follow it. Many number of trees must be planted and all must wear a mask. That is also, it is kind of N95, N99, such kind of air filtered mask must be worn. And instead of using always motor vehicles and other vehicles, better to use a bicycle. See how the foreigners are doing it. European countries, when you go it, people will be advised to use lot of bicycles. And for a small distance, we all prefer auto. Right? Even a kilometer, half kilometer when you wanted to walk, when you wanted to go also we don't want to walk. Can I listen here? Don't sleep off. Third row. Okay? Right? So we don't want to walk. What we will be doing it? So we will be catching an auto and we will go it. So instead of it we can walk it. So these are the common measures we must do it to prevent ourselves from the air pollution. Is it clear to all of you? Are you all aware with, are you all with me? Okay. Next. Third component, next slide, radiation. So we have two types of radiation exposures. One is an ultraviolet radiation, then another one is ionized radiation. See, we are in a great risk of exposing both, right? Because we are comes under health professional, right? So the ultraviolet radiation, that is a gift from the God, we get it from the sun. Is it clear? But how come it will be damaging ourselves, our skin? This is the one which can lead into all skin cancers. But what we must aware is, from 11 o'clock to 4 o'clock, the radiations are high, UV radiations are high. These radiations can affect your skin. See, sunlight is very good in the early morning. So if you wanted to go with 11 o'clock to 4 o'clock sunlight, what you must do it is, what we must do it, maybe the young girls all must be aware of it. Sunscreen with SPF of 30 plus, right? Up to, see, you can start from 30 plus. 30 plus you can start it, SPF, right? So the sunscreen lotions must be advised it. So this is the one which you must understand it. Next is an ionizing radiations. So where you get exposure into the your X-rays and your CT scans where you go it. So there is a chance of, when the lead amount is being higher than the required amount, there is a chances of getting it. So this can increases the chance of leukemia, thyroid cancer and breast cancer. So the fourth type is your infectious disease. So 10 to 13% the infectious disease is contributing to the cancers. So there are a lot of infections. I told you before itself, the infections is a bacterial, viral and your parasites, any kind of infections that may leads into continuously when it's been affected, when you are not being treated, definitely it may goes to cancer conditions. So the common infections, next slide ma. Okay, so there is a one thing which has been left here is H. pylori infection. So the H. pylori infections are Helicobacter pylori, which has been present in your GI gut. So there is a continuous erosion of your mucous membrane that can lead into your stomach cancer. Apart from this, Epstein-Barr virus, HPV virus, human papilloma virus, that is a common thing which has been existing everywhere. Even people with 28 years been suffering with cervical cancer, and about 20 also been suffering with cervical cancer. And hepatitis B virus, when hepatitis B and C, when it is being not treated, it can lead into liver cancer, right? Next is your lymphotrophic T virus cells, which can lead into T cell leukemia, and Kaposi sarcoma, that is a well-known sarcoma that has been affected for patients with HIV infections. So when these infections are being not treated properly, people may develop different kind of cancers. Next slide. Okay. So we had completed second triggering factors. What are those second triggering factors? Louder. Good, excellent. The next is in lifestyle and behavioral factors. So the first is tobacco use. See, I have mentioned here 40% of the cancers cases in India has been because of tobacco use in a different forms. It has been leads into lung, oral and throat cancers. Especially the north zone, when you go it, there is a kind of substance, they just keep it in a mouth and it consists of nicotine, isn't it? So that may leads into cancer, and the smoking in forms of cigarettes, cigars, cigarette pipes, all those things, chewing tobacco, any form of tobacco, when you consume it, definitely there will be a chances of lung cancer. See, it is not that everybody will get it. That is based on so many other several factors. See, people may, when you go and give education, people may argue with you, isn't it? See, since so many years I am smoking it, I am not getting it. That is based on so many other factors, your familial history, your immunity level, isn't it? The way you live your life. So many other contributing factors also been playing a major role. So how can we correct it? How can we control it? So you all know that there is a tapering mechanism that we call it as smoking cessations. So for a period of 6 months, we need to reduce the level of your cigars and cigarettes must be done it, and the proper counseling must be given to the people, and proper education must be given, health education must be given to the people. Next slide. And the unhealthy diet. See, all likes this diet only, isn't it? Everybody likes, right? Isn't it? All frying, deep frying, isn't it? All roasted, all kind of food only we like it. So the processed food, red meats and saturated fats, sugary contents, your tinned foods and salty substances, all these things are called it as your unhealthy diets. So these diets will increases your body weight, because you all know that there is a substance, your salt and sugar, it has a capacity to increases your adipose tissues, that can leads into your obesity. So many pathology which has been behind it. And so to avoid obesity, avoid your sedentary lifestyle. So what the National Cancer Institute is saying, that you must have a 5 servings of your fruits and vegetables, which being an Indians, which we cannot afford it maybe, but at least we can try 2 or 3 servings of your fruits and vegetables instead of going for a junk food. People like health professionals like us, when we are not able to follow it, how the public, how the community will follow it. So we must disseminate the information, we must give education to the public. So what kind of cancers are very common if they consume junk foods? Colorectal cancer, stomach cancer, breast cancer and prostate cancer. If you would have seen all my slides, this breast cancer is there in all the slides. Have you seen it? This breast cancer is there in all the slides. So it is an alarming thing for us. Please think of it. And when we go, and many a times I go and give education to the college students, that is non-medical students. When I talk about breast self-examination, people will be very hesitated to listen. People are hesitated to listen that. So what's your role? What's your duty? Isn't it? Monthly breast self, BSA must be done. For all the college students must be educated with the knowledge of BSA. In a hostel, you must report to your teachers if there is any small lump or a nodules or anything, whether it is moving or not movable, whatever it is, you must inform it before you could change into a cancerous cells. Next. Third is lack of physical activity, 5%. That is sedentary lifestyle. So people wants to live a comfortable life, right? Everybody wants to live a comfortable life, sitting 8 hours in a chair and in front of the system and wanted to go off. Isn't it? Even in a classroom also you people are sitting like that, right? The teacher may be standing and taking classes for 1 hour and 2 hours, you all will be sitting in the classroom. Am I clear with you all? Are you all agree with me? But what the National Institute of Cancer is saying, you just listen. So institute of lack of physical activity. So that is your sedentary lifestyle. When you have it, is definitely it may lead to obesity. The adipose tissue deposition can lead into the BMI. See, always the BMI alarming. You're above 24 to 29, you must alarm. It is alarming thing, right? You're being not only exposed to cancer, you are being exposed for the cardiac diseases, isn't it? Your diabetes, India is the second leading cause in diabetics. So all these things you must think it of. Sedentary lifestyle and obesity is related with so many non-communicable diseases where the government has taken a lot of initiation to control it. So certain type of cancers such as colorectal, breast and endometrial cancer. These are the common cancers for lack of physical activity. How should I improve it? That's what I told you, that even a half kilometer if it is there also, I don't want to go by walk. I wanted to catch an auto. Isn't it? So small things which you can think of it. So what your World Health Organization is stating is, per week 150 minutes, per day 30 minutes. Per day 30 minutes brisk walk must be essential for a 5 days. So for a 5 days it comes 150 minutes. So if you have a 150 minutes per week, definitely you will be able to maintain a normal physical activity. You will be able to prevent all non-communicable diseases and you will be able to prevent certain cancers. See, especially female children, just note here also the breast cancer is there. See how important it is, right? So it is not that every time 150 minutes is being must, so I must do a jogging, I must go for a running, I must go for a gym. That is all not necessary. World Health Organization is insisting that it's supposed to be a brisk walk. What does mean by brisk walk? You must get a diaphoresis, that is sweating, right? And You need to have a brisk walk. You must swing. When your right hand is going front, your left leg must go front. When your right leg go front, when your left hand must go front, and you must swing your hands like this in a fast manner, and you must get a sweating for half an hour. So that is a common thing all must understand. 150 minutes in a week you must go for a physical activities. There is no need of any jogging or a running, the gym, nothing is needed. Only the brisk walk, the WHO is insisting it. So when you do such kind of things, so definitely we will be able to prevent lot of cancers. Next slide, Pa. X. Excessive alcohol consumptions. So this is the area we feel very pathetic nowadays. Everywhere from the school also we could see that children are drinking. It's like a water it becomes. It's like a plain water it becomes, right? So in an European countries, because of the weather, the government itself is allowed for a 1 wine of beer. Wine it is. It is a purely a non-alcoholic wine, that is 1 ounce. 1 ounce is equal to how many ml? Second years? No sound? Faculty, all your teachers are here. After going, they'll ask you. 1 ounce. Second year BScs? No second year students? Third years? Any one of the student? Faculties noticed. 1. Chocolate excellent, only your faculties are giving answer. Huh? So 1 ounce is permitted per day because the weather is like that. But in an Indian government, in Tamilnadu, what will happen in Tamilnadu? Just think of all the task mark in front of the task mark, what's happening it? That is called it as some quarter, half, I don't know what and all, blah, blah, it is there. Right? People will drink so much and they will be flat. Right? So the common cancer which has been affected is your cancer in the mouth, throat, esophagus, liver, breast and colorectal cancers. So these are the common cancers, and people, the mucous membrane will be continuously eroded, and that can lead into H. pylori infections. Again it leads into a stomach cancer also. So these are the lifestyle modification. You must understand it. How should I modify my life? Next. Fourth component. Fourth risk triggers. Next slide, ma. Hormonal factors. Hormone replacement therapy. People who are there with the long-term hormonal replacement therapy like estrogen and progesterone associated tablets or pills or injections when they are there, and people with postmenopausal women are at risk of developing cancers, especially the endometrial cancers and breast cancers. These are the common cancers with hormonal replacement therapy. Next. And certain reproductive factors, this is a well-known factor, your early menarche, late menopause, nullipera women, these are the common conditions where women are at risk of developing certain cancers like breast, ovarian and endometrial cancers, right? And the hormonal contraceptives, when a woman has been taking lot of contraceptives, see that is it necessity. Whatever you undergo, the treatment is necessary, is the tablet is necessary, clear? All these things must be addressed, and your hormonal intrauterine device that can lead into breast cancer. See, even in a single slide, I didn't leave the breast cancer, right? Next. So this is about my previous slide. So these are the risk triggering factors. Any student from the group, can you review the factors, triggering factors? The girl, you're the one. Get up. Get up. You only gonna. From the beginning, what are the 4 major components of the risk factors? Risk triggers. Okay. Faculties, please note, after going, let them answer to you all. Okay. Next. Okay, these are the triggering factors, right? So when you have these triggering factors, so I must know it. What are the warning signs? I have it with me. Whether my mother is having a breast cancer or ovarian cancer, I must undergo for a screening, right? Is it clear? When I am aged, I must think of cancer, isn't it? I am consuming smoking, I must think of lung cancer. So like that, you must think over it. So, okay, you know all the triggering factors. So these triggering factors will lead to what are the common cancers. See, my topic is still the cancer types, okay? So all these triggering factors will lead to certain common cancers. What are these common cancers are there in our body? Kana, next slide. So first classification is carcinoma. What is that? Carcinomas. So carcinomas begins in the skin or in tissues that line internal organs such as lung, colon and pancreas, etc. So within the organ, when there is a cancerous tissues are being arising, that is called it as your carcinomas. Within the organs, when there is a cancerous cells is being arising as a primary tumor, that is called it as your carcinomas. The carcinomas are having 4 major subdivisions, that is adenocarcinoma, basal cell carcinomas, squamous cell carcinomas and transitional cell carcinoma. So here the adenocarcinoma. What is meant by adenocarcinomas are, inside the organ there will be a glands, the different kind of glands, endocrine glands, isn't it? Exocrine glands. So different kind of glands. The tumor or a cancerous cells is being arising from the gland, particular gland, that is called it as your adenocarcinoma. Right? From the gland, when the cancerous cell is being arising, that is called it as your adenocarcinoma. Basal cell carcinoma. So basal cell carcinoma is a very common skin cancer. Very common superficial skin cancers. So this is, we have learned it about your UV radiations, your ionized radiations when you are exposed to continuously, and such kind of times, or when you are suffering with a vitamin D deficiency continuously. So such kind of things you may develop your basal cell carcinoma. And squamous cell carcinoma, also a skin cancer, but which is being arising from the squamous cells of the skin. Next is your transitional cell carcinoma. This is particularly from the renal system, especially the renal system of ureter, your nephrons. The entire renal system has been affected with the transitional carcinomas. Next. Second classification is sarcoma. What is that? Yes. Sarcomas are originate in the bone, cartilage and other connective tissues. So it is originate from the bones and the soft tissues and the other connective tissues. It has a major primary 2 types. One is bone sarcomas and soft tissue sarcomas. Exactly, the cancerous cells has been arising from the bone, that is called it as your bone sarcomas. That is, example is osteosarcoma. Soft tissue sarcomas are in the soft tissues, the connecting soft tissues of the bone where your origination of the cancer is taking place, that is called it as your soft tissues sarcomas. Third is leukemia. You all aware that that is very common among children, right? The cancer begins in the blood forming tissue and causes the production of large number of blood cells and enter the blood stream. If there is any problem in the blood forming tissues, it can be in any form of tissues of the blood components, that is called it as your leukemia. So you all may be learning so many subdivisions. I am just talking about the general divisions alone. So it affects the age group 0 to 5, 14 to 18, even it goes your over the age of 60 and all, we'll call it as complete chronic myeloid leukemia, isn't it? So ALL is very common among children and CML is common among old age people. So that, like that it has been, it is started from the children to elderly people. And subdivisions are lymphoblastic leukemia and T-cell leukemia. These are the other subdivisions. Next slide. Next is lymphoma. Lymphoma, it starts in the white blood cell. It is affecting the white blood cells and affects the lymph nodes in the specific sites, stomach, brain and intestine. And it has two types, B lymphocyte cancers and T lymphocytes deficiency cancers. Next. Next is myeloma. Type of blood cancer that begins in the plasma cells. So plasma cells produces various antibodies. So where and all it affects is, it damages the bone, kidney and entire red blood cells counts will be affected. That is called it as your myeloma. This is the fifth type. Next is your central nervous system type. That is the cancer which is starting in the central nervous system, your brain, spinal cord and your peripheral nervous system, all those things. These cancers starts from the brain tissue, spinal cord, which together forms the central nervous system. So like all kind of gliomas, glial cells tumors and the brain cells tumors are being means forming from this central nervous system. So these are the major classifications of your cancer types. So we have 6 major classifications: carcinoma, sarcoma, excellent, excellent. Okay. So it has, every type has got lot of subdivisions. Due to time constraint, I am unable to continue it. Maybe the one slide which I can show it. Next slide. Okay, maybe it may not be visible at the last. So I can only read it. See, basically the tumors, malignant tumors are being starting from the epithelial tissues. And epithelial tissues and non-epithelial, it is starting from the epithelial or a non-epithelial or mixed tumors. From there, carcinomas, and that is non-glandular, and adenocarcinomas are glandular. So whatever we have learned, it's squamous, basal cell and transition carcinomas which has been there. And non-epithelial tumors, isn't it? Mesenchymal tumors, hematopoietic malignancy, neuroectodermal tumors. So under mesenchymal sarcoma, in that sarcoma we have learned it, bone sarcoma and soft tissue sarcoma. In the hematopoietic, leukemia, lymphoma, myeloma we have seen it, and neuroectodermal, the gliomas and medulloblastoma. The major classification we have dealt it. I hope you are understanding. This is a carcinoma, sarcoma, hematopoietic, under that leukemia, lymphoma, myeloma and neuroecternal tumors, under that glioma and medulloblastoma. So these are the common cancers when we are unable to identify the risk factors and we are unable to prevent it, we are not able to notice it when we are end up, these are the cancers we may develop it. Any doubts? Any clarification, any doubts? Okay. So today's class we have seen the definition, terminology, right? Different type of triggering factors and different type of cancers. Once again I thank the organizers for giving me an opportunity.
Thank you for your knowledgeable section. Has really enlightened us. Thank you, ma'am. Now I request our respected Vice Principal, Professor Gandhimati ma'am, to kindly present a memento to Dr. C. Fula Esther Tangam ma'am as a token of our gratitude and appreciation. Thank you, ma'ams. Participants scheduled for paper presentation are kindly requested to proceed to the ground floor hybrid classroom. Participants scheduled for paper presentation are kindly requested to proceed to the ground floor hybrid hub classrooms.
Session 2. Now it's my pleasure to introduce our next speaker, ma'am. Currently serving as the principal of Bright College of Nursing, Bangalore, Karnataka, and she is highly experienced academician in the field of nursing. She holds a master degree in medical surgical nursing and has recently completed her Ph.D. in nursing from Himalayan University in the year 2025. Ma'am brings with her rich teaching and administrative experience. She has served in various reputed institutions including Sree Venkateshwara Institution of Nursing Science, AVK College of Nursing, SJB College of Nursing, Bangalore. She has been associated with Bright College of Nursing since 2012 and has been serving as principal since 2019. She also holds the position of director in the nursing department of AVK Group of Institution. She has actively participated in numerous state, national and international conference, seminars and workshops on the topics such as nursing research, artificial intelligence in nursing and advanced research methodologies. She has also organized various academic and community outreach programs including cancer awareness, disaster preparedness programs. Ma'am's dedication and excellence have been recognized through several prestigious awards. She is a recipient of the Best Teacher Award from reputed institution in Bangalore. She has also been honored with the Guru Ratna Shiromani Award in the year 2024 and the Tonda Mamani Award in the year 2025 for her outstanding contribution for education and social service. With her vast experience and commitment to advancing nursing education and practice, we are privileged to have her with us today, ma'am. Now I invite Dr. Vijay ma'am to kindly take the stage and deliver her session on the topic Unrevealing Clinical Clues and Tools that Reveal the Hidden Facts. May I now invite Professor Sarala ma'am to welcome our speaker Dr. Vijay ma'am with a floral bouquet.
Good morning, everyone. Thank you so much for the management and principal and especially Sarala madam and making me to be here. Thank you Renu Preeta, student. I thought she is faculty. The way she is addressing us, no, really it is amazing. Thank you, my dear. Yes, 1 hour. Esther madam has covered everything up to types, energetic class with energetic madam. Yes, now you're all become tired or somewhat okay? Tired, okay. Then let us do one game. Okay, when we are so tired, no, we should not listen the class, correct? Yes? I will tell you 3 things, you just follow. 3 flowers. One is rose, second jasmine and lotus. Okay. If I say the jasmine, you do like this. Okay. If I say rose, you just clap. If I say the lotus, you just say like this. Okay? Rose. No. Let me once again. Rose like this symbol, and jasmine, lotus. Rose, jasmine, lotus. Can we play? Even sometimes if I change also you have to change. Let us know how many people can win. Yes? Yeah. Rose, jasmine, lotus. Rose, jasmine, lotus. Jasmine, lotus, rose. Rose, lotus, jasmine. Jasmine, lotus, lotus, jasmine, lotus, lotus, lotus. How many people won? Stand up. Kindly stand up. How many people won in this game? Just you stand up, nothing else will be there. Wow. 2, there 3, 4. Yeah, you can just raise your hand. If you feel very difficult to stand up, raise your hand. These many students, how did you win? You are very aware about what I said. Correct? When you are very aware about it, you can win. Coming to the point, today we have seen the cancer. Correct? If you are very aware about signals of the cancer, how you people win, some of them know? Surely 100% you can win from the cancer disease. Correct? As the first Esther madam said, 40% of the cancer it is a preventable. But even 40%, even 10, even 1, unless if you are not aware, you cannot. Okay, this is what I mean to say with this game. One more thing. So today my topic is signals of the cancer or warning sign of the cancer. Okay, yes. One more thing. Do you like friends or enemies? If you want to win in your life, you want only the friends or you need even the enemies? Wow. But if it's open enemies, you can find out. You should like your friends, but you should aware about your enemies. Aware about your signals of your enemies. Okay, open enemies, okay. Open enemies means what? You know they are the enemy for us. Correct? But nowadays, silent enemies are more than the open enemies. Correct? Correct, no? But silent enemies are very dangerous. Yes, so many people are having the silent enemies. Correct? So we should be aware about silent enemies. So which is a silent enemy? Which I am going to deal the topic, that is a cancer, silent enemy. Silent enemy. That is a cancer. Signals of the silent enemy and tool spotting the silent threat. That is nothing but how you are going to be detect. Now I said no, you have to find out your silent enemies. Correct. So you have to find out how the cancerous comes. This is what today we are going to deal about it. What is that? Symptoms and diagnostic evaluation of the cancer. Next slide. Yes. Last, you are having, yes, you are all being with me. Last row. Can you hear my voice? Now you become okay? Yes. Coming to the point, it is a cancer warning signs. What are all the warning signs? At last slide, I will tell you how you can find out your silent enemies. Okay. If you want to find out your silent enemies nearby you have to listen this topic. If you listen, when I'm asking the question, if you give the answer only, I will tell you how to find out the silent of your enemies. Okay? Yes. So what are the cancer warning signs? Yeah. Change in bowel or bladder habits. Change in bowel or bladder habits, and a sore that does not heal. The next, unusual bleeding or discharge from body, unexplained weight loss and loss of appetite, difficulty in swallowing, new mass or change in the breast. Esther madam said, no, in all these slides, in all the, whoever going to take the resource person, everyone will show the breast. Okay, so breast cancer, that is a very much important. So all these things we'll see one by one. Okay, these all things we'll see the one by one. Next one, next slide. Yeah. The first one, change in bowel or bladder habit. How you can find out the cancer warning signs, because it is one of the leading cause of the death in our country. Okay, why we are saying this silent enemies, this cancer means it will be gradually developed without showing any of the symptoms in early period. But we can expect, we can assess, we can see any kind of these kind of symptoms, we can go for the screening test. Okay, so what is that change in the bowel or bladder habit? The first one is pencil thin or ribbon like stools. It is a narrowing stools. They will say it is a narrowing stools. When the tumor in the colon, that tumor will be narrow the pathway of the pathway of the passing the stool. Okay, so physically the stool itself, it is getting the squeezing itself. That is the reason you can see the pencil thin or ribbon like stools. Okay, the next one, symptoms is tenesmus. What is the tenesmus? What is tenesmus? Sometimes the bladder is empty, bowel also it is empty, but still the person feel to pass the urine and feel to pass the motion. Okay, so that kind of feel, that is a tenesmus. Next, worsening constipation. The person will feel most of the time the constipation. The next, due to presence of blood, stools look black, tarry or maroon. So the stool look like black colors. It's most of the time the blood will not become the bright color. When there is a blood from the esophagus or any colon or stomach region, upper GI tract, okay, upper GI tract system, if anything, any bleeding comes, so the blood look like very bright. And what is terry? So terry, it is a nothing but it is like what is that? The feces will be very thicky and foul smell, and also it is like maroon color. Okay, that is called a tarry or maroon. The feces or stool, it is looking very what is that? Thicky and the bad smell. Okay, that is, these are all the bowel or bladder persistent change in the bowel habits. Okay, these are all the symptoms which is related to the abnormal symptoms which is related to the bladder or bowel. Clear? Yes? So what it means, tenesmus? Anyone can say? Tenesmus means what? Feeling of? Anyone. The person will feel what? Continuously feel to pass the urine and motion, still it is empty. Clear? Yes? Yeah. The next slide. Next, persistent change in bladder habits. Again, what is a bladder habit? Frequency and urgency. Again, same thing. The bladder, even it is empty, the person will feel to pass the urine. Frequency and urgency, and changes in the flow. Changes in flow means when the passing urine, the person feel like that. What? It is sometimes they feel like to pass more, or sometimes it is not passing. Okay, that changes in the flow. And painless hematuria. What is that hematuria? Blood in the urine. Yes. And next, urgency without infection. Same as I told already, the person will feel the urgency, feeling of the what? Feel of the pass the urine. Okay, these are all the symptoms. That is frequency and urgency, changes in flow, painless hematuria, urgency without infection. Clear about it? Yes? Yeah. The next slide. Yeah, next, sore that does not heal. Sore that does not heal. Why it is not getting healed when the patient is having cancerous tissue? So what is a normal process? Actually, you can see that the center healing wound and wound healing pathway and healing epithelium, the site chronic wound and carcinoma, wound healing defect, it hijack the wound healing pathway. Can you see that pic? Okay, I will explain you. So when the wound is getting, when the skin is getting wound, or when any place is getting wound, what is a normal process to get healed? I think you would have studied about the four things. That is, first one, hemostasis, and the second one what? Inflammation, and third one is proliferation, and fourth one is remodeling. So homeostasis, hemostasis is nothing but blood clot. Once the bleeding comes out when the getting wound, so within a few minutes the blood clot will happen. Okay, that is a homeostasis. The second one is when they are getting the inflammation, the WBC will clean or clear the wound. Okay, that is called inflammation process. The second one is proliferation. It will make new tissue. Okay, it is clear the depressed tissue and make the new tissue, that is a proliferation. And the last one is remodeling, means it will make the new things, new skin, or it will complete, the wound will become the complete heal. That is the 4 process of the wound healing. Okay, that is the first one. So how this wound gets healing? With the help of the wound healing pathway, that is growth factors, cytokinase and RNAs and immune cells and stem cells. So how it is making the wound get healed? Growth factors. So what growth factors is doing? It is repair this. This growth factors helps to repair the damaged skin. And cytokinase, it is recruit the immune cells. Okay, it is recruit the immune cells to heal the damaged tissues. And RNAs, what it will do? It will help the what? To form the new skin. And the immune cells and stem cells, same thing. These cells also, it will be helping the avoid the depressed cells or decrease the depressed cells and form the new skin. So all these factors, the wound is getting healing and become the normal wound. That is the third one, is healthy epithelium. This is a normal pattern of the wound healing. Okay, when the person is getting infection, they're not getting cured the prolonged period because of there is no blood circulation, that wound will become the chronic period. Okay, chronic period. But when it is getting carcinoma, if the cancerous tissue or cancerous cell, if it is present, what will happen? It will hijack all this normal process. hijack all the normal process. Okay, so there the person will feel that it is a continuous or prolonged period of sore, it cannot be healed. Okay, yeah, next slide. See, according to the statistics, if you see, the study analyzed 440 adult patient, that is 48% female, 52% male people are affecting during the 2016, that is the current statistics. It shows many of the people are affecting the pressure ulcer cancer. Okay. So, key finding and methodology, incidence rate 17.3% of the total population development pressure ulcer. So, these ulcer or these cancer can be detected by the Braden scale. Braden scale will be helpful for to find out the risk of the cancers, how much percentage of the risk the people are under the cancer. And numerical cancer, that is also will be helping, and pain assessment in advanced dementia scale, because most of the cancer people will affect psychologically. Okay, when the patients are psychologically affecting and with those disease, with those problem when they are coming to the clinic, we have to assess their things with the help of the pain assessment. Okay, the next slide. Yeah, this I have mentioned here, the Braden scale. You can check it out through the sensory perception and moisture, activity, mobility, nutrition, friction and shear. So we have given the marks here, 1, 2, 3, 4. Example, if you take sensory perception, for no impairment you can give the 4. If the slightly limited people, you can give the 3, and very limited you can give the 2, and completely limited you can give the 1. Same like that I have given the things till the friction and shear. In the last line you can see the scoring, if you get 15 to 16 it is a mild risk, but if you getting 12 to 14 it is a moderate risk, whereas less than 11 it is a severe risk. You can find out the patient condition, how much risk of the patient will be in cancer. You can check it out through this scale. Okay, the next. And next, it is a pain scale or numerical scale also you can say. So when the patient is coming with the pain, you have to assess their pain, isn't it? Okay, so how you can assess their pain? If you ask any of the patient, do you have the pain? Yes, I have the pain, like that they will say, but they may not have. How can you find out really they are having the pain or not? With the facial expression, correct? Yes. So I have shown this here, the facial expression. The mild, intense and severe, you can give the mark accordingly. Okay, the next slide. The pain assessment in advanced dementia scale, same like that. Criteria is a breathing, negative vocalization and facial expression, body language, consolability. Okay, according to this you can give the score 0, 1, 2. So I will give the notes later, you can see that. Okay, the next. The next symptom is bleeding and discharge. Bleeding and discharge. In cancer, unusual bleeding can sometimes be an early warning sign. It does not always mean someone has cancer, but it's taken seriously because certain cancers can damage tissue, blood vessels, affect the clotting. See, when the patient is having the cancer, most of the time, okay, it will damage the blood vessels. As I said, most of them, they are getting GI tract problem, upper GI tract problem. If they get, most of them, they are getting the blood vessels damage and tissue damage. Even the blood clotting also will not be happen within a few minutes. Okay, yes. The next. The next, difficulty in swallowing. What is difficulty in swallowing? What it is a medical terminology? I think I have been missed here. Yes? Dysphagia. Yes. And difficulty in swallowing you can call dysphagia. When you feel the pain during difficulty in swallowing, what it is called? Odinophagia. Okay. Yes. The next, food sticking in the throat or chest, coughing or choking while eating, drooling or inability to swallow the saliva, regurgitation of the food. Okay, these are all the symptoms when the patient feel what? Having the difficulty in swallowing. Okay, the next slide. Coming to the next, unexplained weight loss and loss of appetite in the cancer. Whoever it has affected the cancer, like within 6 to 12 months, you can see more than 5% to the 10% of the weight they will reduce. Okay, 5 to 10% of the weight they will reduce. The reason is the one increased metabolism. When the metabolism is getting increased, it will easily burn, or it is very fastly burn all the calories. Okay, that is the reason they will become weight loss. And the second one is loss of appetite. When they are going under the chemotherapy, okay, when they are going under the chemotherapy, the patient will not feel the taste buds properly. Okay, so that is a reason they feel loss of appetite. Even the patient will, most of the patient will get fear and anxiety. When they are having the fear and anxiety, also they will not feel to get the food. The next treatment side effect, as I said now, when they are getting the treatment, most of the patient will go for the frustration, depression. Okay, so when they are going the depression and frustration, again they don't feel to take the food. So again they will go for the weight loss. And nutrient absorption issues. So which kind of cancer they will go for absorption problems, that is a pancreatic cancer and stomach cancer. Especially when the patient is having the pancreatic and stomach cancer, they will have the problem in the absorption. Okay, the next last one is muscle loss. Muscle loss, when the patient is affected in the cancer, more than the fat loss, they will go for the muscle loss. That is the reason the very fast they will reduce their weight. Okay, so these are all the reason why they are getting the weight loss. What all the reason? Can anyone say? Yes, increased metabolism, loss of appetite, treatment side effects, nutrient absorption issues, muscle loss. Okay, these are all the reason for getting loss of weight. The next slide. Yeah, so I'll show one video. Okay, you can see that and how the breast cancer is forming, what all may be the symptoms. If you find the breast cancer, what may be the diagnostic evaluation. Just you can it will be only the 2 minutes video, you can see that. Sound it's not comes. See, it is getting metastasis to the other organs, especially from the breast. It will metastasis to the lungs and liver, other bone areas. You have to do the physical assessment when you feel any lumps. What are the main symptoms when you get the breast cancer? Go back with the slides. Go back with the videos.
Cancer. But for about 1 in 6 women with breast, the broad spectrum of symptoms doesn't include a lot. In this video, I'll tell you about the early signs of breast cancer and what to do next. Breast cancer occurs when breast cells mutate and grow out of control. If breast cancer spreads, it typically goes to nearby lymph nodes under the arm first, or around the collarbone. If it spreads beyond these small glands to other parts of your body, it's called metastatic breast cancer. Metastatic cancer is incurable, so early diagnosis is very important. breast changes are due to hormonal changes and are nothing to worry about. However, if you experience any of the following 5 breast cancer symptoms, see your doctor, even if they seem mild. 1. A lump in the breast or armpit. 2. Discharge from the nipple. 3. Dimpling on the breast. 4. Nipple changes, including the nipple turning inward, pulling to one side, or changing direction. Or 5. Irritation of the skin. Your risk for breast cancer increases with age. About 77% of women are over the age of 50 when they are diagnosed with breast cancer. Less than 1% are diagnosed in their 20s. If you have a close relative, a mother, sister, or daughter, who has had breast cancer, your own risk of developing the disease doubles. If 2 of these relatives have the disease, your risk increases 5 times. In many cases where breast cancer seems to run in families, a mutation in specific genes called BRCA1 and BRCA2 may contribute to the cancer. If you started menstruating before age 12 or went through menopause after age 50, your risk for breast cancer is also slightly increased. That's because your breast tissue is exposed to estrogen for longer periods of time. And finally, there is a clear link between alcohol and breast cancer. Those who have 2 to 5 alcoholic drinks daily have 1.5 times the risk for developing breast cancer as women who do not drink. If you think you might have breast cancer, what should you do? The most important screening test to detect breast cancer early is the mammogram. A mammogram is an X-ray of the breast. It can detect breast cancer long before a tumor might be felt. It is recommended that women aged 40 and older receive annual mammograms. Studies show that women who participate in mammography screening reduce their risk of dying from breast cancer by 41% and experience a 25% reduction in the rate of metastatic breast cancers. Schedule an appointment with your doctor today to discuss your screening options. Thank you for watching this video. Please watch my next video if you want to know how people die from cancer or how...
Yes. So every 1 in 6 women, they're getting the breast cancer. You should be very aware about it, being the girls. You should not hesitate to do the physical assessment. When you take the bath every day, you can do the physical assessment, because now you have seen here how it is getting and what all may be the symptoms. Once if you get, you have to go for at least 6 months once mammography. Okay, that is a breast cancer symptoms. The next slide, nagging. Go back. Yeah. The next symptom is nagging cough or hoarseness. When the person is having continuous cough, some voice changes more than 3 weeks, you have to go for the test. It may be because of even without any infection or without any carcinoma also, sometimes the people are having the cough more than 3 weeks. But you should not think that when it is crossing the more than 3 weeks, you should not go for any checkup. Once if you go for the checkup only, you will come to know that whether it is a normal or any cancerous related symptoms. Okay, the next slide. Next. Yeah. So till now we have seen what all the warning sign of the cancer. Okay, what all the warning sign? Is what all the warning sign? Changing bowel and bladder function, then sore doesn't heal, unusual bleeding, then what? Difficulty in swallowing, weight loss, loss of appetite, Yes, mass in breast. Yes. So these are all the common warning sign of the cancer. Okay, warning sign of the cancer. Mainly they will categorize the general symptoms or localized symptoms. So these symptoms are the warning sign for the cancer. You should be very aware about it. It's not mean whenever you are getting initially you're under the cancerous tissue. It's not mean like that. But you have to be aware for checking. It's you are not getting the cancer. Okay. Yes. Next we'll go into the diagnostic evaluation. So what all the screening tests can identify the cancer cell? The number one is liquid biopsy. So this liquid biopsy is a technique. What is that? Currently they are going with the liquid biopsy. Biopsy that is especially now 2016 they found this liquid biopsy is very effective to detect the early cancer tissue. In previously they will go with the what tissue detection. That means like by a skin biopsy they will do it. It will take time, but comparatively if you go for the liquid biopsy, very easily or early period you can find out the cancer tissue. Next slide. Yes, liquid biopsy. So what all the liquids you can, biological liquids, what all the things you can take? One is blood you can take, and you can take urine sample, and what is that, pleural fluid you can take, and ascites, any other thing, CSF fluid you can take. So CSF fluid and urine, blood, the first picture we have mentioned. So with these biological fluid you can check out whether is there any tumor RNA or tumor DNA or circulating tumor cells. These all things you can find out. If it is there, the third pic they have mentioned. So it is very, when you are coming to know that when the patient is having the tumor or cancerous tissue, this liquid biopsy, it will be very easy to find out the mutation detection. How fast it is a gene is getting, a DNA is getting into the multiply with the cancerous tissue, that you can find out through the mutation detection. And tumor recurrence monitoring. You can find out where the tumor is exactly present. Okay, where the tumor is exactly present, that also you can find out. An analysis of the therapeutic efficacy. When you find out where the tumor exactly present, you can go with what kind of treatment we can give exactly for that. And prognosis prediction. So when you started the treatment, you can find out how much percentage of the people is recovered from the disease and where still they remain the cancer tissue, that you can find out through the liquid biopsy. How they will collect? First, the first stage they will collect the sample and they will go for the pre-analysis, and next they will go for the lab experiment, and by giving the warning signal of that result, they will come to the conclusion whether they are having the cancer tissue or not. And down there mentioned liquid biopsy in early screening of the cancer. So it will be very helpful comparatively the previous. Very easily you can find out within a day or within an hour you can find out whether the cancer is there or not. The second one, biological fluids and analytes used for the liquid biopsy. As I said already, what all the biological fluid here, that blood, urine and CSF fluid and pleural and some if anywhere it is a pus collection is there, means that is also you can take it out for checking the cancer tissue. And emerging detection technologies and method of analysis. What is emerging detection? New technology. Okay, nowadays they are checking the AI, through with the help of the AI you can check out very easily with this liquid biopsy. And limitation and challenges liquid biopsy are currently facing. Yeah, still though we are going with a very advanced stage, this liquid biopsy, some limitations are there, some challenges are there, because what will happen when you are going with a liquid biopsy? It will not cover the entire tumor. It will not cover the entire tumor to detect whether the cancer is there or not. The one is, you see, all the protocols you have to follow the properly. If you are missing any protocols for the same patient, they will give the different kind of result. Same patient, different kind of result. These are some limitations are there. challenges also is there. And the next new perspectives for the development of liquid biopsy. What is the new perspectives? Same thing as I said, no, like AA you can use. With the help of the AA you can avoid this kind of some challenges and limitations. Yeah, this is about the liquid biopsy. The next, yeah, what is a new technology to find out the cancer? AA, transforming the cancer diagnosis. AA is a very vast topic. I cannot go deep into that. But AA can, with the help of AA, when you are going, all the limitation and challenges you can overcome. As I said, no, you can completely cover the tumor. Easily you can detect. It is what is that? If sometimes humor error it will be happen, technician error it will be happen. That can be changed by the AA. So how is the AA used in the cancer diagnosis? Medical imaging analysis it can give, and genomic data analysis you can get very fastly, and pathology slide interpretation and clinical decision support, all with these, no. So AA can give the very clear information and clear idea what you have to go for the further treatment. The next technology or next deduction is single cell technology. What is a single cell technology? So with this single cell technology you can find out the individual tissue compared in the bulk tissue. When you are going for the bulk tissue, sometimes the error will happen, sometimes the result will be may or may not be accuracy. When you are going for the single cell, it will give the very accurate result. So for that, single cell technology allows for the analysis of individual cell rather than the bulk tissue. It helps bridge the gap between initial diagnosis and personalized treatment. And early cancer detection, as I said, no, you can check and find out in an early period, the beginning stage, identify the minute number of the cancer cells, and identify cancer stem cells and circulating the cancer tumor cells, and it can be identify therapeutic target. I said, no, like when you are coming to the what is that? When you are coming to the what kind of cancer, if you find out through the single cell technology, you can go for the therapeutic treatment very immediately, and you can tracking the metastasis. Sometimes, no, the metastasis in the cancer, where it is getting affected, which organ is getting affected, which all the organ is going to get affected, you may not get into that. So, but the single cell technology will give the clear picture, tracking metastasis, where it has happened, where it is happening, where it will be happen, that you can give the clear picture. And monitoring the minimal residual diseases. Monitoring minimal residual disease means once you are giving the treatment, the patient is getting cured. After the patient got a treatment, sometimes like 2 to 5% still remain the cancer tissue somewhere. That you can find out through the single cell technology. And you can give the, you can check out the evaluate immune cells, how much percentage of the immune cell is there, so that you can tell to the patient how much percentage of they can, what is that, they will get the immune capacity, whether they will get again the secondary, what is what to say, like say once the cancer is getting cured, there is a chances to get again. So how much percentage there is a possibility to get again, that you can check it out through single cell technology. Yes. Next. The next technology is cytology. So that is fine needle aspiration cytology, a quick, safe and cost-effective outpatient procedure that uses a thin hollowed needle to sample cell from lumps or fluid for microscopic analysis, often distinguishing between benign and cancerous tissue, commonly used on the neck, breast, thyroid and lymph node. It provides a rapid, highly accurate result. So when you want very accurate result, more than the 80%, you can go with the fine needle aspiration. So where you can get fine needle. Yes sir, good morning sir. Can sit down. Good morning, sir. Yes, coming back to the point. So through the fine needle aspiration, you can find out the more than 90% of the result. If you want very accurately, you can use this diagnostic evaluation. The next. Yes. The next one, light microscopy. The microscopic structure of the cancer cell. It can find out what is the structure of the cancer tissues or functions of the cancer cell, that you can find out through the microscopic structure of cancer cell. The next. Yes, the next, immunohistochemistry. So immunohistochemistry uses antibodies to detect antigen in a simple sample. It is one lab technique a pathologist may use to check for the sign of disease following a biopsy. Immunohistochemistry is commonly used to diagnose cancer, predict a treatment response, and determine likely outcomes. Most testing labs use the immunohistochemistry test to see if there are hormone receptors on breast cancer cells. If the hormone receptors are present, this means that the cancer cells growth fueled by the hormones estrogen or progesterone. So this you can find out which kind of antigen. Okay, through the antibodies, most of the cancers patient, if when you are going check and they're having the more differentiate in the estrogen and progesterone level. Okay, that you can check it out through the immunohistochemistry. Next slide. Yeah. So still now we have seen what all the symptoms, warning signs, and what all the diagnostic evaluation to find out the cancer tissue. Finally, what is a research gap? So what is a research gap? That means where we are having still facing some challenges to find out the cancer tissue in an early period, because when the patient is going for the fourth stage or third stage, it is very difficult to come back. But when the Esther madam said in the morning, 40% of the cases can be preventable. So how it can be preventable? In the early period, if you find out, it can be prevent, isn't it? So when you can go for the stage 1, if you go, it will be very easy to find out the, to prevent the cancer. So what here the research gap? So like especially the pancreatic and ovarian and liver cancer, there is not the proper diagnostic evaluation to find out in an early stage. Whereas you are having like breast cancer, I said, I shown that the mammography, isn't it? That is easily can find out in the beginning period. But still some of the cancers like the pancreas and ovarian liver cancer, we need to be, the researcher should give the concentrate on these kind of deduction or what kind of diagnostic evaluation can find out to in early period, that we can give the concentrate. Okay, that is a research gap. And the next. And future research direction is, as I said, in early period, like liquid biopsy. I said in liquid biopsy, though it is a very current, very good diagnostic evaluation to find out in early period, some challenges are there, some limitations are there. It cannot control, it cannot cover the entire tumor to give the proper result through the liquid biopsy. How it can be avoided? So with the help of the A, you can, it is as I told already, it is a very vast topic. But with the help of A, you can find out all the very accurate result. You can avoid most of the challenges and limitation, so that you can give the concentrate in the future times. Is the next? Yes. At last, we're all nursing. Nurses are very important in the clinical side. I used to say, when we are having a lot of works, we are at a time we have to do, but we don't have the time. So we need some trustworthy person to share our works to complete within the time. The same like that, God also want to give much work to the people, especially for the patient. The God is searching to whom my trustworthy person to take care of the patient. At last he found the nurses. So the nurses are best next to the God, because we are all 24 hours we are being with the patient. So when we are being with the patient 24 hours, we should have the knowledge. Independently we have to work. Sometimes when the patient go for the very critical condition, within a fraction of second we have to take a decision. Yes, we have to follow all the doctor's advice and orders. When we are in the very critical condition, within a fraction of second, when we are exposed to that critical condition, we have to take some decision, isn't it? When you are going for the taking the decision very immediately for the patient secure, you should have the knowledge first. You have to update your knowledge every day. So the nurse's role are very important to take care of the patient here. Autonomy, it is the independent decision makers, independent capacity. You should get your knowledge up to date. And central influence, the same thing. You have to get knowledge in all the views, in all the ways. And knowledge empowerment, you have to update your knowledge. Psychological impact, most of the patient, I said when I explained, I told most of the patient will go for the psychologically impact. So you have to give the psychological support to the patient. And health seeking behavior, the patient will go for behavioral changes. You have to explain about the topic. You have to explain about the disease condition. What is the patient is actually having? What may be the problem? You have to explain to the patient. And patient navigation. Patient navigation in the sense the nurses should be the navigator. What is a navigator? What is a navigation? You have to lead the situation. You have to lead the current problem. So that means you have to say to the patient what is their actual problem, how they can manage, how they can overcome that. You have to be informed to the patient. And removing all barriers. What all the problem the patients are facing to overcome. The morning I have read in one book, nowadays like more than the medicine, the mindset can give the treatment for the patient. So mindset, the patient should have the confidence. They will come back to the normal stage. That is called rehabilitation, correct? So that you can give the confidence to the patient. Removing all the barriers. Wherever the patient is feeling the very difficult to overcome the problems, that you have to point out and advise to the patient how they can come out. And early detection. Yes, I said no, like example, the breast cancer, you people, you can every day you can assess your breast during the taking both physical assessment you can do. It is early, like you can start from the age of the 12. Okay, so that is a early detection and increased uptake. That's what, update knowledge. So these are all the nurses' role, early detection of the cancer. Have you all understand? So today we have seen what is a warning sign and diagnostic evaluation, and at last what is the nurse's role. Thank you all.
Thank you, ma'am. Your contribution made this section truly meaningful. Thank you, ma'am. Now I request our respected principal, ma'am, Renuha ma'am, to kindly present a memento to Dr. Biji ma'am as a token of her gratitude and appreciation. Thank you, ma'ams. The inauguration section is about to begin. We kindly make yourself comfortable and maintain silence, so everyone can fully benefit from this section. After this section, there will be a tea break for your refresh. The inauguration section is to begin. We kindly make yourself comfortable and maintain silence, so everyone can fully benefit from this section. After this section, there will be a tea break for you to refresh.
I kindly request everyone to maintain silence. I kindly request everyone to maintain silence.
Good morning, respected dignitaries, esteemed doctors and distinguished guests. It's my great pleasure to welcome you all for the inauguration of this conference on cancer care, the next frontier. Today marks a step forward in advancing innovation, collaboration and compassionate care in the fight against cancer. With great honor, we now begin the inaugural section and invited our respected guests to grace the occasion. Where there is a hope, there is a life. Today, as we gather with shared a vision of healing and innovation, let us take a moment to seek divine guidance for all those who dedicate their lives to caring the patient and supporting their journey. Now, I request the college choir to kindly come forward and lead us in the prayer song. Kindly request all the dignitaries and the audience to please rise for the prayer song. After, we request everyone to remain standing as we move on the lighting of Kunthavi.
लसत्तुण्डिलाङ्गो परिव्यालहारं गणाधीशमीशानसूनुं तमीडे ध्वनिद्वं सवीणाललोलास्य वक्रं स्वरच्चन्दद्वन्द्वोलसत्बीजपूरं गदद्दर्पसङ्गद्य लोलालिमालं गणाधीशमीशानसूनुं तमीडे गणाधीशमीशानसूनुं तमीडे गणाधीशमीशानसूनुं तमीडे.
Lighting the lamp symbolizes the removal of darkness and spread of knowledge, wisdom and hope. On this auspicious occasion, we begin our program with the traditional lighting of the Kuthuvelaku, signifying enlightening and the pursuit of knowledge in our collective fight against cancer. Now I request the esteemed dignitaries on the dais to kindly come forward and light the ceremonial lamp. Thank you all. May I now request everyone to kindly be seated.
I request everyone to maintain silence.
A warm smile is a universal language of kindness. In healthcare, a warm welcome reflects our dedication to empathy, service and teamwork. Privileged to Professor Sarla Ma'am, HOD of Medical Surgical Department of Sree Abirami College of Nursing, to deliver the welcome address.
The best way to find yourself is to lose yourself in the service of others. Mahatma Gandhi. A respected Chairman Dr. P. Periyaswamy sir, a distinguished member of the Board of Directors, esteemed Chief Guest Dr. S. Madhavi, a respected Chairperson Dr. R. Renuka, and respected resource persons, faculty members, delegates and dear students. A very pleasant morning to all of you. It is my great privilege and honor as the organizing secretary of this prestigious national conference organized by Medical Surgical Nursing Department, Sree Abirami College of Nursing, to extend a warm and heartfelt welcome to each of you gathered here today. I extend a warm and respectful welcome to our beloved chairman, Dr. P. Periyaswamy sir, whose inspiring vision, strong leadership and continuous support have been the foundation of the growth and excellence of our institution. I request our principal, Dr. Renuka ma'am, to welcome our chairman with the bouquet. Thank you, ma'am. It's my great pleasure to welcome our esteemed Chief Guest, Dr. S. Madhavi, Principal, KMCH College of Nursing, Coimbatore. Your outstanding contribution to nursing education along with your vast experience and dedications are truly admirable. We are deeply honored to have you with us today, not only as our chief guest but also one of the distinguished resource person for this conference. I request our chairman sir to welcome Dr.S. Madhavi ma'am with shawl and bouquet. Thank you, sir. I extend my sincere welcome to the respected members of the Board of Directors, Dr. SenthilKumar, sir, and Dr. Balamurugan, sir, for the valuable support and encouragement. I am delighted to welcome our respected chairperson, Dr. R. Renuka, Principal, Sree Abirami College of Nursing, whose guidance and leadership have been instrumental in organizing this conference successfully. A special and heartfelt welcome to all our distinguished resource persons who are pillars of the today's scientific sessions. Dr. C. Fiula Esther Tangam, Principal, Nehru College of Nursing and Research Institute, Coimbatore, Tamilnadu. And Dr. Vijay C. Postgraduate Board of Members, Rajiv Gandhi University of Health Sciences, Director, AVK Group of Nursing, and Principal, Bright College of Nursing, Bangalore, Karnataka. Dr. Rajkumar K.S., Professor of Surgical Oncology, Ph.D. Institute of Medical Sciences and Research, Coimbatore, Tamil Nadu. Dr. Rajeshwari R., Vice Principal, Indrani College of Nursing, Puducherry. And next, Dr. Mudaliyappan R., Principal, Sacred Heart College of Nursing, Bangalore, Karnataka. And seventh resource person, Dr. A. Priya Mary Stella, Principal, P.K. Das College of Nursing, Kerala. We are truly grateful to have such an eminent speakers who will be sharing their expertise across the 7 sessions planned for today. I am confident that their insights will enrich our knowledge and enhance our clinical practice in cancer care. I extend my warm welcome to our Dean, Dr. Dakshinamurthy, sir, and all principals and faculties of Sree Abirami institutions whose presence adds value and encouragement to this academic gathering. My heartfelt welcome to all the delegates who have joined us today. Your enthusiasm and active participation make this conference meaningful and successful. This conference aims to provide a platform for learning, sharing, and exploring new ideas that can make a difference in patient outcomes. I take this opportunity to take the tireless efforts behind the scenes to organize this conference successfully. Once again, I welcome you all, wish you a very informative and enriching experience. Thank you.
Thank you, ma'am. Innovation is seeing what everyone has seen and thinking and no one has. On this auspicious occasion, we are honored to invite our respected principal and eminent and truly inspiring leader, Dr. Renuka ma'am, to come forward to officially unveil the theme of our national conference on cancer care, the next frontier.
Sir, honored chief guest, distinguished dignitaries, esteemed resource persons, beloved faculty, and my dear students. A warm good morning to all. It's with great pride and excitement that we gather here today for this national conference, which is a platform of knowledge, innovation, and commitment to one of the most pressing health challenges of our time. Now, I unveil the theme of today's conference, Cancer Care, the Next Frontier, exploring innovative approaches to battle cancer. Cancer is not just a disease, it is a journey that tests the strength, resilience, and hope of patients and healthcare providers alike. In this journey, nurses stand at the forefront, not only as caregivers, but as educators, advocates, and pillars of emotional support. This theme reflects a call to move beyond traditional care and embrace innovation, research, early detection, advanced treatment strategies, and compassionate patient-centered care. It reminds us that the fight against cancer is evolving, and so must we. As nursing students and professionals, we are the heartbeat of healthcare, and our role is not limited to administering care but extends to promoting awareness and prevention, supporting early diagnosis, delivering holistic and evidence-based care, bringing empathy and hope into every patient's life. This theme challenges each one of us to think ahead, learn continuously, and lead change in cancer care. So let this conference inspire you to become not just nurses but innovators, leaders, and change makers in the fight against cancer. With this vision, we proudly unveil the theme of our national conference. Thank you.
Thank you, ma'am. A leader is one who knows the way, goes the way, and shows the way. Today, we are privileged to gain insights and guidance from the visionary leader who truly embodies these principles. We are deeply honored to welcome Dr. P. Periyaswamy sir, Chairman of Sree Abirami Institution, Residential.
Respected Chief Guest, Dr.S. Madhavi, Board of Directors, Principal Dr. R. Renuga, Organizing Secretary Professor Sarada, distinguished resource persons, faculty members, delegates, and my dear students. A very good morning to all of you. It gives me great pleasure to preside over the inauguration of this National Conference on Cancer Care, the next frontier, exploring innovative approaches to battle cancer. I extend a warm welcome to everyone present here. I'd like to take a moment especially to welcome our Chief Guest, Dr. S. Madhavi, Principal, KMCH College of Nursing, Coimbatore. She is highly respected academician and an experienced leader in the field of nursing education. Her contribution to nursing practice, education, and research is truly commendable. We are honored to have her with us today, and I am sure her words will inspire all of us. I also warmly welcome all the resource persons who have kindly accepted our invitation to share their knowledge and expertise. This conference includes 7 important sessions, each focusing on different aspects of cancer care. These sessions will cover recent advances, innovative treatment methods, patient care approaches, and the role of healthcare professionals, especially nurses, in managing cancer effectively. I thank all the speakers for their valuable time and contribution. Cancer continues to be one of the major health challenges worldwide. It affects not only individuals, but the entire families emotionally. However, with increasing awareness, early detection, and advancement in treatment modalities, we now have better opportunity to fight the disease. In this journey, nurses play a very important role. They are the backbone of healthcare system. Their care, compassion, and commitment bring hope and comfort to patients during difficult times. Their role is not limited to treatment alone, but extends to emotional support, education, and rehabilitation. This conference provides an excellent platform to learn, share ideas, and update knowledge. I encourage all participants to actively engage in all the sessions and make the best use of this opportunity. I sincerely appreciate the efforts of the Department of Medical Surgical Nursing, the organizing team, and everyone involved in making this conference possible. Your dedication and teamwork are really admirable. Let us all work together with commitment and compassion to improve cancer care and build a healthier society. I wish this conference a grand success and a very meaningful learning experience for all. Thank you.
Thank you, sir, for your words. It's my great honor and privilege to warmly welcome our esteemed chief guest, Professor Dr. S. Madhavi ma'am, Principals of KMCH College of Nursing, Coimbatore, a distinguished academician and eminent leader in the field of nursing. Ma'am brings with her decades of rich experience in education, research and clinical practice. Her remarkable contribution to medical surgical nursing, research and academic excellence have earned her numerous accolades, including the Best Teacher Award from the Tamilnadu Dr. M.G. Medical University. Her dedication towards advancing nursing education, patient care and research is truly inspiring to all of us. On behalf of Sree Abirami Institution, I extend a heartfelt welcome to you, ma'am. We are deeply honored by your presence and look forward to your valuable insights. We welcome you, ma'am.
Thank you very much. Most respected Chairman of Sree Abirami Institutions, the Board of Directors, Dr. SenthilKumar, respected Dr. Balamurugan sir, the Dean of Sree Abirami Institution, Dr. Dakshinamurthy, the learned principal and my dear good friend, Dr. Renuka, other organizing team, resource persons on the dais, off the dais, and my dear enthusiastic participants of this day. Warm greetings to all of you. And I would like, at the outset, I would like to congratulate the Sree Abirami institutions, which I have seen grown leap and bounds and had made a great mark in the annals of education and especially the nursing education, and a wonderful the infrastructure that has been given to the nursing college. And it is wonderful to see sir, and I am very happy, delighted, and I think long back when college was in the inception stage, I had been here for the lamplighting ceremony, and huge growth, and the output from the Sree Abirami College of Nursing is commendable, and I really appreciate and I thank the chairman and the board of directors for inviting me and honoring me in this gathering. And this one-day workshop is beautifully organized from giving an understanding about carcinogenesis to empathetic care, compassionate care, without which the nursing becomes zero. You have lakhs and millions of rupees, and you remove that one, will become null. So is very important that nursing is to be revolving around the concept of care that is grounded in empathy, compassion and sincerity. So more so with the cancer care, the kind of treatment advancement has gone sky high, and in those days it used to be pronouncing the diagnosis of cancer is equal to pronouncing death, but now people are living healthy and happy for years because of the advancement of technology. But with advancement and with the technology has always the side effects and the problems. It cannot be all the time true. So careful, diligent nursing can mitigate many problems. So you will be, patient will be ordered the second drug, which is imperative. You need to be when you are administering. If you are a careful nurse, you can save the patient and you can relieve him from all the problems. Whereas if by your simple careless act, maybe he lose the hand or something like that. So very important. Nowadays there is so much advancement, but all comes with some kind of problems. As nurses, it is not just being there with the patient, but it is being with as a resourceful person, mitigating the problems and treating human responses to therapy. So very, very important in cancer care as a multidisciplinary team, and this one day proceeding will definitely enlighten you towards the direction and I'm very happy to see such enthusiastic participation from all the brilliant young nurses. You are going to uphold the professional values and ethos of nursing, and all the very best, and thank you for this opportunity. Thank you.
Thank you, ma'am, for your inspiring presence. We are truly grateful for your valuable time and insights. Thank you, ma'am. Now I request our chairman, Dr. P. Periyaswamy sir, to kindly present a memento to our chief guest as a token of our gratitude and appreciation. Thank you, sir. Leadership is the art of inspiring others to dream more, learn more, do more, and become more. With this inspiring thought, I invite Dr. SenthilKumar sir, Managing Director of Sree Abirami Institution, to deliver his special address.
Good afternoon, one and all. It's a wonderful day for a nice conference on cancer care, the next frontier. First of all, I'd like to thank Dr. Madhavi Madam for accepting and coming over here, and I would also like to thank all the principals and the faculty members who have accepted our invitation to come over here. And I see a huge number of students from KG, RVS, SRIPMs, Royal Care, Chettinad, PPG, KMCH, PSG, Nehru, Hindustan, Sai Ranganathan, Sashuri, GKNM, Kungunadu, Ganga, JK, Sai and Karpagam. I think almost all the colleges have been represented. That shows the organizational capacity of our principal and the faculty. That is really great. See, they give us the proposal of this and then we leave it to them. Behind this successful conference, definitely Dr. Renuka, Dr. Sarala's work is there. They have taken so much of work in spite of their regular academic schedule, and I believe the exams are coming over next week, I think. In spite of this, I am delighted to see so much of attendance. That is really good. Cancer nale, it's very, very common. And it is said that 1 in 9 of Indian population are going to have cancer. And as of present, around 1.2 lakhs patients of cancer are there in Tamilnadu. Every year, that's a huge number. Initially, munnadiyellam paatha, cancer ngiradhu or cancer specialty hospital. Angadhan cancer was delegated to a superior level, which was not regularly happening in the smaller nursing homes and hospitals. Now it is not like that. Everywhere cancer is coming up, it is being diagnosed at an early stage and it is being treated. And in our hospital, Abirami hospital, we have all facilities for cancer care. Surgical oncologists are there. Periyaswamy sir as a senior urologist is there. We give for surgical gastroenterology, Dr. Balamurugan is there. And we have surgical gastroenterologist and oncologist also. So that is the huge rise that is going on in our world now. So definitely you should know about it. Dear students, everything will not be taught in the schools or the colleges. In colleges we regularly follow the prescribed test books which is peer reviewed, and by the time it comes to the colleges it is usually around 5 or 7 years old. Definitely you will learn a lot in the conferences where it is reasoned. It is always said that you should never stop learning. Learning never stops with BSc, learning never stops with MSc, learning never stops with Ph.D. It is said that once you stop learning, you slowly start harming your patients. So it is very, very important that you be fresh with the latest of the cancer care. It is very, very important. So always attend conferences like this, and conferences we want it to be, especially our conferences, we want it to be interactive. It should not be a one-way monotonous speech. We want you, all of you, to interact with the faculty, get their ideas. If it is not possible during the lecture sessions, catch them during the lunch sessions or in the break sessions. All the faculty are there to help you out. We want everybody to interact with your senior persons, learn as much as possible, make use of this conference. Wish you all a very bright future. Thank you.
Thank you, sir, for your words. Great achievement starts with a single bold ideas and the courage to pursue it. With immense respect, I invite Dr. Balamurugan sir, Managing Director of Sri Abirami Institution, to enlighten us through his special address.
A warm good morning to all present here for the Cancer Care National Conference. On the dais and off the dais, I congratulate the organizing team under Dr. Renuka ma'am and the faculties across the country and my dear students. மிகினும் குறையினும் நோய் செய்யும் நூலோர் வழிமுதலாய் எண்ணிய மூன்று. That is, when the loss of balance, it becomes disease. When the cell counts increases, it causes cancer. So we have to take necessary early steps for prevention. நோய் நாடி நோய் முதல் நாடி அதுதணிக்கும் வாய் நாடி வாய்ப்பச் செயல். So early detection, prevention is the best, and treatment for cancer at early stage is curable. Now robotic surgery is also available even for cancer surgeries. So take home this message that early cancer is curable. I wish you all a very happy learning and to utilize the best of the opportunities. உற்றார் உறவினரே பார்க்கவும் சகிக்கவும் முடியாத கேன்சர் வியாதியை செவிலியர்கள் அன்புக்கரங்கள் கொண்டு உங்களது சேவை தொடரட்டும். தேங்க்யூ.
Thank you, sir. As a token of love, Dr. Madhavi ma'am present a book, Burner and Siddharth, a textbook of adult health nursing, to our institution. Kindly, I request our chairman, sir, to collect the. Thank you, ma'am. Thank you, sirs.
Well, now we'll take a short tea break. Enjoy the tea and snacks. Kindly regather in the auditorium by 12:05. Refreshment will be provided outside the auditorium. Chandra Medical College, Chennai, and also served as nursing supervisor and staff nurse in cardiothoracic intensive care unit. Ma'am has made significant contribution internationally as an visiting faculty at the University of Wisconsin, USA, where she presented on critical care topics and observed advanced nursing programs. She is also a recognized Ph.D. guide under the Tamilnadu Dr. M.G. Medical University and has served as an Senate member since 2004. Her leadership extends to become an advisor for NABH accreditation, executive editor of the Tamil Nadu Nursing Council Journal, and a member of various national and international academic and advisor boards, including Lippincott Publishers, USA. She has organized international, national, and state level conference and has been a resource person for numerous workshops across prestigious organizations like TNAI and Critical Care Association. In the field of publication, she had edited 6th book, co-edited the renowned Bronner's and Siddharth Medical Surgical Nursing textbook, authored multiple chapters and published numerous research articles in reputed journals. She has also developed online learning models for continuing nursing education. Dr. Madhavi Ma'am's excellence has been recognized in various works. Best Nurse Educator in Tamil Nadu 2011, Best Teacher Award with Tamil Nadu Dr. MGR Medical University 2012, Excellence in Nursing Education Award 2019, multiple research grants and Best Paper Awards. May I now invite Dr. Renuka Ma'am to welcome our speaker Dr. Madhavi Ma'am with a floral bouquet.
Thank you very much for that wonderful words, kind words. So without making a lot of time, let me go into the topic, the therapeutic arsenals against cancer, Cancer Conclave 2026. So worldwide 20 million new cancer cases are occurring with 9.6 million deaths. You can understand what is the magnitude of the problem. Okay, so in India we have again new cancers. 22 census says 14,61,427 new cancers. So it is one of the important non-communicable disease and that cause death and disability. The crude death rate is around 100.4 per 1 lakh. So when we talk about, I think in the morning session you had learnt about carcinogenesis from cell to coas, and the latest diagnostic tests were done by expert faculty. So in this session we will see about the advancements in oncology. So the first and foremost is now precision medicine. So identification of actionable targets for prevention and treatment strategies using next-gen sequencing and biomarker analysis. So this is a very, very important thing. Earlier they were trying to target, so invader is coming. So cancer cells are like terrorists. They are mixed in between the common people. They will be mimicking a normal cell, but they will behave differently, like a terrorist is doing that way. So they take away all the resources. So new angiogenesis is a very important marker of cancer cells, and it can invade the adjacent lymphatic or even adjacent blood vessels. So thereby it gains root and entry into the distant organs, which can be very difficult to identify. But nowadays, these next-gen sequencing and biomarker analysis helps them. Then advancement in genomics and genetic engineering has advanced so much. Now there are a lot of methods, thereby we are treating cancers and they are giving good results. Then application in AI diagnostics are very helpful in using deep learning techniques. Now liquid biopsies, no more. Earlier it is always punch biopsy or incisional biopsy, and then of late it was FNAC, but now we are looking into the cancer cells from the blood itself. Liquid biopsies are now becoming the order of the day for diagnosing various cancers. Then application of AI across the treatment. It is not just the diagnostics. AIs are very useful. Deep learning techniques are useful in therapeutic modalities, especially like radiation oncology, which we will be seeing later. Sorry. So precision health is use of biological, genetic data alongside social, economic, cultural and environmental factors to guide individualized treatment towards optimal well-being. So how this precision medicine is going to change, you can see in the next few slides when I am talking about how certain treatments and preventive strategies are very helpful when they are using the precision medicine. So the order of the day for treatment is multidisciplinary approach. You will be also asked about this question. So the cancer is not treated, it is by one single person. It is always multidisciplinary, medical, surgical oncology, radiation oncology, oncology nurse plays a vital role, and she plays the central role in all type of oncology. Then we have psychosocial worker, clinical psychologist. We have other members, physicists and so many other people also are involved. But the nurse's role is so vital. So let us first talk about medical oncology, radiation and followed by surgical oncology. I think there is a session dedicated for surgical oncology advancements. I will not talk a lot about surgical oncology, but I think I will concentrate more on medical oncology. So the latest, earlier all of you might have read the different type of cancer group of drugs. So anti-cancer, antibiotics, anthracycline, so many different groups you might have seen. But now all those cells, all the treatments, whether it is radiation oncology, earlier ortho voltage machines are used where low energy radiation is focused on a particular organ. While they are killing, in the process of killing oncogenic or oncologically modified cells, it kills the adjacent cells. It produces enormous normal healthy vital tissues which are very important. But what is that now is like the targeted therapies are very, very useful. So precision guidelines are helpful here. Immunotherapy involves the medication or biochemical mediators to stimulate or suppress components of immune system to kill cancer cells. So immunotherapy is the now it is a gift of advancements, technological advancements. Dramatically changed cancer treatment and has improved survival for many forms of cancer. Because I have worked in cancer ward in my first stint in railway hospital. First 6 months, I requested the patients will be coming to the ward, will be walking, and after my full morning duty or afternoon duty or anything, my work only is to dilute the chemo medications, giving. And by the end, after 3 or 6 cycles, he will be sent to the Roy Memorial Hospital, which is a radiation institute. After completing all these therapies for around 6 months to 1 year, he will be becoming very sick, and we will put them in one bed number. Bed number 22 in our ward used to be where his suffering will be ended. So a person who is walking is ended in no time, maybe 6 to 8 months time, he will be facing death. So that was the condition. Okay. So now you can see the survival is so much, even with the lung cancer. Even with lung cancer, nearly 15 years of complete disease-free remission we are seeing. And multiple myeloma, leukemia, these treatment are giving enormous advantage for all the patients. So there are different types of immunotherapy: non-specific immunotherapy, monoclonal antibodies, checkpoint inhibitors, cancer vaccines, chimeric antigen receptor, T-cell therapy. So these are all the latest advancements which are happening all around the world, in our hospital also, and you will be seeing all this type of patients. What you as nurse need to know, you have to learn about it also. So let us see one by one now. Non-specific immunotherapy. When you think about your immune mechanisms, you know the role of T lymphocytes. B lymphocytes only just engulf the bacteria or any pathogen, and that is the end of it. But whereas T cells start attaching to cancer cells, and it starts T helper cell and T killer cells, so many different types of cells it produces, and in the process T killer cells produce interferons and interleukins, and these interleukins are having the capability to kill the normal cells. So immunosurveillance is one concept. I hope the previous speaker might have talked about it to you. So if not, please go and refresh yourself about immunosurveillance, how our own antibodies, our own immune system is capable of, it keeps a watch, like cameras are giving surveillance to the administrators. Like that, our immune system is capable of keeping a careful watch, and it can catch the immune modulated or genetically modified cancer cells, and it can engulf and remove it off from our system, so that the modified cells will not proliferate and make into cancer cells. So the interferons, interleukins and colony stimulating factors are non-specific immunotherapies, and these are all identified and they are used as a therapeutic modalities. They are cytokines with antiviral, anti-tumor and immunomodulatory capacities. Multiple anti-tumor effects of interferons include anti-angiogenesis, and it can prevent new blood vessel formation, direct destruction of tumor cells and inhibition of growth factor, disruption of the cell cycle. So this is the method how which it is causing in cell death. And the interleukin 2 and options are advanced cancer cells and metastatic melanomas in adults. They are very useful. See the monoclonal antibodies. So the monoclonal antibodies are cultured from human cells and has the potency to kill cancer cells and with less side effect. MOBs are used, trastuzumab. I think many of you might have heard of trastuzumab. These are all monoclonal antibodies. MOBs are used to assist in diagnosis of ovarian, colorectal and breast and prostate cancer and some type of leukemia and lymphoma. Side effects are flu-like symptoms, chillness, weakness, malaise, headache, nausea, vomiting. See, all these are all some of these side effects. But this is somewhat manageable. But whereas earlier conventional chemotherapy, they used to have anticipatory vomiting. First cycle they will come without any problem. Second cycle they will come okay. But they will have enormous vomiting. The third cycle also. Tomorrow is the third cycle, and today itself the patient will start vomiting. That is the kind of psychogenic vomiting the cancer treatment can produce. Okay. So monoclonal antibodies do produce or induce vomiting, but it is manageable. So the FDA approved monoclonal antibodies. So many MOB, if you find some things like that, they are all rituximab is very, very commonly and effectively used in lymphomas. Earlier lymphomas, people will not survive long. Trastuzumab produce enormous good effect for breast cancer patients. Then immune checkpoints are specific protein on the T cells that need to be blocked or inactivated to initiate immune response against cancer cells. So where is the problem? Why everybody is not getting cancer? It is because our T cells are protecting us, whereas these T cells are incapacitated in cancer patients. So immune checkpoints inhibitors are a specific kind of proteins and on the T cell that need to be blocked or inactivated so that cancer cells can be effectively destroyed. MOBs block specific checkpoints on T cells to enhance cancer cell surveillance and destruction by the immune system. PD-1 inhibitor drugs, nivolumab, premolizumab, semiplimab, these are all specific proteins that are found to be used now as checkpoint inhibitors. Then PD-L1 inhibitor drugs, atezolizumab, avelumab, all these are all other kind of checkpoint inhibitors. CTL4 inhibitor, LAG3 inhibitor, these are all specific proteins. LAG3 is a specific protein. CTLA is another protein, specific protein found on the cancer patients. Cancer checkpoints are successfully treating now patients with lung cancer, non-small cell lung cancer. Okay, the non-small cell and small cell lung cancer. Small cell lung cancer, we found that very few months earlier. I have seen patients where they lived only 2 months or at the most 2 months. Entire lung field you can see in the X-ray filled with warts like wart cell carcinoma. Earlier it is called wart cell carcinoma. Like warts it will be. So it is all effectively now treated with the immune checkpoints. And breast cancer, especially triple negative. Triple negative means we have in our cancer patients, they test the estrogen receptor, progesterone receptor, Herceptin receptor. If these three are negative, the possibility of prognosis is very bad. In those patients, they die within 6 months of time of diagnosis. I have one of my students who died within 6 months, less than a year time, after completing adjuvant chemotherapy, neoadjuvant chemotherapy, then radiation therapy, complete surgery, everything. She died within the 1 year because she was triple negative. But nowadays we see these checkpoint inhibitors are helpful for them. Kidney cancer, bladder cancer, hard skin lymphoma, liver cancer, colorectal cancer, stomach esophageal cancer, cervical cancer and endometrial cancer. In all these type of patients, cancer checkpoint inhibitors are very helpful. What are the side effects? Again, skin rash, difficulty in breathing, swelling, redness, diarrhea, fatigue, loss of appetite, cough. Side effects are activation of inflammatory response in organ systems like pneumonitis, myocarditis, nephritis and thyroiditis. So, whatever may be the advancement, patient suffering cannot be negated. So, there is no replacement for a compassionate and empathetic nurse and empathetic care. Then cancer vaccines. So, they have identified now. See, what a lot of problem people will used to suffer with earlier days. Now, because of vaccine, very many infectious diseases we are successfully overcome. With the vaccine, and the smallpox is now eradicated. So, like that, there are attempts now to help people with the cancer vaccines. Cancer vaccines mobilize body's immune response to prevent and treat cancer. These vaccines contain either portion of cancer cells alone or portion of cells in combination with other substance that can be augment or like live attenuated vaccines. So in the live attenuated vaccines, they are they are not giving the pathogen is still alive but attenuated, the virulence is reduced. The same way cancer cells virulence is reduced, but it is capable of inducing anti-cancer properties so that our body can kill the cancerous cells if there is any new development. So that is what is the idea. So in that way they have developed now vaccines, HPV-9 vaccine that prevents cervical cancer. That is recently in our new government initiative, they have started for the young girls, they have started giving Gardasil. Gardasil, all of you might have, community girls who are going to community might be knowing about it. It is a vaccine that is supposed to be preventing and prevented very effectively in Western countries. Why they are not having lot of cancer cervix is because of that vaccine. So now Government of India also is helping our people with these HPV-9 vaccine. HPV is the viral oncogen that produce cancer in the cervix and ovarian cancer, testicular cancer, all this reproductive organ cancer. So this vaccine prevents cervical, anal, vaginal and vulvar cancers. The 3 doses over a period of 6 months for best result before embarking on sexual life. And then Ciplucel, this is helpful in metastatic bladder cancer. BCG vaccine is used in this into the doing through a cystoscopic method. They will be introducing BCG vaccine and that helps metastatic bladder cancer. Now this is the new order, symmetric antigen receptor T cell therapy. So I have already talked about. So there are B lymphocyte, T lymphocyte. T lymphocytes are one type of A granulocyte and that goes through the thymus and becomes capable of detecting cancer cells and intracellular pathogens. So these T lymphocytes are very, very essential part of our immune system that is capable of doing immunosurveillance and killing cancer cells. So the symmetric, so in a cancer patients, these T cells are supposed to be not very potent or not very effective. So they are weak soldiers and they fall prey to the cancer cells. So this symmetric antigen receptor T cell therapy is a type of targeted immunotherapy that uses tumor specific antigen recognition. So they make these cells to recognize. So earlier days it was all for especially for blood cancers. Okay, so for leukemia and all these things, bone marrow transplant is the last order which can give some effectiveness. But now this our own using our own cells, this effectiveness is attained. The CAR T cell therapy involves use of genetically modified T cells, our own cells, to kill the cancer cells. So in acute lymphoblastic leukemia, certain type of lymphoma, this gives best resolutions. So what do? They collect the autologous or allogenic T cells using the leukapheresis. Like blood is taken, for transfusion, many of you might have donated blood. So like that, using a large bore needle, they will be collecting the blood from the patients. And then these blood is sent to lab where they are genetically modifying the T cells of our own blood. Okay, by adding chimeric antigen in the labs. In the lab, these cells are modified, T cells are modified, so they are enabled to, are capable of identifying a new cancer cells. So whenever there is new cancer cell arising, it is going to destroy and demolish. Okay, so genetically modified this, it takes so much time for the genetically modified cells to grow in clones, so many numbers. So subsequent numbers, sufficient numbers are grown genetically modified in the lab. Only then they are ready for administration. Okay, once it is ready, it is administered like any other blood transfusion. So this is the process. In our KMCH, they are doing CAR T cell therapy, and many of you must be wondering what is CAR T cell therapy. CAR T cell therapy is taking our own blood and identifying the T cells and genetically modifying them so that inactivated or incapable T cells become capable. And they will destroy using a normal process. So what are the side effects of CAR T cell therapy? Actually, the labs which are capable of growing these genetically modified T cells are in Mumbai and Pune. So whatever is taken from all over India, this goes to Mumbai or Pune, and from there it is the clones are grown up and genetically modified, and they are coming back for us, and then it is infused. So cytokine storm is the most common side effect of T cell. Cytokine storm. Say whenever cytokine release is a common protective mechanism. So we are working with a knife. Knife can cut improperly, it can cut your finger or it can cut the fruit you are indenting. But in the same way, we are trying to work with the T cells which are normal knife which we are having, God has given us. And when we are manipulating, sometimes it can cut our cells. Like that, it is a normal mechanism. It produces a cytokine release and bradykinin, all the different kinins, and that produce cytokine storm. So clinical manifestations of fever, tachycardia, chills, myalgia, arthralgia and fatigue. In severe form, it can cause hypotension, hypoxia, respiratory distress, coagulopathies and end organ toxicities. So neurological toxicity can range from headache, mild confusion to cerebral edema or intracranial hemorrhage. So whenever we transplant a bone marrow, earlier to the transplant they do total body irradiation or knocking dose of chemotherapy, whereby the entire body system chemotherapy is destroyed. So the patients will be zero immunity. They will be more prone for infection, like more than a normal newborn. But this is not like that. It is more, and the rejection rate also is very less. That's very important advantage of CAR T cell therapy. Next we come to the targeted therapies, drugs that specifically target receptors, proteins and signaling mechanism that allow uncontrolled proliferation of cancer cells, such as lock and key mechanism is known as targeted therapy. So many drugs are administered orally. So you can see earlier all the drugs are mainly, to my knowledge, I think 35 years back when I graduated, we can see tamoxifen is the only one drug that is given as oral chemotherapy. But whereas now so many oral chemotherapy drugs, like paracetamol, like now so many chemotherapy drugs are available. So this is how for a tumor to grow, there is a prerequisite. So tyrosine kinase is needed, and that needs ATP. When these things are fit properly, it start multiplying in uncontrolled way. There is no normal cell death. So in any body system we have cell death. Normal apoptosis is one term all of you might be remembering. Every cell goes for a natural death. But these cancer cells are not listening to the apoptosis signals. So they keep on proliferating, and it can enormous number of time it proliferate. So that is how it is not responding to cell death signals. So when we have a damage, so our cells grow from the sides and it fills. Once the margins are meeting each other, the cell growth signal is stopping. So that is why the cells are, after filling the gap between it may be a muscle loss or a skin loss or anything, once the edges touch each other, there is a signal going to the body and it stops. This signaling mechanism is inherent in our body. This cancer cell, genetically modified cells, they don't listen to apoptosis, and they grow to other place and it proliferate new angiogenesis. It can like root like it can go to deep to the adjacent blood vessels, adjacent tissues, and it can invade. So all these are all the properties because they are getting all these funds. No, all these ATP molecules, tyrosine kinase get affected, and then the genetic transcription happen and proliferation happens. All these are all cut when the inhibitory signals, the IPS inhibit the ATP molecules that are available for the cancer cells. So MABs, anti-ligands, checkpoints, all these are all preventing the ATP molecules. So the life is, you cut the oxygen, you cannot breathe. If there is a fire, you prevent the oxygen. So the fire will not be able to sustain. So it gets doused. Same way, the cancer cells also get inhibiting. Okay, when the ATP molecules are taken away from it. So now we have so many FDA approved TKIs, NIBs and MOBs. NIBs are called imatinib. It is useful for CML, chronic myeloid leukemia, GIST and others. Dasatinib, spray cell, it is the brand name. Again, ALL for CML it is used. Nilotinib is very commonly given in our cancer patients, CML. Gefitinib is useful for erlotinib, also very commonly given to lung cancer patient. Lapatinib is useful for breast cancer. Sarfatinib is useful for kidney and liver cancer. And sunitinib is useful for kidney cancer. So there are other drugs, other oral anti-neoplastic agents such as for cancer. This slide I just put chlorambucil long time back it is identified, but I have added because these are all dexamethasone is the first choice. It is given like any drug, but it is a first line of treatment for AL. So, and prednisolone we commonly give for allergic disorders or for asthmatic patients, but these two also are a oral anti-neoplastic drug concerned with ALL. And cyclophosphamide is given as a IV drug, but it is available now in a oral form. Chlorambucil is a drug that is available in a IV form, and now it is commonly given as anti-neoplastic oral chemotherapy. Because why I want to stress here about is oral cancer drugs are now prescribed very commonly. You as a nurse may be handling these drugs. When you are handling itself, you have to be very careful, because all the cancer drugs are carcinogenesis. They kill cancer cells, but in a normal patient that can induce cancer. So when you are standing below and you are mixing cyclophosphamide drug or your adriamycin you are doing without gloves, what you can have, you can get in contact and you can inhale those drugs and you can potentially give rise to cancer yourself. So you have to protect yourself. And in the same way, oral cancer drugs also, you have to wear gloves, and that should be out of reach of patients. Yella ore mari, no, look alike drugs and sound alike drugs. You are all might be knowing there are many medicine which may look like paracetamol. But if you are going to take that medicine, it can give cancer to a normal person. So that is the one you have to be very carefully telling. Sometimes patient may not know they are taking that drug, they feel vomiting like, and they throw 1 lakh rupee. So lepotinib is cost one strip cost around 1 lakh it seems, which is given for lung cancer patients. They will just throw off. What will happen? So it will make the cancer cells to grow at a faster rate. Then small cell lung cancer, you have etopside, ovarian cancer, ultratamine. So these are all oral cancer drugs. For breast cancer, cepicitabine, tamoxifen, anastrozole, dexamethasone, letrozole, and for myelodysplastic syndrome leukemia. Myelodysplastic syndrome is a precancerous stage where patients will have aplastic anemia, aplastic, all cell lines will be affected. They may have topotecan, is one of the oral anti-cancer drugs which you need to be very careful when we are administering. So all the oral anti-cancer drugs have to be handled with care, and when your patients are prescribed by the doctors, when it is prescribed to them, you have to be double checking, triple checking, and you have to involve the patient and the relatives. This drug are potentially carcinogenic and it has to be handled with care. Patient should wear gloves and it should not be missed, and because many a time this we are seeing with our patients. Then I think the next important advancement in radiation therapy is precision radiation therapy. Like precision medicine, we have seen about targeted, instead of targeting all the surrounding normal tissues, now we are going for radiation therapy also, precision radiation therapy, intensity modulated radiation therapy, image guided radiation therapy. So these are the techniques. Earlier it is ortho voltage machine, they will be lying down under the it is 60 grade only, it will be giving for 6 hours or 8 hours. The patient will be lying down. After 5-6 settings, they start having dry desquamation followed by wet desquamation. They will have stopping, they have to stop the radiation therapy. Now the LINAC, the new advanced machines is giving precise particulate radiation therapy. It gives particles. So it goes deeper into the tissue and it gives only the precisely it gives. But what is the other problem is, like there are organs which start moving, like for example colonic cancer, the colon keeps moving because the peristalsis will be happening, and there is a breast cancer getting radiated, the lung keeps moving here and there with every movement. So the image guided and intensity modulation is happening with the algorithm. Then the image guided is real time images. So with every setting, every session, there is a shrinkage of the cells. So the same amount may be lethal. So they will be reducing. And in the intensity modulated things where when the machine is sensing whenever the lungs is moving out, when you are inhaling, the lungs is closer to the chest wall. So the machine stops radiating, and when it is going inside, when we are breathing out, it goes inside. At that time the machine will deliver. So this is what is called as precision radiation therapy. We have much advanced now, and magnetic resonance, MR magnetic resonance imaging along with LINAC is also nowadays is very useful. It prevents targeting normal surrounding tissues. So this is what is the picture, how we can, you can see this is the tumor cells, the beams are given, and the normal salivary glands. Earlier it used to be head and neck radiation. The most important problem is xerostomia, and the patient is unable to get good nutrition. So these salivary glands are very essential, and it is saved by intensity modulated radiation therapy. I think sir is there, he is already there, and I don't want to add on this, and he'll be telling a lot about this. So when the medical world is growing taller and taller with a lot of advancement, as nurses we need to know. I think I urge all these young students here to take up courses like a 1-year diploma in oncology nursing, then ostomy care nursing, so a 1-year diploma in palliative care nursing, then medical oncology trainings are being given in Trivandrum Cancer Institute, Tata Memorial Institute is giving, because they are removing the colonic cancer, they are doing colostomy. So the patients, all the shit is coming, the motion is coming throughout, and it may smell bad, and they feel so bad, and it may even reduce the self-esteem, and they need specific care and counseling. So ostomy care and all these things are all there available for you. And whenever you are handling medications, onco medications, you have to be double and triple check always the dose, double dose, wrong dose. You have to avoid. You are a diligent nurse, you are a very astute nurse. I wish you are to be continuously monitoring the patient. So whenever you are inserting the line, be very careful and see that you are monitoring and not allowing vesicant to be making necrosis, all those things. So for oral health, we need to be embracing new technology like mobile health and electronic health records. We need to be also be aware of what is artificial intelligence can do to us, and simulation technology or virtual reality. Because we are 24/7, we are there, but we should be able to educate the patients and how this can help, what they have to do as nurses. So these are all the things, nursing implication I would like to tell you all. So at the end of the day, I would like to tell you all, guys, you are going to do a great thing. As nurses, your work will be commendable. You can make the patient have a quality of life and quality of death also. As a palliative care nurse also, you can do dignified death. So it's a specialized field. Oncology nursing is a specialized field. BSc nursing or diploma nursing is not giving you enough knowledge and skill. You need to update yourself. You need to get specialized knowledge and skill. You have to be passionate about it. Require expertise in handling chemoports, because one chemoport installation may cost so much for the patient, but you are inadvertent, not nice hands, it can collapse the waste, it will waste, and it can cause necrosis around the chest area. So you need to be very smart and handle the ports and the central and peripheral lines. You have to carefully monitor, knowledgeable about chemotherapeutic agents, which are the drugs which are emetogenic, which are drugs which can cause very bad immunosuppression or bone marrow suppression. What are the drugs that can cause cardiotoxicity? Your knowledge on those things, you can be watchful. Doctors are prescribing, but what is happening, you also should be taking responsibility towards it. Then collaborative practice and teamwork. Many drugs are now oral, need follow-up and monitoring for successful assessment. Expertise, extreme passion and love for the field makes it successful. I want every one of you here to be passionate about oncology nursing. It's a very, very pertinent and rich field where your contribution, you can make a difference in human beings' life. All the very best, and thank you very much for your patient listening and the opportunity.
Thank you, ma'am, for your insightful section. Now I request Dr. Renuka ma'am, Principal of Abirami College of Nursing, to kindly present a memento to ma'am as a token of love. Thank you, ma'ams. It is my great honor and privilege to introduce our distinguished speaker, Dr. Sir, a highly respected name in the field of surgical oncology. Sir is currently serving as a medical superintendent in Ph.D. Institution of Oncology and also a professor of surgical oncology at PSC Institution of Medical Science and Research, Coimbatore. With an outstanding academic journey, he completed his MBBS from Stanley Medical College, followed by his MS from Postgraduate Institution Medical Education and Research, Chandigarh, and MCH from Key Park Medical College, Chennai. Adding international excellence to his credentials, he earned his Fellowship of the Royal College of Surgeons of in Berg. His professional journey is equally remarkable. He has served as an associate professor and sub-dean at AIIMS and also contributed as an international surgical advisor to the Royal College of Surgeons of Edinburgh. Sir contributed to research is truly inspiring. He has authorized over 60 research publications, 3 book chapters and has led 15 research projects along with guided multiple student theses. His excellence has been recognized globally through prestigious honors such as UICC Technical Fellowship 2024, SSO IASO Fellowship Award 2024, Commonwealth Distance Learning Scholarship and title of the Promises Oncologist 2024. He is an active member of 15 professional societies and has delivered more than 100 conference presentations, showcasing his dedication and advancing medical science. A registered practitioner with both the Tamilnadu Medical Council and the General Medical Council. Continues to inspire many through his knowledge, leadership and commitment to patient care. Let us welcome this eminent personality, Dr. Sir, section on Scalpel Against Cancer. May I now invite Dr. Renuka Ma'am, Principal of Abirami College of Nursing, to welcome our sir with a flower bouquet.
Thank you for that long introduction, ma'am. I'm Rajkumar. I know we are running late and I am the one who is keeping you from your lunch, so I'll be as short as possible. My topic here is to introduce you to the surgical aspects and surgical care in cancer. So greetings from Ph.D. Institute of Oncology. Financial disclosures, no relevant financial disclosures, no conflicts of interest. Thanks to my teachers, seniors and my team members. And this is my team. We have a very good oncology nursing team at Ph.D. They are one step above the other nursing team in Ph.D. So before I start, what is cancer? Cancer is not a single disease, it is a group of diseases. So each patient with cancer is different, each cancer is different and each cancer will require a different treatment. So why is it important? It is a disease of national importance with at least 15 lakh new cancer cases every year in India and at least 8.5 lakh deaths every year in India. So what causes cancer? There are so many causes of cancer. There are more than 200 varieties of cancer. So I usually divide the causes of cancer into 3 categories: nature, nurture and Narayana. So nature is what we are born with, what we are living, all the problems that we go through and all these things. Nurture is how we grow, eating habits, smoking, alcohol, all these things, and Narayana is what is not under our control. And early detection of cancer is important because the cancer initially grows very slowly and then suddenly rapidly grows. So summarizing these things, cancer is not a single disease and therefore it does not have a single cause and therefore there is no single treatment. So how do we treat cancer? Before we treat cancer, it is important to find out is it cancer or not, the type of cancer, the stage of cancer, and the patient is the patient fit to undergo treatment or not. So what are the treatment options that we have? We have multiple treatment options: surgery, chemotherapy, radiotherapy, immunotherapy, hormone therapy, targeted therapy, gene therapy, everything. Whatever you want to name them, you have all these things. But how to choose which treatment the patient, particular patient requires? It is by a multidisciplinary approach, because as I said, cancer is not a single disease. Each cancer is different, each cancer patient is different. So you need more than one type of treatment and more than one team or team member or a treating person involved in the patient's care. So we have multiple team members involved: radiation oncologists, medical oncologists, pharmacists, surgical oncologists, nurses, specialist nurses, physiotherapy, social counselors, all these people. So as I said, why do you need multidisciplinary teams? Because it takes a village to raise a child, right? So when we come to a decision of cancer treatment, the patient is in focus. The patient is in focus, and all of us focus on what is best for the patient, and multiple factors go into the decision making. The age, the performance status, the diagnosis of the cancer, the stage, the pathology, the comorbidities, what prior treatments the patient has undergone, what is the evidence for the particular treatment. But apart from these medical factors, there are other non-medical factors that are important when we decide on surgery. It's the patient's preference, the social support that is available, the finance and logistics, and the infrastructure that is available with your hospital. So now coming to my topic. So what is cancer surgery? How is it different from other surgeries? So for cancer, we might need to, the surgical treatment of cancer might be required at various stages of cancer treatment. You might need a surgery to diagnose the cancer. You might need a diagnostic laparoscopy or a biopsy or a thoracoscopy or something to find out whether it is cancer or not. Then you might need a surgery to stage the cancer. Then there comes the radical surgery, where you need to do a surgery to remove the cancer or debulk the cancer. Then going one step forward, you remove the cancer while preserving important organs or functions. That is a conservative surgery. Then you might need a surgery to prevent cancer. Probably you might have heard of Angelina Jolie, who underwent breast bilateral mastectomies, by breast removals, to prevent her getting breast cancers. So that is prophylactic surgery. Then there is supportive care surgery or palliative surgery, where patients are suffering from end stage cancers and they might need surgeries for their feeding or breathing, or to pass motion or pass urine, or pain, reduce pain or something like that. And then there is the rehabilitative or the reconstructive surgery after cancer treatment. So then, as I said, how is it different from other surgeries? I usually give this example to whoever asks me how cancer surgery is different from other surgeries. So what is important is we do more than what is required. One step higher, that's the goal. Always one step higher, one level more, a centimeter more, just more than what is adequate. The typical example is, we are like Jyotika, kudukra panathoda jastiya nadipom. Seringla. So radical surgery, we do one step more, that is more important. So we don't worry about what is to be removed. We worry about what is to be preserved. We identify structures that need to be preserved, then remove everything else. We don't bother what is inside. So we don't, the reason is, the cancer is like vidadu karuppu. Enga vittu varamo anga dhaan thirumbi varum. Where we are compromising, where we think that let us do one step less, that is where the cancer will come back. It is very unforgiving. It's an unforgiving disease. So we always do what is more than required, a step above, one level above. So that is what is different from other surgeries, and that is how we are different from other surgeons. So cancer surgery has evolved from maximal surgery, that is a radical surgeries. I think you would have seen patients where their faces, the whole face is removed, or whole big surgeries, big incision from top to bottom, amputations and all these things. That is maximal radical surgeries. Then we moved on to the era of minimal invasive surgery, where we did the same surgeries through keyhole surgeries, laparoscopic and robotic surgeries. Then now we are in the era of minimal surgery or conservative surgery, where we are trying to remove the cancer completely while preserving important functions and organs as much as possible. So that is minimal surgery. Probably in the future, we might end up in a situation where there is no surgery for cancer. But it is always a dream, and as men we always like to dream. So Madam wanted me to tell a few words about robotic surgery. What is robotic surgery? It's nothing new. It's just it is an additional innovation, a latest innovation in the field of minimal invasive surgery. It is just another tool in the surgeon's whole armamentarium. Okay, the surgeon holds the robot holds the instrument, but the surgeon does the surgery. So it is actually robot assisted surgery and not robotic surgery. The robot does not do the surgery. Probably in the future there might be AI and all these things, and probably we are going to go in a direction where the robot might become autonomous, Skynet can become active, but as of now the surgeon does the operation from a console, sitting from a console, and the patient is on the operating table. So the surgeon indirectly controls the instruments sitting at a console. So this is the usual setup of a Da Vinci robotic surgical system. There are other robotic surgery systems also available in the market. The surgeon sits on the console, the patient is somewhere else, the robotic cart, patient's cart will do the surgery controlled by the surgeon. So why robotic surgery? It increases the surgeon's capability to operate in a less invasive way. It increases the access of the surgeon to hard to reach access areas inside the body. There are areas in the body where will be very small. So just dream, instead of having your hand go in, probably a 6 millimeter miniaturized hand going inside and then operating like that. So it increases your access. It provides a stable operating field, so steady camera and vision, improved mobility and dexterity. So the robotic instruments are 6 millimeter in size. It's like your wrist, but 6 millimeter size. So it's a miniaturized wrist inside the body doing all your surgeries. So there is greater precision, and there is a fingertip control. Minimizes tremors, therefore less damage to the important structures, nerves, blood vessels, all these things. There is enhanced vision, and the boon for surgeons is the surgeon can sit and operate. So improved ergonomics. So I commonly tell this, why robotic surgery? It makes an average surgeon like me do more complex surgeries better. So that is how. So for the patient, what happens is there is greater surgical precision and therefore better surgical and functional outcomes. There is improved ability to spare healthy tissues that are not impacted by cancer or disease. There is an improved access to hard to reach areas, so increases the scope of surgery. Smaller incisions, lesser scarring, reduced pain, reduced blood loss, reduced post-operative complications, and faster recovery to normal activity. This is more important. Faster recovery to normal activity. And especially in cancer, the patient might require further treatment, some chemotherapy or radiotherapy. So faster return to the further treatment. So I think many of you are, I think all of you are Gen Z. You are going to be the future of the country and the world. So future directions in which I would like you to explore and take it forward. We might probably create a robotic ecosystem where the whole OT is enabled, VR, AR controlled, the operating table moves with the robot, all these things, the scans are all included in the robot, all these things. So hybrid integrated ORs, artificial intelligence, augmented reality, all these goggles and all these things probably in the future. Modular systems, intercompatible systems, smaller systems, more haptic feedback, miniaturized systems, single port systems. Probably you can design probably some of you can become innovators and design new robotic systems where through a small port the robot can go in, and then like the movies, snake arms come and then go and operate. You can probably create all these things. Microbots, microsurgeries, nanobots, no surgeries. Probably inject some nanobots inside your blood vessel. It goes to the area where the cancer is and it operates and comes back in the urine. Probably you can create something like that. Telesurgery is coming up in a long way. We have already demonstrated, the world has demonstrated transatlantic surgeries. In India, we have demonstrated surgery from Delhi to Tamilnadu. We have demonstrated live surgeries. So there is a, to 2024, they demonstrated surgery from Houston, Texas to International Space Station. So probably next is going to be the moon or Mars. Okay. and probably make in India system, robotic assistance with the artificial intelligence, cost reduction and all these things. So those are going to be the future of robotic surgery. And I am going to conclude now. We have a multidisciplinary tumor board at Ph.D. hospitals which decides on the patient's treatment. So take home message: cancer is not a single disease, so no single cause. So treatment is always multidisciplinary and patient centric. Surgery is a small part of cancer care. Surgery is an important part of cancer care, but it's a small part. Robotic surgery is a latest advancement, but it's not the answer to every cancer. Okay. So prevention is better than cure, and early detection and leads to lesser treatment and better results. Thank you.
Thank you, sir. It was amazing section. Now I invite Professor Sarla ma'am of Abirami College of Nursing to kindly present a memento to sir as a token of love.
Thank you.
Now it's lunch. Please proceed and enjoy your meal, and kindly get back by 2 p.m. sharply at the auditorium. Attention please, lunch will be provided as follows: non-veg on the 4th floor and veg counter will be provided in the 3rd floor.
Okay, it can be achieved by therapeutic touch. Okay, so how many staff nurses or how many student nurses are sitting near the patient and asking questions and discussing what is their problem? எத்தனை பேர் பண்றோம்? Put your hand up. Anybody? Only one? Only 1, 2, 3. You are having chair in the ward? You are having chair for staff nurses or student nurses in the ward? Yes? No. But according to one palliative care nurse specialist, that is, in the previous week we had a session with Ms. Shirley Burns, who is a international palliative nurse, who suggested that please sit near the patient. Put a chair. If the management is not going to give you a chair, have your own chair. She suggested like that. That's what I am communicating you, the same. Put a chair, sit near to the patient and ask what they are feeling. What is their need? That is what here palliative care insists. Not on giving injections, but okay, symptomatic pain management, everything is there. But as a nurse, we want to give a personalized care to the patient. Okay. What is personalized care? What is personalized care? It is the care needed by a separate individuals with separate histories. So as a nurse, you should put much more effort to cover them. Okay. So I want to tell you one real incident which happened in our institution that affects us personally and professionally also. One of our neighboring concern professor, she is a good leader, motivator, teacher, very good, very healthy. She went on for a medical checkup also for a month, 1 month before. She went to hospital, a very good corporate hospital, had all the checkups and has nothing as negatives or nothing as a diagnosis. But one fine day, she got a pain in the abdomen. What it was suggested of means some ovarian twist, and they were diagnosed like that. And they were sent to a higher institution in Puducherry for scan and surgery. Okay. She went to the surgery. There they opened and they saw a mass of mucilaginous lesions over the appendix. By opening, they confirmed it is cancer, and they called the oncology team, and they also went remove all the tissues and sent for the testing, and it was diagnosed as stage 4 cancer. Okay, so here he is full of having good habits, no bad habits, no risk factors, no genetic risk factors also involved, but she had without any symptoms. She has been suffering with stage 4 cancer, and our healthcare professionals has told you will be there only for 6 months or 1 year. So you be happy. You said all the whatever you want to do or whatever you want to tell everything like that from a very good higher institution of one of our from our place. Okay. But after that, now she recovered, she is in chemotherapy, that is all different story. How they approach that one different person, very close person to our institution. She was really fed up. She was closed, chapter is closed, like that she was thinking. So here what is lacking means the personalized care is lacking. Even she is in chemotherapy, she said she is from engineering field. She is very good in all using of AI tools. She fed all her history in AI, and she will tell all the symptoms whatever she is suffering because of chemo and all to AI and getting suggestion. For example, to prevent vomiting, what is the position to be acquired? Okay, this is what the nurses should do. Want to have a personalized care to each and everyone where they are attending. Okay. So, palliative care is very, very important. It is not only for the end of life care, it is starting where the disease is severe. Okay, and it is continued till the hospice. I will tell you the difference between palliative and hospice in the following slides. Okay, so here it is not the quantity of days, it is the quality of days. It can be provided only by the healthcare professionals. Okay, and adding life to days, not just days to life. Okay, what is that? Adding life to the days. So whatever life they are living, make them happy. Play a music they like. Arrange a prayer meeting. That is all it consists of. Okay. Then palliative care never saying there is nothing we can do. There is always something we can do. Okay. These are all the concepts. So as a nurses in palliative care, nurses can perform something for the benefit of the patient. This is the concepts of palliative care. Okay. Why we need palliative care? From the morning everybody was talking, cancer burden is growing. The same thing I want to tell you. It is the 14.6 lakh cases in 2022 to 15.7 lakh cases increased by the year of 2025. And common cancers in men are, what are the common cancers in men? Oral cancer and lung cancer, and in children it is lymphoid leukemia, and in women breast and cervical cancer. You see the incidence, that is 1 in 29. If there are 30 women, 29 women, there will be one who may have breast cancer or cervical cancer. Okay, this is the vast burden of cancer, and you see the unique burden. 1.6 million cases projection is by 2025 is there. Prime age group is 40 to 64 years, and lifetime risk, the Indian has 1 in 9 to 10 Indian has lifetime risk of developing cancer. See about palliative care, again you see 58.7 million people needs palliative care. Okay, from that 78% is living in low and middle income countries. In that 98% are children, and only 14% receives palliative care. Only 14% receives palliative care. Remaining all 86% are the people who need palliative care, but they didn't receive anything about it. See about in India, Pallium India in the year 2023 reports, people need care annually is 7 to 10 million. People receiving care is only 4%. India has recognized only 4 palliative care centers. Okay, and not able to reach within 30 minutes or 28.7 million people. Okay. So importance of palliative care, you see, palliative care is not only the end of life, it is should begin early and continue alongside of the curative treatment to ensure the possible best quality of life. Okay, you see the graph, you can very well understand. When the curative care starts, palliative care is also started, and they are given treatment. Palliative care is also provided, and finally they are ending with hospice care and peaceful death. So palliative care should start aligned with the curative care. It's very, very important. So next we will move on to the multidimensional need of palliative care. Why we need palliative care? Because first one is in palliative care, before only I told you an example, every person needs the individualized patient care. So, okay, for example, anyone suffering with severe illness, they receive they want to have the health care in a different manner. So, individualized patient care is needed. Support for the family and support from the family is needed. Okay. So, whenever a patient is sick, here the family also need to be supported. And interdisciplinary teamwork is needed in palliative care. It is not a single that can provide everything. A team should make a change, and trust is needed. Trust should be developed in palliative care, and safety considerations are very, very important. And effective communication is needed in palliative care. We will discuss about effective communication and the skills of palliative care nurses in the following slide. Okay. So next we'll see about the benefits of palliative care. So what is benefits of palliative care? I told you, whenever we are going to start that is curative care, palliative care also, it is started aligned with that. You see, we can have the advanced care planning. Okay, so according to the need of the patient, the care planning can be done priorly, and they can be given the care accordingly, so that the patient can have the increased coping. So coping level of the patient will be increased with the help of palliative care, and their quality of life will be increased, as we said in the concepts, and relief of suffering and symptoms will be there, and enhancement of human dignity. Yes, dignity is the word very, very important in palliative care. The patient should be treated with dignity. Not only the patient, the family members should be treated with the human dignity, and there is a effective closure in the palliative care. So these are all the benefits of palliative care. So now we will see on the types of palliative care. So types of palliative care we can classify based upon the stage of illness, the place where we are going to give the care, and also the level of care. Okay, so in stages of illness, it is early palliative care and end of life care. Okay, it also includes the end of life care. We can classify according to the level of illness, the palliative care can be classified. And according to the places, we can say it is hospital-based palliative care, home-based palliative care, and hospice care. Okay. Our institution, we have MOU with one, I told you, it is a Sanjeevan palliative care. Actually, no, we will go, every month we will go to the community visit. First, we identify all the bedridden patients for the palliative care. Okay. Then after identification of them, we will make the caregivers, we will advise the caregivers to take care of them. And every week we will visit them. Periodically we will visit. We cannot visit everyone all the days. Okay. Periodically we will visit, and we will give advices and take care of the patient. And caregivers, we will make the caregivers understand about the procedure, and also take care of the that is patient in the good manner. That is home-based palliative care, and hospice care is the end-of-life care. And next is palliative care is classified into primary, secondary, and tertiary palliative care. Primary is at the initial level, secondary is at curative level, tertiary is at the hospice level. So like this we can classify the palliative care. Next we go to the principles of palliative care. So before itself I told you, it is the quality rather than the quantity of life. So whatever life they are going to have, we want to give a quality life than the quantity of life. Okay, that is, they should have a good food and then beddings and hygiene. Everything should be provided, and whatever they like, we can provide them with the help of any assistive devices. Okay. Next is, life is affirming, but death is accepting. So you are making the life better with the fact that the death is going to come. What does that mean? You are going to make the life peaceful and happy for that little time. Okay. And effective communication at all the levels. Okay, it's very much needed. And following slides also I'm having for effective communication. I will tell you there. Respect for autonomy and choices. So here the nurses or healthcare professionals, they should give the respect for the independence and choices of even treatment. If at all, if any patient undergoing cancer treatment, chemotherapy, if a doctor is prescribing after finishing chemotherapy, you want to have a targeted therapy. Like that, when a doctor is saying, a patient himself or herself, otherwise a family themselves can have the choice of having the treatment or not having the treatment. Because we know very well, this cancer therapy medications are very, very costly. Many of this society people cannot afford whatever the price also. Okay. Here they can have the choices of getting the treatment also, and they can be very well informed about the benefits and also the disadvantages of any therapy they are going to get. Okay. Then effective symptom management, that is what, especially pain management, and holistic multi-dimensional approach. Okay. So here palliative care involves all the healthcare professionals at all domains, like nutritionists, dentists, physicians, and healthcare workers, sociologists, psychologists, like that, and caring about the person and those who matter to that person, and also carrying the family members. So palliative care gives focus to the family members also. Next we'll go to the domains of palliative care. So domains of palliative care, already I told, physically, psychologically, socially, spiritually, the patient should be taken care of. For example, physically, when they have some symptoms, the symptoms should be treated, nursing care should be provided accordingly. For example, pain, dyspnea, etc. Psychological, when the patient is having anxiety, fear, it should be managed socially. Financial things, we can refer some government schemes, otherwise government hospitals, and family aspects you can give guidance. Legal aspects also, the guidance can be provided. And spiritually, we can give the hope and see why me. You can give the concept of being holistic. Okay. So the domains of palliative care is physical, psychologically, socially, spiritually, the patient should be taken care of. So now we will come to the key roles of nurses in palliative care. There are 8 salient points. We will discuss one by one. So one is assessment of pain and symptoms, good communication, administration of medication, psychological support, family education, coordination with multidisciplinary team, advocacy for patient dignity and comfort, and nurses as various roles, caregivers, counselors, educators, and patient advocates. One by one we will discuss on those things. The first one is assessment of pain and symptoms. Okay, so you all know very well because from the morning there have been classes on cancers. First is assessing the physical symptoms in serious illness of cancer: pain, nausea and vomiting, breathlessness, fatigue, loss of appetite. Okay, so first nurse's role is to assess the physical symptoms. Okay, how far they are suffering with the physical illness, you want to monitor that. Then that includes severity, frequency, and impact on daily life. How severely they are vomiting, what is the impact on the daily life. These are all to be assessed in the symptoms. Okay. Next you go on to the psychological status. In the psychological status, as a nurse, you want to measure the anxiety, depression, fear of death, pain, anger or denial, feeling of hopelessness, and social isolation. So psychological aspects also, the nurses do assessment and care of the psychological feelings. Okay. And next, when you see about the social needs, okay, whenever we are talking about the psychological aspects, we want to tell some important things. Our society still considers cancer as a stigma, cancer as a sin. Okay, you see, it is a past sin, it is a bad character, it is contagious. There are so many myths and psychological beliefs regarding cancer. Okay, you see, it is a taboos, so that they are hiding the diagnosis because of fear of marital life and also fear of abandonment. Okay, so these are the things which even occurs now. So when we assess psychologically, we want to convey the myths and facts about the cancer to the people. So under the psychological status, you also assess the mood, behavior. You ask facial expression, you ask simple questions. Are you worried? Are you sad? Have active listening skills. You listen to the patients and know their worries. Okay. And assess the sleep pattern, appetite changes, and identify the symptoms of severe depression and also the suicidal thoughts. Okay. Next is about the social needs. Okay. Every family is getting enough support for a palliative care. Every family is getting enough support for the palliative care. Yes or no? Yes or no? If every family, any elderly or any cancer patient suffering bedridden, they are given total holistic care by the family members? No, isn't it? No, yes or no, ma? No. Okay, so first we want to know about the family support and caregiver availability. Okay, no, in many families there is no caregivers at the end of the stage. And know about the financial assistance, help with the daily activities, and know about social interaction. You avoid the isolation, tell the access to the healthcare services, and support for the dependents, that is children, elderly who are depending the patients also be given support. You see, I want to show you this picture. See what this picture depicts. Can anyone tell me? Women, power and cancer. The double burden, prioritizing everyone else's health over her own. What does it picture indicates? What does it picture indicates? This is the status of the women in India, isn't it? What is this? What does it indicates? What the picture shows? One hand she is having. One hand she is having. Enna vechirukanga? Baby, say one hand she is having, taking care of baby. Other hand? Other hand? Medical report. You see the medical report. And then she is cooking, prioritizing everyone's health than her own. That is the status of the women in our society. Okay. So they are prioritizing the family members. This is happening in the society. See, when we have seen a case which has been admitted to Jigmar with colon cancer, a lady around 40 years old. Okay. Husband doesn't taken care of that lady and she doesn't came for follow-up. Okay. She went for one checkup. Other time she doesn't came for follow-up. When we asked her mother-in-law, she said again for the treatment. And then she asked one question, when she will come back to cook food like that. Okay, that is what happening in our society. So that is all to be addressed whenever you are taking care of a patient in the palliative care stage. Okay. See, next one is financial toxicity. We all are telling government is giving treatment. You see, it is the indirect cost. Travel, food often exceeds the medicine cost than the whatever medicine they are getting, the cost will be more because they want to travel from their own house to the hospital. They want to get food for that day. Like that, the cost is very, very more than the medicine cost. But you know, cancer drugs are very costly. Some of the drugs will not be provided in the government setup also. See this one picture I want to show you how there is lost to follow up of the cancer patients. What is this, ma? What is this? Bucket of water with so many number of holes. What are the holes you see? What is the first hole? It is miscommunication. Due to miscommunication, there so many are doesn't getting followed up. That is 22%. And see, logistic barriers 16%. Lack of social support 32%, and financial distress is around 20 to 22%. So averagely, it is about the cancer patients in Puducherry. They lost follow-up. It is 25% to 38% of the cancer patients are not coming for follow-up due to these reasons. Okay. Yes. Okay, ma. So this is all the things when you want to assist psychologically, you want to know of. Then you go for the social needs. Involves the family in care and tell them about the government schemes and funds, financial aids available. Refer to the social worker, support groups available. Encourage social interaction. Coordinate community-based services. See, in some area, there will be the patients, but they don't know where to go for a palliative care or hospice care like that. Okay, for example, in our area itself, one adult patient only, but tracheostomy, he was been in the house, but suddenly the tracheostomy tube comes out. He don't know what to do for. Okay. So like that, so many are left without their care. Okay. So the proper advocacy should be given for the one who is suffering a lot. Next you go for the spiritual concerns. In spiritual concerns, you can question about the meaning of life or suffering, and then fear of death or afterlife, loss of hope or purpose of the life, desire for religious rituals. We want to ask whether they have any wishes to pray for or prayer meeting. All those things can be asked. And need for forgiveness or reconciliation. So these are the things to be addressed when you are going to address spiritually. Okay. So in spiritual concerns, as a healthcare professional, what you can do? Provide the emotional and spiritual support and respect the patient's beliefs and values. Facilitate access to spiritual care providers. For example, anyone who is there for them, particularly priest or any chaplains, you can have a facilitation for them. Encourage the hope and meaningful making. Include the family in spiritual practices if needed. So these are in spiritual considerations. Okay. So these are all under the assessments. The healthcare profession nurses should do when we consider the palliative care. Next is about the good communication. Here under good communication, active listening should be done. Pay attention. Acknowledge the feeling. Okay, sit with the patient. Know their feelings. That is what first one to be done. Have a clarity and honesty. Use simple language. Be truthful to them. And empathy and compassion. Understand and validate emotions. And have a non-verbal cues. Okay, this is all you know very well. See, nurses communication tools, 3T approach. One is trust. Okay, so establish trust. Acknowledge the fear. Build the rapport. Okay, and then truth gradients. Share the news in small steps. And then third one is tools. Use the pictorial tools and guides to give the message to the patients. So here I want to say you the framework for uncertainty and a consent. Okay. What is a, just putting a signature is not a true consent. Explain properly what is there, what is for the patient, and get the validated signature. That is very much important for the communication. So in the framework for uncertainty, when the best case is what means when the treatment works well and there is a good quality of life, that is best case. And worst case means the treatment doesn't work and there is only focus on comfort. And most likely when there is a balance, honest, compassionate middle path, we will say that as a most likely framework. Under the framework we will classify under most likely. So whenever a nurse should get a consent, get a true consent. So as a nurse, early detection is equal to easier journey. Okay. So whenever there is an early stage of cancer, stage 1 to 2, there is a less aggressive treatment, lower cost and high survival chances. When it is a late stage, stage 3 to 4, aggressive treatment should be there, high cost treatment and also lower survival chance. See, nurse's role is there in bursting myths. So what is a myth? Cancer is a death sentence. Is it like that? No. What is a fact? Everyone can tell. What is a fact? Please, everyone can tell. What is a fact? Many cancers are curable if it is caught early. So second myth, surgery spreads cancer. Whenever a doctor removes a tumor or anything, okay, it is going to spread the cancer. What is the fact, ma? Read the fact. What is the fact? Read the fact, students. Surgery removes the tumor. All of you repeat. What is the fact number 2? But at the last, no one is repeating. Till you are repeating, we will be in this slide only. Okay, what is the second fact? Okay, surgery removes the tumor, it does not spread it. Okay, third myth, chemo is unbearable. What is the fact? Supportive drugs manage the side effects well. And myth, last one is it is a karma. So it is not a karma. Cancer is a biological disease. It is not a punishment. So as a nurse, you want to bust out all the myths and spread the fact among the people. Okay, next is administration of medication. So here no, I want to skip and net connect ahuma. Net connect ahuma. Okay. I want to show you some caregivers procedure before going to next slides. YouTube. Okay. Pinadi YouTube. Thanks. Last slides. Slide. Okay, open. I want to show caregivers procedure which has been published by Karnasharya Palliative Care Center, Bangalore. My friend Mrs. Sangeeta, she is nurse in charge of the Karnasharya Hospital Center. She has sent me these videos to spread to our students and make them know about these videos. Okay, so in between we can have some videos. Okay, so instead of saying tell this, tell that, okay, to see some videos how to give a basic how the caregiver should be given knowledge about this procedures. Yes. So there are 17 videos in this link. Okay, I will share this link to your organizing peoples. They are having already in my slide. So you can use this for your community area people, wherever there a patient is bedridden, the caregivers can get the knowledge how to take care of the patient at the home itself. Okay. See, this is on catheter care. Play. Voice It is without sound only. Just listen. This is an animated video on back care. Sorry, what is this? Catheter care.
You're doing wonderful, Lakshmi. This is an important part of Ama's comfort. Catheter care. It prevents infection and helps us stay clean, dry and dignified. First, always wash hands well with soap and running water. Dry with a clean towel. Then wear your gloves and mask. This keeps Ama safe from infection. Before touching the catheter, check if the urine is flowing freely. See that the tube isn't bent or twisted. Let's start with cleaning. We call perineal care. And odor. Place a waterproof sheet under the buttocks. Help her turn slightly to the side. Use warm water or mild soap. Always clean from front to back, never the other way. That's how we stop germs from entering the urinary passage. Now clean around the catheter site, from near the body to all the way. Use a fresh swab each time. Never pull or twist the catheter. Like this, sister? Yes, perfect. After cleaning, dry gently with a soft towel. Now check if the bag is full. We empty it when it's about 3/4 full. Always keep the bag below the bladder and never on the floor. Once done, remove gloves, wash hands again and make Amma comfortable. For men, it's the same, just a little different in cleaning. Start from the tip of the penis. Clean gently outward, 1 cotton for each stroke. Clean around where the catheter enters, from the body outward. Dry carefully.
So the sound, it is not audible for you. See, we have so many number of procedures under this. Back care, colostomy management, end of life care, self care, like that. We have 16 to 17 animated videos. Okay. In the home itself, the caregiver can know the procedure and they can give the care accordingly. As a nursing student, I will play you 1 or 2 videos so that you can get idea. Then we will continue on the remaining slides. So 5 minutes more. Okay, time is going short, so we will complete it within 5 to 7 minutes. Okay, you see on one video, we will complete with all of the slides. Go through and we'll. So one video. Anything? Colostomy management. You see to that video, colostomy management. How many minutes? 2-3 minutes.
10 minutes. Back here to back here.
So okay. so வருதா?
With a small bag on her abdomen, a colostomy bag. For Priya, her daughter, it was all new, frightening and unknown.
Nurse, I'm scared to touch this bag and I might hurt her while cleaning. I've never seen anything like this before. Don't worry, Priya. This bag may look unfamiliar, but it's what's helping your mother live comfortably. I'll show you everything, step by step. This soap here is called the stoma. It's pink, soft and moist. That means it's healthy. If it ever looks blue, black or too pale, that's when we call the doctor. We'll first remove the old pouch and clean around the area. Always be gentle. Remember to wash your hands before and after changing your pouch. Don't pull. Push the skin away instead. Now wash gently with warm water, saline or mild betadine. Pat dry, don't rub. The skin around the stoma should look just like normal skin. Sometimes it looks red and that's stomal irritation. It can happen if stool touches the skin or if the pouch doesn't fit well. We'll use a barrier cream or powder. Even karaya powder with egg white helps heal it quickly. Otherwise, you can use the ointment as directed by your doctor. Now we'll prepare the new pouch. The opening should be just a little, about 3 millimeters, bigger than the stoma. This prevents leakage and skin injury. Empty the pouch when it's 1/3 full. For reusable ones, wash with mild soap and dry in shade. It's not as scary as I thought. See? You're understanding well.
okay, like this we have 16 videos. I'll share the link so that you can share it to your caregivers in the community wherever they are taking care of any bedridden patients. Okay? Otherwise, it can be taken as an education video also for us also. Okay? So, okay. Next. So, as the nurses, I told you we have 8 salient points. So, emotional and psychological support should be given. Administration of medications, as usual, you want to follow all 5 R's in giving the medication. Next. And so emotional psychological support should be given in proper manner. Next. And then this is also a picture which is taken in the community area where the family members are involved in giving a palliative care to a patient here. The one sitting also suffering with some disease, and the one in the bed also, they are bedridden. So like this only the situation occur in the community. So patient and family education should be given according to their needs. Next. Okay. So next. So coordination with multidisciplinary team. I told you we want to have the several members for the palliative care. Next. And advocacy for patient dignity and comfort. Dignity is the word which is very, very important. I told you before itself. It should be followed throughout the process. See autonomy, give confidentiality, maintain dignity and promote the comfort. Okay, next. Next. What is the next? So nurses here act as caregivers, counselors, educator and patient advocate. Okay. Yes, next. So here qualities of palliative care nurses. See, compassion and empathy, good communication, clinical competence, teamwork, and emotional stability. So these many times I repeated before also how the nurse should be in giving the care. So these are the qualities where a palliative nurse should follow whenever providing care to the patients with the in the end of the life. And I want to say you, next you go next. I want to say you what is the difference between hospice and palliative. Hospice care is a care which is also given for symptom alleviation, that is symptom management, but it is for the patient with terminal illness. That is, they will be having only period or less than 6 months they will be alive. For that patients when the care is given, that is termed as hospice care. Okay. Next. So the same qualities to be maintained as palliative care in the hospice care also. Next you go. Next. So you see, hospice care versus palliative care. So hospice care is pain and symptom management when they have the terminal diagnosis of life expectancy less than 6 months, not seeking the curative treatment. But in palliative, there is curative treatment also there. Patient may not be terminal, may be still seeking disease-directed treatment. Okay, next. So, we are all want to remind, caring goes beyond curing. That is the main concept of palliative care. Next one. So, take home message. Quality of life matters at every stage of illness. Palliative care is not just end of life care. It can begin early. Relief from pain and suffering is a basic human right. And holistic care, it should include physical, emotional, social, spiritual support. Okay? And supporting the patient means supporting the family too. Next. So, this is the one link I told you about Karna Sharia Hospice Trust and their procedures. It is in the slide I shared with your team. You can get it. Okay. My sincere gratitude to Sanjeevan Palliative Care and Karna Sharia for their support and their materials which we presented in this presentation. And I would like to express my sincere gratitude to each and every one of this hall to be cooperative for the presentation. And I'll end up with the quote, together we will make some differences. Thank you all.
Thank you, ma'am, for such an insightful and engaging section. Now I invite Professor Rajeshwari ma'am to present a memento to ma'am as a token of love. Thank you, ma'ams. It is my great privilege and immense pleasure to welcome Professor Dr. Mudaliyappan, sir, a remarkable individual whose dedication, knowledge and leadership has significantly contributed to the field of nursing education and community health. He has completed his Ph.D. nursing from Himalayan University, marking a significant milestone in his academic journey. He earned his Master of Science in Nursing, Community Health Nursing from Oxford College of Nursing and his Bachelor of Science in the Vinayagar Mission, Annapurna College of Nursing. A journey of dedication and leadership with over decades of rich experience, Sir has served in various prestigious roles. Currently, he is serving as a principal of Sacred Heart College of Nursing, Bangalore. Prior to this, he held the position of principal at Saurabha Institution of Nursing Science and has served as a professor at Shanti Dhamma College of Nursing. His contribution extends beyond teaching. He has served as an examiner of both undergraduate and postgraduate program under the Rajiv Gandhi University. Organized numerous impactful workshops and community health innovatives. Lead awareness program on AIDS, mental health and diabetic care. Successfully organized the prestigious Florence Nightingale Award event in 2023 to 24. His passion for community reflects in his research work focusing on community health, diabetic education and school health programs. He has actively participated in both national and international conferences, contributing to an advance of nursing education and healthcare practitioners. Known for his exceptional problem-solving abilities, excellent communication skills and an innovative mindset, he is not just a leader, but a true inspiration to students and colleagues alike. On behalf of everyone present here, I extend a heartfelt and warm welcome to Professor Dr. Mudaliyappan Sir to start this section on risk reduction and cancer prevention across the lifespan. May I now invite Dr. Arvind Babu Sir to welcome our speaker with a flower bouquet.
Thank you, ma'am, for the warm welcome. Good afternoon, students. Very good. Energy is there still. Okay. Good afternoon, my dear friends. And I thank the management, the principal, the organizer of the Sree Abirami College of Nursing for giving this opportunity to present the topic today. So the topic is given to me is the risk reduction and cancer prevention across the lifespan. So from the morning we were seeing about the cancer. What is cancer? The incidence, the signs and symptoms, the diagnostic evaluation and the surgeries, the palliative care, everything. So as a nurses, so what is our role in this? So while seeing the topic, so actually I felt that the topic is apt for me because I am from community department. So I think this will be helpful because the government is initiated the home visiting. Am I right? Community study, no? Home visiting, primary health care. Yes or no? Started sleeping. Okay. So because so most of the people they cannot, so already they were talking about the feasibility, the money, the economic is very, very important. So most of the diseases, whatever it is, we learned. So what we learned, it is prevention is better than cure. Yes? Prevention is. So the prevention, how we can do that is through the risk reduction. Next slide. So today we will learn at the end of the session. So I will be learning about the cancer and risk reduction and prevention and identify the major cancer risk factors and explain cancer prevention strategies across different life stages and describe the role of nurse in cancer prevention and promote healthy lifestyle behavior to reduce cancer risk. Next. So the introduction already we have seen from morning, the same, it may be repeated, some of the things. So the cancer is the major global health problem. So all over the world it is there. And the many cancers are preventable. Focus on reducing exposure to the risk factors. So most of the diseases are preventable. So because we studied all the risk factors, so how the disease comes? There is exposure to certain things. If we avoid the exposures, so what we can do? We can avoid the diseases. The nursing role. So mostly in the hospitals, what we'll do, we'll be giving care to the sick people. So we'll move on to from sick care to the well care. So what is the well care? So we'll be giving care to the well people. What type of care we will give? So this is, we'll give the health education. or the screening process, what we can do this. So before the disease arises, we have to prevent the diseases. That is called well care. After the disease gets, then started to curing the disease. Instead of that, we have to prevent the disease before the disease occur. The nurses play the key role in the education, screening and early detection. So as madam said, at the last stage, so they went to all the screening and everything. Finally, when they come to know the disease, it is the fourth stage. So fourth stage we cannot do anything. So the early detection is very, very important. This is especially in the medical profession, especially in our nurses' hand, it is there. So when we not diagnose properly, what happened? The patient is sufferer. So as a medical profession, we are in this field, we should know what type of the disease is there, how we will diagnose this. So we study in the, when you are college, during the classes, we study the differential diagnosis. The headache will be there, headache is a one common problem. But we had lot of diseases, most of the signs and symptoms only have headache. Like nausea, vomiting, pain, everything is the symptoms, but this will be common to most of the diseases. So we should identify the difference between the why the pain is there, why the symptoms is there. We have to find that the differential diagnosis we will be studying, we have to identify that. Then the carcinogenesis, the cancer is often multi-decade, it's not come in within a day. Yesterday I went for some park, I drink some water or juice, so because I got this disease. So we cannot say within one day or within a 1 week, within a month. If you want to detect the cancer before 10 years or before the minimum 1 decade, it started growing in your body. It's not come in within an hour, within a day, within a week or within a month, within a year. It's a decade disease. So we should know about the prevention and the risk reduction and how to screen, how to educate the people, everything we should know. Next slide. So cancer we studied in the morning, so there is an uncontrolled cell growth and the ability to invade the surrounding tissues and the potential spread to other organs is a metastasis, and most of the common cancers are breast, lung, cervical and colorectal and prostate. This already we have seen that in the morning classes. Next. So my topic is the major risk factors. So reduction of the risk factor and prevention all throughout the life. So here the major risk factors, mainly we can divide the risk factors into two types. One is modifiable risk factor, another one is the non-modifiable risk factors. The non-modifiable risk factors are age, genetics, family history and gender. This you cannot change. But some of the things we can change, that is in our hand, that is a modifiable factor, like tobacco use, alcohol and unhealthy diet, obesity and infections. So see this risk of cancers, mostly these are all these will come. So the genetics that we cannot change, the environment where we live. I don't have habit of smoking, but my friends will smoke. But if you are staying in the same surrounding, even if you are not smoking, you will be a passive smoker, you will get more chance of him to get the cancer. I don't have any good habit. So madam said she don't have any good habit, everything. She may not have that or he may not have that, but the surrounding, the environment, that makes you to get the exposure to the certain things. So be aware of your environment, where you are. So based on that only you will be getting this. Next previous slide. The chronic inflammation, so the food pattern or any peptic ulcer, something like that is there, you will get it then, recent exposure. So when you go to any hospital for other person, maybe my family members to exposure, X-ray or CT or MRI, anything, if you go along with them, not only they exposure, we also will exposure to so you should avoid that. Then cosmetics, nowadays without cosmetics no one is there, from the lipstick to eyeliner, makeup, foundation, everything. So that all leads to cancer. Next, poor gut health and metabolism and stress. Nowadays everybody is living in the stressful situation. Then alcohol and obesity, these are all the major risk factors for the cancer. Next slide. Next, the tobacco and cancer. So the tobacco is the major cause for the death. So especially the leading preventable cause was 30% of the deaths caused through the tobacco cancer. It is associated with the lung and oral, throat, bladder and pancreatic cancers. The prevention, how we can do cessation of program. So we cannot do anything. So first we have to stop the smoking. Other any tobacco like pan and some other things are there. No? So this all nowadays the cool lip. So many are there. So especially the boys, even it is found in the North Indians than compared to the South Indians. So this can be avoided, and public awareness we have to create. So the situations where you are, even if you are not using that, if you are surrounding the areas, so as it is the passive smoker. So if you are there, you will get the chance for getting it. Then you have to give the counseling how you can do all those things. Next, the diet and cancer. So diet also causes cancer. I am eating good food. I am eating something. You can say that I am not. So we don't have any bad habit. No tobacco, no smoking, no drinking. But still, some people have cancer. Am I right? Yes or no? So we say that he is a total teetotaler, all those things, you will hear that. But he will have the diseases. Why? This is the food habit. So what are the food habits? The diet, what diet, carcinogenic diet. Nowadays what we as previous teachers told about the pesticides and other things. So everything, the crops which we create, so everything, so we want more yielding. So we use the pesticides. Through that also we'll get the carcinogenic foods, and other is the high processed foods, then red meat, lower fiber like the fries, pizza, burger, okay, all those things, all the Western culture foods. If you started eating, then we will get the diseases. So how can we avoid this? This is by using the protective foods like fruits, vegetables, and whole grains, fiber-rich food, okay, fruits, vegetables, all those things. That if you take that, you can be avoiding the cancers. Next, the physical activity. So physical sedentary workers, as already previous the morning, the FILA madam, so all teachers are sitting, are standing, and students are sitting. So the mostly all the official work, okay, we people are getting this sedentary. We are called sedentary workers. Without doing work, will be eating too much, ordering and parties, everything. Okay, so this physical activity is very, very important to improve this reduce the obesity and improve the immune function and reduce the risk of breast, colon and endometrial cancer. This is a recommendation of 30 minutes of moderate activity daily. So as modern terms of 150 minutes per week. So at least 5 days, Monday to Friday, 30 minutes each day. If you walk, brisk walk for 5 days, so 150 minutes you can cover. So you can reduce the risk of cancer. So no need of going to hospital, taking treatment, this one chronic, this one chemotherapy, radiation therapy, surgery. This all can be avoided in the future. You can save the money also. Only by walking. This is a risk reduction. Next. Then alcohol and cancer risks. So this alcohol is increasing the liver and breast and oral esophageal cancers. So how can we prevent? We can limit the intake and promote the awareness to the public people how to reduce how the cancer caused through this alcoholism. So we can cease the alcoholism. Next. Next, infection linked to cancer. Certain infections in our body that creates a cancer. So already whatever we have this HPV. So the human papilloviruses that cause the cervical cancer, especially in the older adults. So in the hepatitis B and C is the liver cancer will be there, then H. pylori, so stomach cancer will come, and then prevention. So the vaccination is there for all. HPV also vaccine is there, hepatitis B, C vaccine is there, and H. pylori also. So all through the vaccines and we can prevent this. And safe practices. When you give the most of the nurses, we are working in the clinical. So needle prick injury. Yes or no? Do you have the experience of needle prick injury? So that's what in the initial, the first year itself, we will having the hepatitis injection. So before go to the hospital, as soon as you are laminating, so before send you the clinical postings, we will be giving the hepatitis vaccine. Then we will send to the hospitals to avoid the needle prick injury, to cross infection, nosocomial infection, and to avoid this hepatitis B. Okay, so all those things will be doing that. Then the early treatment, these are the things we can prevent. Next. The vaccination for cancer prevention. So the important vaccine is HPV vaccine. So this HPV vaccines for the cervical cancers, so recommended for adolescents. This is the age group between the 9 to 14 years, between the adolescent period. there will be a 2 dose or 3 doses depend upon that. Then the government now introduced in India also, as madam told previously. So 1,000 rupees like one vaccine, we can get it through the government subsidy. So through the primary health center, all the young girls before they get married or before have the sexual contact, so before that they will be having these injections. So like that it will be the HPV vaccines. So that's recommended for the age adolescents group. So between the age group 9 to 14 years, and the hepatitis B vaccine, that is to prevent the liver cancer. Next. So when come to this, these are the risk factors till now what we have seen. So next we move on to the prevention, how we can prevent. So all of you know that there are 3 levels of prevention there. What are the 3 levels? Primary prevention, secondary prevention, and tertiary. These are the 3 levels of primary prevention. That is the primary level. Our main goal is prevent the disease before it occurs. So main goal is prevent the disease before it occurs. That is our main goal. So instead of after getting the diseases, then going to hospital, finding, then not finding, okay, there's no proper diagnostic tools, or not, the doctors not diagnosed properly, no proper treatment, then going to the last stage. Instead of that, prevention is very, very important. So primary goal. So the goal is the prevention disease. So how can do through the immunization and smoking cessation and sun safety. Mostly some of the diseases in the childhood, you will get sunburn. Okay, also madam, you know, sun protection, SPF above 30. So we have to use sunscreen lotions, all those things. This all we can do by to do the primary prevention. And go to the next, secondary prevention. It's a yearly detection in asymptomatic patients. So early detection is very important. So not at the last stage, 4th stage, because it is at last 10 years or 15 years it will be there in our body. Then only the symptoms will start to spread. So what we can do here, the early detection is very, very important. So how we will do early? I don't have any problem. Then why I have to go to hospital? Why I have to spend money? Especially in the village side, we have to, doctor will say something for getting money. Why I have to go? Doctor gamagonu velalla, nasugonu velalla. Chuma kaasu pradum solranga. Yes or no? But as a nurses, as a health professionals, we should teach them. We should educate the people why we have to do. At least every 2 years or every 3 years, we should go some health checkup, master health checkup or some screening. If you do that, then you will come to know the cholesterol level, diabetic level, okay, any other infections, what you have that, everything you come to know that. Early detection is very important than suffering later. So here what you can do, especially in the women's, we have to do the mammograms and colonoscopies and pap smears we have to do at the after 40 years, every 2 years or 3 years, once we have to do this test. Then come to the tertiary level of prevention. Here the prevent the complications recurrence as a palliative care. So the tertiary care, the rehabilitation after the chemotherapy, radiation, surgical, all the treatment is over. The patient is sent to home for the palliative care or any other rehabilitation. So in the rehabilitation, what you do, the reoccurrence we can avoid it. So if you give proper care, so as my known student, okay, they are studying in the one of our college. So she was in the second year. She was diagnosed as a cancer. She taken the chemotherapy, everything. But last in the final year, she is completely cured and she completed the course when without any signs and symptoms. So like that, some people are there. Some people are go within 6 months, they die also. This is all how you take care of, how you believe. So mostly the things, so the psychological feelings that will affect you. Suppose you see the child walking on the road, the child will fall down. After get down, it will see surroundings. Anybody seeing us? No one is see. What they will do? The child just clean their dress, it started to walking. But somebody started, oh, what happened? Ooh, started to crying. Yes or no? Am I right? Because no one is see there, I am all right. If somebody see, I need the care and attention seeking. Started to crying and rolled more, oh, I cannot walk. Then somebody's mother has to carry the child. Am I right? Yes or no? Attention seeking behaviors. So this all will be there. So this is same like the psychological feeling. So you have to same like that. My mother, so she suffered from Guillain-Barré syndrome. She was admitted in the Nimmans hospital, but along with that more than 20-25 other patients are admitted. But no one is cured. But she is cured now, completely cured from the disease. She is doing how she was previously, same like that. Past 6 months she was not doing, she was in the hospital. We have given the proper care. She had the will power. I can come back, I can walk, I can go to my native. Like this she felt that now she is doing as a normal, how she was before get the disease, same like that she is working. But still I have seen most of the people in the rehabilitation center after getting the Guillain-Barré syndrome. So this is the what I want to say, that the psychological feeling what we feel. We should have that, yes, I can. So nothing is impossible. Understand? Everything is possible. In impossible, so there is a possible word is there. So all can do, everything is our mindset. So think it, so yes, I can do, I can get cured from the disease, then automatically, definitely you get cured. So whatever we feel, that will happen. This is called manifestation. Understood? Do you hear about the manifestation? I will become doctor, I will become doctor, I will become doctor. If you say, definitely one day you will become doctor. If not become MBBS or MS, at least you become Ph.D. doctor, like me. Understand? My dream will be there. I want to be doctor, but we cannot be doctor. So because of the parents' situation and other things, or the economical something, now somehow we studied, we converted Ph.D., now I am doctor. I am also doctor, like that. Now I made my daughter become doctor. She is studying first year MBBS in Bangalore. So my dream I put into my child. So something we have to dream. So what the dream has to come one day. Okay. Next. The risk reduction. So through the lifespan, how we can do that? From the childhood to till you become old. How can we prevent this cancers? The pediatrics, the adolescents, the 0 to 18 years, what we can do? Mainly we can do this HPV vaccines at the starting age of 9 to 12 years. The sun safety, this is sunburn I told you, no? The sunburn, this will be like this. So if the, so see the village side mostly, the tropical regions, because of the hot and everything, they will not even wear the shirt. Okay. Have you seen the people when you go community posting? The children, only with the trouser or sometimes without trouser, all they will be roaming here and there, playing in the mud, full hot sun, burn, full dark black, like me. Yes? So this all will happen. This is the sun protection. So that also leads to cancer. So this can be avoided. So we have to give them proper protection through the sun. Then the second hand smoke education for sometimes the parents will be chain smoker. He will be having the child with them. The child may not know anything. She want to be with the father or she want to be with the relatives. But through that the child also will have the cancer. So this can be avoided in the early childhood. So how can we prevent this? First, healthy nutrition we have to provide. For our children we have to provide the healthy nutrition and physical activities. We have to make the children to go and play like this, then avoid exposure to tobacco smoke as I told previously, then vaccinations, then sun protections. So the role of parents and healthcare is very important. The parents is the main person here to protect the children. As well as when you go for the community posting and during the rural areas also, we have to teach the parents, not the children. The children doesn't know anything. They want to play, but we have to teach the parents how we have to protect the children. So avoid the obesity, then regular health checkup, then protect the sun, proper sleep, okay, then all those things. Next slide. Next, cancer prevention in adolescents. After 14 years, 15 years, so we will be doing adolescent period. That time only everybody will become heroines. Impact of cinemas. Yes or no? So that actor is smoking, I also will smoke. He was drinking, I also will start to drinking, everything. All the habit will start during this adolescent period. So that all should be avoided. The HPV vaccination is there, then health education, avoid tobacco and alcohol, and healthy lifestyle habits, and sexual health education. Through this, we can prevent the cancer during the adolescence period. Next. Next, we will move to the risk reduction in the young adulthood. That is the 19 to 39 years. Young adulthood, that is a period where the people develop most of the diseases by work hard work. So here the testicular, especially the men, we have to do the testicular self-examination. So the period is 20 to 35 years. So for the males, the testicular cancer, prostate cancer, all those will develop. So we have to do the testicular self-examination. We do that. Same like that for the females, we have to do the breast awareness, self-breast examination that we have to teach to them. So you have to identify, so every day as previously teachers told, during the bath time or during the bedtime, so you have to do all those things. Then cervical screening, pap smears, so you can after the 21 years, we can start doing every 2 years once or 3 years once according to your conditions, so you can do that. Next, risk reduction in the middle adulthood, that's a 40 to 64 years. Here what happened, the screening era. So after the 40 years, most of the people will be started suffering from diseases. Yes or no? So till 40 years will be starting to working, so with the stress and running for the family, like that will be there. After 40 years, all the disease will start. So here, this is called the screening era. So more than the 40 years, the cholesterol, we got to the cholesterol level, but all the diseases we have to see that. Then breast examination we have to do that. Then prostate cancers all will be developing. So we have to do all the screening tests. As I told, the master health checkup or any other health checkups, that all we have to do at least 3 years once or 2 years once, like that. Next. So how can we prevent during this adulthood? So the main things is regular health checkup, then cancer screening test, and healthy diet, and physical activity, and weight management, and stress reduction. So these are all the some of the ways we can prevent the cancer during the adulthood. Next, sir. Next, risk reduction in the late adulthood after 65 years. So here the lung cancer screen. So here the low dose of CT scan for those who with the significant smoke history. So you have to do the CT scan, MRI, something is there that need. We have to do that. Then mostly the risk versus benefit. So after 65 years, see the lifespan. So what is the lifespan? The 64 years, the Indians, the lifespan is there. Okay. So see that depend still how many years he will be there. So instead of finding the disease and making them to give treatment, I put 10 lakhs, 15 lakhs for the hospitalization, everything. So see the survival of the rate. So that is a when to stop screening. So that time no need of start to do all the checking. It is all you have to screening, everything you do at the age of 40 years. Not others after 65 years. So already whatever there, then God is there as a sort told no. So nature, nurture and Narayana. God is given, no other. So we have to go to the God after 65 years. Say bye bye. Like that. Okay, no need to go to hospital suffering and this spending whatever the children earn, and the children will become Kadangara. So that should not be happen. You have to see, but you have to see the life of the person. That is important, because we have to take care of the parents. That is one of the ways there. You have to see that what is needed, the benefit, because of we do some things the person he can survive for another 5 years, 10 years. Yes, definitely we can go. For another you going to die within 1 month or 2 months. No need of. It's my personal vision, but don't think bad. Okay, it's all depend upon you. Okay, next. Next, cancer prevention in old adulthood. How we can do that? First, regular health checkup. Then cancer screening test. Then healthy diet, physical activities. Then weight management and stress reduction. Through this, somehow we can maintain. So they'll go for the park, play. That's whatever we want. Same like that. My grandmother also experienced. He was suffered from stroke. More than after 67 years, something like that. So when I was studying BSc 4th year. So that time, so I was there in Chennai. So my parents called like that. So just one day visited there. So then I told my father, so you don't take her to hospital. This is 2003. It was happened. 2002, 2003 that time. I was student, final year student. Because we have got stroke. Now we cannot do anything. So because most of the, especially the nervous system, we cannot gain back. So what I told, so better whatever she want, give the good food. Till now whatever she not eat, mutton, chicken, whatever you want to give daily good food. Maximum 20 to 25 days she will be survive. So will be, don't worry, because already she has suffered something, so we can leave her peaceful death. So at the end, so after I went there, so she not allowed me to stay in my home. She told, go, why you came here? She was not able to speak also, but she was pulling my hand and go, you go, why you came here? Go to college, don't stay here, go like that. I went to for my study, but after 22 days, she died. So, but it was peaceful death. My mother also took care of very well. So it was like this. So the age we have to see, the olden age, what we can do, the peaceful death, that is the main thing what we are going to give to our parents. Next. Next, the ABCD of the skin assessments. Already maybe some teachers have explained. So here mainly when with the risk reduction and prevention cancer, everyone, listen here, everyone has to identify this in your body. So this is A, B, C, D, E. This is the main thing in our life, we have to follow that. The A is asymmetry. Suppose if you find any tumor or any other wound, something like that, the asymmetry will be there. Some of this is like gulles and some other boil, something, if you see that, no, it will be all round shape. But here the cancers, anything, if you find if it is a cancer tissue or cancer injury, something is there, or malignance of growth, if you find, that will be asymmetry will be there. Then the border, how there will be like irregular borders, the second picture. There's no round border or square border, it will not be like this. It's a irregular or notch will be there. Next the color, the multiple shade will be the color, will be there, not red or not black, something like this. The multiple color will be there. And the diameter also is more than 6 mm will be there. And the evolving, change in the size. Last month it will be small, again it will grow, again it will be go on growing, will be the change in the size, shape and the color. So if you find any of these symptoms, then immediately you have to visit to the doctor and start to screening the process and try to prevent at the earliest. Next. Next, cancer screening methods. There are a lot of screening methods are there already. The diagnostic method, we have studied so many things. Just for the preventive method, we can do this pap smear for cervical cancer and mammography for the breast cancer and colonoscopy for the colorectal cancer and PSA test for the prostate cancer. Next, sir. Next, these are some of the warning signs. This all of you know about it. Okay, caution. Yes? Have you heard this? Caution. So caution is a change in the bowel and bladder habits, a sore that does not heal, and unusual bleeding or discharge, and thickening or lump. Next, I is indigestion or difficulty in swallowing. O is obvious changes in the wart or mole. Then N is the nagging cough or hoarseness. So these are the caution, anything if you find. So these are some warning signs. If you immediately have to go to the doctor and get the diagnostic treatment. Next, sir. Next, the role of nurse is very, very important. Yes? All of nurses, everybody has taken oath, no? Laminating is over, right? So the first day, so the God, as previously Vijay Madam said about this, the God is choosing some people. I also believe in that. Okay, so I hope, so you people are the agent for the God. So some people brought the agents to the college. This college, yes or no? Like this, you are the agents. The people, so you can work for the agent to the God and work for the agent to the demon, Yemen. You know Yemen? The person who is taking to the heaven. Okay, so to whom you want to be a worker? As a agent. You want to work as a God? Work for God or work for Yemen? So I hope all nurses are work for God. Angels. So that's what we call nurses or angels. So we take the oath, I will not administer any drug, knowingly, unknowingly. Yes or no? So we give the care. What is nurses? Nursing definition. Remember, unique function of nurses, that is to assist the individual in the performance of those activities, contributing to the health, whether he is sick or well. Yes or no? So whatever the patient can do, the daily activities, brushing, bathing, combing, all the works will be done by the nurses. Am I right? Even the parents will not do after a particular age. Before 5 years, before go to the preschool, during the preschool time they will do that. When you go to that primary school, you do yourself. Am I right? But the nurses at the age of 40 years also, 50 years also, anything. So you can give care to any, without gender discrimination, will give care for all the male and female patients. Am I right? So God is chosen you for giving the good cause, care to the people, So all of you know about this good touch. I studied. Good touch, bad touch. Yes or no? All of you know that no good touch, bad touch, the uncle touch, all will do no. So they already studied in the movies. Also we learned, the teachers also will teach about that. Have you heard about this healing touch? Healing touch. This is the touch given by the nurses to the patient. Healing touch. If you touch, as the madam told, so you have to sit with the patient. You have to touch the patient's hand and you say that I am there for you. Don't worry. You will be all right. You have to give the psychological support to the patient as well as to the family members. That is the role of the nurses here. So here the nurses will be, what will do, we have to give health education to the family members. Not only about the prevention, the risk factors, everything you have to teach about the health educations and the lifestyle counseling, how they have to behave. What is the smoking cessation, okay, and tobacco, how to control everything, we have to teach about all these things. Next about the vaccination programs. Most of the people doesn't know about that. So we have to teach them. We have to create the awareness among the people. What are the government giving facilities? That is our role to take care of this. Then screening promotion. Then yearly detection. Yearly detection is very important than any other things. Then community awareness. Create the community awareness among all the people is a nurse's role. Next. The barriers to prevention. To prevention of cancer, there are certain barriers are there. That is a lack of awareness. Most of the people, as the myths and facts we see, no, like the lack of awareness are there among the people. The nurses are playing the key role to prevent and to create the awareness among the people. The cultural belief, certain cultural belief, so they will be following that. So because of that also the cancer will come. Then limited access to the health care. So mostly the village side, some people they have to walk and they have to go for job. So if they go to hospital, that one day salary will cut. So like that. So because they will be postponing the visiting the hospitals. So due to that also it will be the certain barriers. Then fear of diagnosis. Most of the people will have the fear of diagnosis. If I go to the doctor, I have this problem, headache, something, nausea, vomiting, hoarseness, everything will be there. But if I go to doctor, if the doctor diagnoses this disease, what will happen? That means what will happen? If my neighbor come to know I have this disease, what they'll think about me? So due to this fear, lot of the people are not going to hospital at the end stage. They are not able to care themselves, or they are not able to tolerate. That last moment they'll go. By the time the doctor will say, this is the last moment, we cannot treat you. This is the end stage. So we cannot do anything. So this all should be certain barriers. Then the financial constraint. So money also will not be there today. So these are certain barriers. We will see that, but as nurses, we have to teach them. So unless don't give the unnecessary expenses to the patients, and you teach them the good care, what need, which is the necessity diagnostic procedure, only that things you can do that. Now can see that some of the movies also, even some of the hospitals also, they'll be, if you go with the headache, they'll start writing CT scan, MRI and all, without assessing the patient properly. So what we have to do, we have to assess the first history collection is very important. Assess the patient conditions and try to find out the things, why it is the cause for the particular things. Then identify the differential diagnosis. Then we can refer them to the hospitals, whatever they need. Next. So strategies to overcome barriers. How can we overcome these barriers? First, community education. So as a nurses, we have to educate the community people about the cancer and the causes, the risk factors, how can we prevent, everything we can teach to them, and affordable screening services. So the government hospitals and some cancer institute, they have given with less cost, so we have to refer them to that particular hospitals. Next, government health program, there are a lot of government health programs is there. Okay, so there also we can refer them. Then the nurses lead awareness campaign. We have to certain campaign programs, some health programs we have to conduct. Next, policy implementation. What are the government implement the policies? Most of the policies not reaching the people. It is end up in the higher level only. Only few hospitals or few centers will be following that. Most of the people not aware about the government health schemes, everything. Okay, so this all we have to take them and reach to the people. Next, sir. Okay, so by this we will end the session. So at the end of this session, so we have all of you learned about, I think, many cancers are preventable. So it is not, as a doctor said, it is not a particular age group. The cancer will not come for it, only for this group only will affected. It's not like that. Only particular gender will affect. Only particular religion people will affect. It's not like that. The cancer will be affect everyone, but it is preventable. When you reduce the risk factors, when you reduce the modifiable factors, when you can know the preventive measures, when you started to follow the good habits, good food habits and regular exercise, yoga, meditation, then automatically you can prevent the cancer. Many cancers are preventable. Then healthy lifestyles reduce the risk. Healthy lifestyle is important. Avoid smoking, alcohol, any other things. Then screening enables early detection. So whether you have disease or not, you are 100% you are healthy, no problem. Just 5,000, 10,000 goes, no problem. Do health checkup. That is very, very important. By that you can prevent the diseases. Then spending the lakhs of rupees later, you can spend thousands of rupees now. Then vaccination prevent certain cancers. Some of the vaccines like HPV, hepatitis B, like this we can, some vaccines can be prevent the cancers. The nurses are essential in the cancer prevention. Nurses play the major role in cancer prevention. Next, sir. Next, in the conclusion, so the cancer prevention is a lifelong process. It's not a particular day. Yesterday I got cancer, today I went to hospital, tomorrow I am all right. It's not like that. So when it's starting the disease itself, it takes a long time. 1 decade it takes. After screening, it takes lot of time. It's not one day we cannot identify. After that, the diagnostics, the chemotherapy, radiation therapy, then surgical. After surgical also, there will be continuous radiation or chemotherapy have to be there. It's a lifelong process. So try to avoid before you get the diseases. So through the healthy lifestyle choices and vaccinations and regular screening and health education, we can prevent the cancer. Next. The final thought which I told you, so the best cancer is the one that never starts. The best cancer. So you can say malignant cancer or brain cancer, that is good. So we will have some pain. I had headache. This I am not able to tolerate. If I get some leg pain, I cannot tolerate it. Yes or no? But if you get some small finger pain, that also not. Tooth pain, ear pain, which is the best? When we feel certain things, we will say that instead of this, if I got this, I will feel better. But any diseases, if you affect, even that's a discomfort. The minor discomfort also will cause a problem. So here, which is there's no good cancer, no bad cancer. So that is, if you find any best cancer in this world, that is never start. If you not started with any cancer, that is the best cancer. And that one caught before it has name, before it has the name, then that is a good cancer. Next. Thank you for giving this opportunity. Thank you once again for everyone.
Thank you, sir, for enlightening us by a valuable section. May I request Dr. Renuka ma'am, Principal of Abirami College of Nursing, to kindly present a memento to sir as a token of gratitude.
Thank you, sir, and thank you, ma'am. It's my privilege and honor to introduce Dr. Periyaswamy ma'am. She has achieved remarkable milestones her teaching career as a lecturer and assistant lecturer in various institutions in Karnataka from the year 2003 to 2010. Ma'am is widely recognized as expertise in NAAC and IQAC quality assurance process, active involvement in research guidance and publications. Let us welcome this eminent personality Dr. to start this session. Healing beyond the bedside, nurses leading cancer care. May I now invite our Vice Principal, Professor Gandhimati Ma'am, to welcome Dr. Periyaswamy Ma'am with a floral bouquet. Thank you, ma'am. Hello. Is it cordless? Hello. Hello, good evening everyone. So, are you all tired? So, I'll be taking very little time, some 30 to 35 minutes. We'll have an interaction section and I hope you are going to enjoy the session. So, if you are very cooperative, even within 20 minutes we can finish. So, is it with you? It is with you. When we proceeding to 1 hour or 20 minutes, it is with your answers. So, shall we start? Yes. So let me first congratulate the organizing committee for organizing such a wonderful national conference, and the topic which I have got, that is healing beyond bedside, nurses leading to cancer care. So actually when I got the topic itself, I felt it was interesting. Always teaching radiation, chemotherapy, treatment modalities, this topic felt somewhat overwhelming and something different. So congratulations to the organizing committee, HOD of Medical Surgical Nursing, for selecting such a wonderful topic. Congratulations, ma'am. And congratulations to the College of Nursing principal and the staff for organizing such a wonderful national workshop, and I'm very happy to be a part of it. So shall we start? Okay. Next. So can you see a photograph? Yes. Can you tell what it can be? What is that? What did you understand? Mic volume. Can you hear? Okay. So what can you interpret from this? Is she a familiar person? No. So can we name her? What shall we name her? Fast. എല്ലാവരും മലയാളീസ് ആണോ? അതെ, അപ്പം നമുക്ക് മലയാളത്തെ കുറിച്ച് സംസാരിക്കാം. അപ്പം ഈ അമ്മച്ചിക്ക് നമുക്കൊരു പേരിട്ടാലോ? എന്താ പേര്? എന്താ? ഗാന? ക്ലാര. ഓക്കെ. സോ അമ്മച്ചിന്റെ പേര് ക്ലാര. അപ്പോൾ അമ്മച്ചി എവിടെ നിൽക്കുന്നേ? ഒരു ഗാർഡനിൽ. സോ നമുക്കൊരു കഥയായിട്ട് തുടങ്ങാം. So I am not very familiar in Malayalam, but I can manage. So she's, as we named, Miss Clara. She was diagnosed with 4th stage of cancer. She was admitted in the hospital. And from morning you have been hearing what is cancer, what are the different stages and everything. So you know 4th stage of cancer, how severe or in which stage she is in. So every day when the nurse goes and treats this patient, she is not speaking, or she is not taking food, or she is not interested. Naturally, she is in the last stage of her life. So the nurse discovered this photograph near to the bedside. So she asked the lady, that is what we name Miss Clara, is this you? So what will be the answer of the lady? Will she feel happy? No. So when you see this type of photograph and you speak with them,
So other than treatment, medication, their food, the diet, instead of that, if you are asking, is it you? So immediately the lady answered, yes, it is me, it was me, and it was my garden. And this photograph tells that Miss Clara is fond of roses, is it not? And she started describing about her garden, about the roses, the colors of roses, the variety of roses. So this nurse and the patient came into a relationship. So this relationship was not created due to treatment or the injection she has given or the medication she has given. The relationship was because of the communication she had. She identified the old photograph, she asked about the photograph, and Miss Clara started talking with the nurse. And finally they had a very good relationship and she developed a very good nurse-patient relationship. So this is what is called as compassionate nursing care. So when we come across patients with cancer, we should be able to be compassionate, provide compassionate nursing care. So that's what we are going to discuss about today in my topic. Okay, next slide. Next. So what is compassion? How can you define compassion? So think of the moment. So Miss Clara, she was not healed with the nursing, what is the nursing care or procedures. She was trying to communicate because of the compassionate communication the nurse had with the patient. So compassionate is not just kindness. Talking kindly or being kind is not compassionate. It is actionable empathy. I hope you all know what is empathy. What is empathy? Is there a difference between sympathy and empathy? Yes, so what is empathy? To see ourselves in the shoes of others is empathy. So compassionate is not just kindness, it is actionable empathy. And as an opening thought, I would like to tell you that patients may forget what you said, but they will not forget how you made them feel. So when you are with the patient, whatever you speak or whatever you do to them, they may forget. But the feeling they get out of you or the feeling they get with your relationship will be a lifelong process. So develop a compassionate care or compassionate relationship with the patients, especially with cancer. So compassionate in oncology nursing, cancer care is unique. Why? When we compare cancer to other disorders, it is a long-term treatment. I think for morning you would have been discussing, it is not a very short duration. It takes a very long process from months to years for healing. So it is a very long process. And the emotional trauma the patient undergoes is very severe in cancer. And the patient usually undergoes a fear of stress and it always disturbs the family process. So how can you define compassion? Compassion is to recognize the suffering. We should recognize or understand that the patient is suffering. So for us, she is a patient and she is a patient with cancer. We should recognize that she is actually suffering or she has a difficulty. And we have to connect emotionally. So as I told you in the story, we should have an emotional connection with them. And we have to take action to relieve. So these are the three things you have to remember. First step, you have to recognize they have an issue. Next, you have to understand. And then you have to connect emotionally. Then you have to take steps to overcome it. So in the furthermore slides, you will be learning how to have a compassionate nursing relationship. And here you see, a patient is refusing to take food. So as a clinical approach, what will you go and tell? You must eat. So if you should recover and go, you must eat. Is it not? അല്ലേ നമ്മൾ എന്താ പറയാ പേഷ്യൻ്റ് ഭക്ഷണം കഴിച്ചില്ലെങ്കിൽ കഴിക്കണം കഴിച്ചാലേ ശരിയാവുള്ളൂ നടക്കണം ഡിസ്ചാർജ് ആവണം അല്ലേ പറയുള്ളൂ ദാറ്റ് ഈസ് കോൾഡ് ആസ് എ ക്ലിനിക്കൽ അപ്രോച്ച് ബട്ട് വെൻ യു ടോക്ക് അബൌട്ട് ദ കമ്പാഷനേറ്റ് അപ്രോച്ച് are you feeling nauseous or vomiting? You should identify why the patient is not eating. Because she is a patient with cancer, just if you tell her food, she will know. You should find out the reason. So this is called as compassionate care. Instead of just telling the patient to eat, get emotionally connected with her, identify the reason why the patient is not eating. Maybe she is nauseated or she is feeling vomiting. That's why, or she doesn't like the food. So be emotionally connected and then start with the care. So this is a simple example which will make you understand what is compassion in oncology. Compassion in oncology മനസ്സിലായോ? എന്താ compassion? വെറുതെ അയ്യോ പാവൻ പറയുന്നല്ല കമ്പാഷൻ. നമ്മൾ മനസ്സിലാക്കണം പേഷ്യന് ബുദ്ധിമുട്ടുണ്ട്. ആ ബുദ്ധിമുട്ടിൽ നമ്മൾ കണക്ട് ആവണം. ഇമോഷണലായിട്ട് വി ഷുഡ് ഗെറ്റ് കണക്റ്റഡ് വിത്ത് ദം. and finally we should help them to overcome that difficulty. That is called as compassionate nursing care. Did you all understand? Understood? Are you able to hear those who are at the last? Okay, next. So why compassion matters in cancer care? This already I have discussed with you, and here you should understand that cancer patients don't just fight disease, they fight fear, loneliness and pain. So cancer patients not only struggling with the disease, they also struggle with fear, loneliness and pain. Next slide. So I think you are familiar with cancer. So to just overview, cancer is uncontrolled abnormal growth. It has the ability to invade the nearby tissues and it can metastasize or it can spread. And many types of cancers are there, and the common ones are sarcoma, carcinoma, leukemia and lymphoma. And here in compassionate nursing, you identify a lady who is 52 years old woman who is having a lump in the breast. So as a female lady, she will find difficult to go for mammography or express this with her relatives, or herself feeling shy to go to a doctor. And finally, when she develops pain or when she develops discharges from the breast, what she does, she goes to the hospital. Then she is being diagnosed with 4th stage of breast cancer, where her life is in a question mark. So as a nurse, we should create an opportunity that the patients are very free enough, or they are they're free to communicate with us regarding their disorder. That is called as the compassionate nursing care in cancer. Next slide. Next. So what is the nurse's role across the cancer continuum? So first one is prevention and education. So the sir who was speaking before me, he has given a very detailed idea about prevention and education, screening and early detection, diagnosis support, treatment administration, symptom management, rehabilitation, palliative and end of life care. Here the nurse works as an advocate of the patient, educator and the care coordinator. So in each and every this aspect, I am not going to tell you what is screening, what is prevention, how can we provide compassionate nursing care in all these processes. Okay, next slide. So the first one, prevention and screening. So already sir has described very well regarding all this. So I am not going deep into it. So as a compassionate nurse, what can you do in prevention? So you can see example, you are a OPD nurse, a patient comes to a OPD visit. The nurse identifies the patient is smoking 20 cigarettes per day. What will you do? You will spend 5 minutes and you will tell the patient how to stop tobacco, or if there is any programs or counseling, you will refer the person to the program, or else not just collecting the history and proceeding with the doctor's procedures. So this is called as compassion in prevention. So whenever you hear the history or you know the patient is at a risk of developing cancer, as a nurse, as a compassionate nurse, as a empathetic nurse, you should be able to identify and help them across so that they are not going to develop cancer. Next. Next is the screening programs. I hope you are familiar with all this, like mammography, colonoscopy, oral cancer screening and pap smear. So when the person comes for screening, as a compassionate nurse, explain the procedure in a very simple language so that you will alleviate their fear. You can obtain the consent, reduce the anxiety and maintain privacy. So most of them don't like to be diagnosed with cancer. So in this stage is a critical stage where the nurse can have a very compassionate relationship, where you can make them understand that screening is very essential, and sir has already explained you what is screening, what are the different types of screening. So I am not going detail into it. As a compassionate nurse, be with the patient during each and every diagnostic procedures. Next slide. And during the diagnosis, you can assist in biopsy procedure, you can monitor the post-procedure complications, and as a nurse you can prepare them emotionally and physically. For example, a patient go for liver biopsy. So once the liver biopsy procedure is over, it is not that your responsibility is over. You have to observe whether the patient is having bleeding. check the blood pressure, see whether the patient is going for hypertension, and ask the patient several times whether he is struggling with abdominal pain, because these patients are in pain for a very long duration, so they may not report that they are having pain. So if all these are the patient is going to a complication related to liver biopsy. So it is not that I have taken the patient for liver biopsy, procedure is over, I have shifted the patient from the room and my duty is over and I am leaving the shift. So your handing over should be in that a way. When you give the handing over, also explain to your co-partner, I have shifted the patient just from the liver biopsy, he can have abdominal pain, he can have a drop in blood pressure, check the blood pressure and report to the doctor. So this is called as compassion. So last till all the conditions we learn during pre-procedure, intra-procedure, post-procedure. Once you shift the patient, our duty is over. But in case of cancer, even due to diagnosis, patient can develop multiple complications. So we have to be compassionate and we should be behind them to identify whether they are going to suffer because of the procedure. Is it clear? Are you all able to follow? Am I too fast? Yes. Okay. And the major thing you'll be facing with the cancer patient is breaking the bad news. So telling a patient you are diagnosed with cancer, you are diagnosed with 4th stage cancer, or it is inoperable tumor, or there is no surgical treatment available, that is a very bad and restricting factor you will be undergoing, or situation you will be undergoing. So during that situation, how will you encounter the patient? Sit at the patient's level, allow silence, encourage question. So you stop talking and ask the patient to ask anything and then provide emotional support. So usually during this time the patient becomes mum, they will not speak. So don't force them to speak or don't force them to tell anything, just sit silently with them after you break a bad news telling they are being diagnosed with cancer. So here the patient, I am giving you an example, a patient says, am I going to die? So what will be your answer? Will you tell yes? You will tell no? Yes or no? No. What will you tell? I understand that this diagnosis is frightening. Let's talk about a treatment options. There are so many treatment options available. We'll discuss with your doctor or what can be done, what will be the survival. So you can speak about it and you can deviate the patient from the current situation. So breaking the bad news is a very critical situation you will be facing as a nurse working in the oncology sector, and telling the diagnosis or telling a patient you are hypertensive or telling you are diabetic is different by telling you are having cancer. So you should be very cautious when you are breaking the bad news. Next. And these are the different treatment modalities like surgery, chemotherapy, radiation, immunotherapy and targeted therapy. Each and every therapy the nurse plays a very vital role, as I told you. Not only shifting the patient for the procedure or post-procedure care or treating them like dummies. They are human beings who are undergoing a very distressful situation and pain and agony. So as a compassionate nurse, be with them during the procedure, motivate them, emotionally give support and psychologically provide support to them. To each of the treatment modalities, I am not going deep into all this. I think from the morning you have been hearing. Is it not? Okay, next. So during chemotherapy, you will verify the drug, dose, patient, check the lab values. You will assess the IV site. During administration, you will monitor for externalization, watch for analysis, and after administration, educate about side effects and safe handling of body fluids. So opposite, I have given you example. A patient is receiving IV chemotherapy. He develops flushing and breathlessness. So it is not like any other drug you are administering. It is chemotherapy and it is so complicated. So immediately you will stop the infusion, you will inform the doctor and you will administer the emergency medication. So when you administer chemotherapy, usually it is not like any other IV fluid we are administering. Chemotherapy, even during the process of infusion, the patient can die, he can develop complications. So be very cautious when you are administering the chemotherapy. Watch rigorously and be very polite to the patient. He may develop nausea, he may have tiredness, he may become sick, his BP may fall. So many you cannot tell that the patient is going to develop only this complication. You cannot expect the complication during chemotherapy. So as a compassionate nurse, understand the patient is struggling and be with him during the chemotherapy. Next. And you have to protect yourself also. So wear PPE, use biological safety cabinet, you dispose the cytotoxic waste properly and follow the spill management protocol. Next. This is the spill management protocol. You will isolate the spill area, you will contain, you will decontaminate, dispose and record. If the spills are smaller, if it is a larger spill, then you will notify to the healthcare provider. So radiation therapy, I am not going detail into it. It is a external beam radiation, you have internal beam radiation. Here the patient can develop skin rashes and redness, so avoid harsh soaps, no tight clothing, report burns and skincare education. So if the patient with the neck radiation is developing any complication, so you should observe the patient after radiation whether he is developing, because sometimes they will not have pain. Without the patient's knowledge, he may be developing redness, he may be developing color changes. So inspect the area after the radiation therapy, see whether he is developing, and if he is undergoing any changes, notify the physician and take actions that they will not go into complications. Next. And the common side effects with cancer management is patient can have nausea, so administer antiemetics before chemotherapy. Patient can have hair loss, so you can give psychological support. That is a very important aspect. Usually people struggle with, they will have unexpected hair loss once they start the chemotherapy. So you can give them different options like use of wigs or scarves or any other options that can make them mentally prepared. Once chemotherapy is started, they will be having hair loss. Then neutropenia, prevention infection. Then fatigue, you should teach the techniques of energy conservation. A patient can develop mucositis, then you provide oral hygiene and care. So here the major thing they can develop is neutropenia. I hope you all know what is neutropenia. There is abnormal drop in the blood neutrophil count, so the patient is prone to develop infections. So here you will monitor the temperature, you will follow very strict hand hygiene and tell them not to eat any raw items and limit the visitors. In case of emergency, the patient temperature is more than 38 degrees Celsius, you will report, because the patient is developing febrile neutropenia. So you would have seen patients with cancer walking around with mask. So before corona, when anyone walks with mask, we will observe them why they are walking. Now we are very used to this usage of mask. So the patient with the cancer can develop neutropenia and infections are prone in them. Make sure that they will not develop any infection. So as a compassionate nurse, make the family members understand the importance of neutropenia and how to manage with it. Okay, next. And apart from all this, the patient can also develop some oncological emergencies like spinal cord compression, superior vena cava syndrome, tumor lysis syndrome and hypocalcemia. So a patient with leukemia after chemotherapy will develop muscle cramp. So muscle cramp is very simple. So you may massage the area or you can apply some antiseptic analgesic ointments, or you will give analgesics, but that is not the case. The patient is developing tumor lysis syndrome. So tumor lysis syndrome is a complication of tumor, that is the tumor cells are breaking lysis and it is spreading throughout the bloodstream. So even a simple muscle cramp or a simple nausea or a simple vomiting can lead to complications. So whenever you care with a patient who is developing cancer or who is having a treatment for cancer, be very cautious even with a very simple signs and symptoms. Next. And major part we are going to discuss is about the psychological and emotional support. So here the patient, due to hair loss, she can develop body image disturbances, there's fear of death, financial concerns and family stress. All this sir has already explained in detail. So here the nurse's role, whenever the patient has any psychological issues, active listening, refer to a counselor and have some support groups. So I have given you an example of emotional care. So a patient is undergoing chemotherapy, refuse full daily. So doctors prescribe supplements because the patient is not taking any food. What doctors did, they have given some IV fluids or supplements, but nothing changed. So one nurse sat beside her and gently asked, "Are you feeling sick or something worrying you?" The patient cried and said, "Yes, I feel I am dying. What is the point of eating?" So the nurse, so this is the reason the patient is emotionally down. So the problem is not physical. Patient is not eating because of nausea or vomiting. the problem is not physical, the problem is emotional. So as an oncology nurse, you should be able to relate whether the problem complaint of the patient is physical cause or a emotional cause. So here you can see, usually when the patient is not eating, we relate it to the physical. Maybe patient is not feeling hungry, or the patient is having constipation, or patient is feeling nausea. But here in this case, what is the case? The patient is at the end of life and she is feeling very bad that she is going to die. So she is asking, why should I eat? So identify the reasons. So what will you do? You give her psychological support, give some support groups, give her counseling, make her understand the need of food. So here the problem of not eating food is not physical, it is emotional. Okay, next. And the other part of oncology care is palliative and end of life care. So here we focus on pain control, comfort, dignity and pain scale regularly. So once the patient is in the end of life care or palliative care, it means no further treatment is required, or patient cannot be treated, or even if surgery is done, they are not going to survive. So in that case, the main thing we are going to focus is dignity of the patient. So let the patient have a peaceful death. So 4 major things you will come here is pain control. Give analgesics to the patient whenever required, and we have the WHO ladder for analgesics. According to that, you can give analgesics to the patient so that they will die without pain. And every frequently use a pain scale as the pain analgesics can be given. Provide ultimate comfort to the patient, provide dignity to the patient during the end of life care. And example, if the patient rates pain 8 or 10 on the scale, then administer the opioid and reassess every 30 minutes. So if the patient is telling pain, every 30 minutes also you can give the medication so that the patient will live with dignity and he will die without pain. Next. So here end of life nursing care. Here we have a story. A patient quietly asked a nurse, am I going to die? So the nurse paused, sat down and said, I understand why you are asking. What worries you the most? The patient opened about fear of leaving children. So she has a mother, she had children. So her fear on end of life is she is going to leave her children behind. So you can find out the family support, who can support them, or how their family or children are going to live without the mother. So here compassion is not about giving answers, it is about holding spaces. So for this question you cannot answer. I am going to leave my children and die. So what is going to happen to my children? That is the question of a mother. So this place, as a nurse, you have no major role to do. But you can have some support systems or make them understand that something is required or something can be done. So this is the end of life care a nurse can give to a patient as a oncology nurse. Next slide. So here the patient is in the last stage. She is asking for relief. So here we are shifting from curing to comfort. End of life care is not focusing on curing. When the cancer is being initially diagnosed, we have so many treatment modalities, we will try everything. And at one stage, there is no treatment is available or he cannot be treated. So he comes to the last stage, which is called as end of life. So our concern shifts from curing to comfort. Main thing is we have to keep the patient comfortable. And pain management, as I told you, and emotional care. So holding the patient's hand can be as powerful as medication. So just without giving medication, you can just sit with the patient, you can hold his hand, you can listen to what he is telling. So rather than giving a medication, even holding the patient's hand can cure or can give some sort of comfort to the patient. Next slide. And when we talk about the ethical and legal responsibilities, as a nurse, you should know how to get informed consent, how to maintain the confidentiality, how to respect the autonomy of the patient and truth telling. So the family will request you not to tell the diagnosis to the patient. So each hospital will have their own policies of what should be done. But the patient should know that she is struggling. So whatever the policy of the institution, that should be followed, and there are few ethical principles that has to be followed. So as an oncology nurse, you should know how to break the bad news and whom to tell, whom not to tell, how to maintain the confidentiality and how to carry over the treatment process. And documentation, this is a very important part of nursing. So we have to record the drugs administered, the side effects. I told you even very simple signs can be side effects, and how you manage the side effects, what were the vitals of the patient. Even simple fall of blood pressure can lead the patient die. Patient's temperature of 38 degrees Celsius is severe neutropenia. So even the vital signs documentation is very important, and patient education. And if there is no documentation, it means that you have not done anything to the patient. So whatever you do or whatever you have done to your patient during your care or during your duty shift, everything should be documented very clearly, because each and every minute of a patient's cancer life is very precious. So everything should be clearly documented. Next. And as you all know, cancer cannot be managed only by a nurse. It is a multidisciplinary approach where we have an oncologist, we have a nurse, we have a pharmacist, we have a dietitian, we have a social worker, and we have a physiotherapist. And here the nurse will be the central coordinator. So central coordinator is a person who coordinates all these persons. So in oncology, the nurse plays a very important vital role where she will be coordinating the multidisciplinary team. Next. So usually in cancer what you have seen always shouting at nurses. Few people, a man is always shouting at nurses. And once the nurse asks, why are you shouting or what is worrying you? Then he is crying and telling, I don't want to lose my mother. So you will face this type of relatives also. So cancer not only affects the patient, it will affect the family members also, because they don't want to lose their loved ones. And this fear of losing the loved one changes into anger. So it is not that when the relative is always shouting at you, it doesn't mean they are angry at you or they are angry at the hospital. It is their own fear they are making anger or they are shouting at you. So understand the relatives also that they are shouting or they are blaming is only because of their fear. Next. And here again, if the patient is asking, so I have already explained. Next slide. And as a team approach, the nurse has made a major role where she plays a role of emotional anchors. So the patients are very free to the nurses. They will share their problems with the nurses. So the nurses act as a emotional anchors. They will understand the emotions of the patient very well, better than the doctors. And they are patient advocates. They will help them to take informed decisions. They are educators. So I told you all the screening procedures, preventive procedures, diagnostic procedures, you are with them. Doctor is doing the procedure. So you play a very major role in the diagnostic theory as educators. And you are supporting the family. So you are called as the family supporters. So we are helping the family actually to cope up with this situation. And we are end-of life care providers. I told you our aim changes from curing to comfort. So we are the agents who provide end-of-life care to the patient. Next. So you see a patient is always silent. A young cancer patient stop talking. What can you do? Now you can answer. ഒരു cancer patient വർത്താനം പറയുന്നേ ഇല്ല. അപ്പോൾ നമുക്ക് എന്താ ചെയ്യാ? നമുക്ക് മൈൻഡ് ആക്കാതെ പോകാൻ പറ്റുമോ? ഇല്ല. അപ്പോൾ നമുക്ക് എന്താ ചെയ്യാ? ഫാസ്റ്റ് എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ? അവരുടെ കൂടെ ഇരിക്കാം, പിന്നെ അവരോട് കമ്മ്യൂണിക്കേറ്റ് ചെയ്യാം. Can we force them to speak? No. So next slide. So power of presence. So if you can just fix the silence, sit with them. Just sit beside them, the patient daily. So what this nurse was doing, she was just going and sitting. She was not at all talking. So fourth day, the patient slowly started talking and she told, thank you for not forcing me to talk, because she was not liking to talk. So the presence made a great change. So even if the patient's not talking, your presence. So when you enter into the patient with cancer, the patient is not talking, it doesn't mean you will do a procedure and you will come back. You will spend time, you will be present there. Even that presence can make changes. And the second one is the last moment. So after the thing, when the patient was going to die, she talked with the nurse and she told, once the nurse caught the hand of the patient or touched the patient, she told, now I am not afraid. So sometimes touch heals more than medicine. So presence and touch, they are patients who are struggling and suffering and they are at the end of life. So presence and touching have a major role. Next. And we can have non-verbal communication like eye contact, look into their eyes, sit down with them, gentle tone, you speak with them with a very gentle tone, and appropriate touch. These are some non-verbal clues which will make them more comfortable. So body language speaks louder than words. So even when you're not speaking, your body language, the way you speak, the way you communicate, the way you look with them, the way you touch them, all these can create a major difference in care of patients. Next. So till now we have been discussing about the patients. So not only the patients, after doing all this, we are also becoming tired. Is it not? So how will you take care of yourself? The tired nurse. So nurse is also doing all this. She is getting tired and she stop connecting with the patient. So your situation comes like this. What can you do? Take a break. Have a conversation with your colleagues, speak, open up. So because when we face all these situations, when we see all this as a nurse, we are also human beings, we will get tired and we will get out of place. So we also need some sort of relaxation. So have a very good communication with your colleagues. So you must care for yourself as you care for others. Next. So to care yourself, you cannot pour out from an empty cup. കപ്പിൽ ഒന്നില്ലെങ്കിൽ നമുക്കൊന്നും ഒഴിക്കാൻ പറ്റില്ല. ഇത് മൊത്തം ചെയ്യേണ്ടത് നേഴ്സ് അല്ലേ? അപ്പൊ ഈ കപ്പ് ആരാ? നേഴ്സ് സന്തോഷമായിരിക്കണം, നേഴ്സിന് എന്തെങ്കിലും ചെയ്യാൻ പറ്റണം. You should be happy. So if we are empty, we are tired, we are not able to do anything, the patients are not going to get anything out of you. So you should be a cup full. So how can you make yourself full? Signs of burnout, we may become emotional exhaustion, we may become irritable and we may detach. In that cases, take 1 minute breathing, talk to your colleagues and you should have your own emotional boundary. When we care the patients with cancer, especially with kids, what happens, today they will be there, tomorrow morning when we go to duty the patient would have expired. So we will get emotionally drained out because we will get so attached with that usually pediatric oncology patients, is it not? And this occurs even in adults. So we should have our own emotional boundary. Though we are doing all this to the patients, we are very close to them, we are doing everything, we should have our own emotional boundary so that even something happens to them, we are able to face. So do not have too much of personal relationship with the patients. Next. So some things which you like to take, do small things with great love. Compassion is a skill and it is not just a feeling. Nurses are the leaders in cancer care. So I am also a nurse and I proudly tell we play a very major role in cancer care. Though there is oncologist, social worker and everyone, we are the coordinators and we are the leaders of cancer care. And small actions create, I told you, just explaining about the photograph or asking about your family will create a big change, and caring for yourself. So when you do all these things, we cannot pour anything out of an empty cup. We should be happy, we should be healthy. So take care of yourselves also. Next. So thank you. Do you have any questions? Any clarifications? You understood anything? So what did you understand? അത് ചോദിക്കാൻ പാടില്ല അല്ലേ? ഒന്നും മനസ്സിലായില്ലേ? ഇപ്പോൾ ഒരു ഓൺകോളജി പേഷ്യൻ്റ് അടുത്ത് പോകുമ്പോൾ നമ്മൾ എങ്ങനെയാണ് നിൽക്കണ്ടേ? സാധാരണ പേഷ്യൻസ് അല്ല അവർ, ദേ ഹാവ് സ്ട്രഗിൾ, അതുകൊണ്ട് മനസ്സിലാക്കണം. അതേമാതിരി റിലേറ്റീവ്സിനും ബുദ്ധിമുട്ടുണ്ടാകും, അത് നമ്മൾ മനസ്സിലാക്കണം. ഇത് നോക്കി നോക്കി വരുമ്പോൾ നമ്മൾ വയ്യാതാകരുത്, നമ്മളെ നോക്കണം. അതെല്ലാം മനസ്സിലായേ? അത്രയേ ഉള്ളൂ. അപ്പൊ അമ്മച്ചിന്റെ പേരെന്തായിരുന്നു? ക്ലാര. ക്ലാര അമ്മച്ചിക്ക് ഇപ്പൊ സന്തോഷാവൂലേ? ഇത്രയൊക്കെ നമ്മൾ ചെയ്ത് സംസാരിച്ച് ഭക്ഷണം കഴിപ്പിച്ച് ഫാമിലി കുളിച്ച് സംസാരിച്ച് നമ്മൾ ടേക്ക് കെയർ ചെയ്യുമ്പോൾ ഈവൻ ദ പേഷ്യൻസ് ആർ ഹാപ്പി, വി ആർ ഓൾസോ ഹാപ്പി. ഓക്കെ, സോ താങ്ക് യു, ഹാവ് എ നൈസ് ഡേ. താങ്ക് യു.
Thank you, ma'am, for your knowledgeable and interesting section. Now I request Dr. Tamilnadu ma'am, Vice Principal of Abirami School of Nursing, to kindly present a memento to ma'am as a token of love.
Kind attention, please. We request all the participants to kindly take a moment to scan the QR code displayed on the screen and share your valuable feedback. Your responses will help events in future. I repeat again, we request all participants to kindly take a moment to scan the QR which is displayed on the screen and share your valuable feedback over there. Kind attention, please. We request all participants to kindly take a moment to scan the QR which is displayed on the screen.
Hello.
Now, I request all the dignitaries to come to the stage as we are about to start the valedictory session. I repeat, I invite all the dignitaries to come over to the stage as we are about to start the valedictory session. I request all the dignitaries to come to the stage as we are about to start the valedictory session. We arrived at the concluding chapter of this enriching national conference. It is now my privilege to welcome you all to the valedictory session, a time to honor contributions, acknowledge excellence and carry forward the spirit of learning.
Now I would like to introduce HOD of Medical Surgical Nursing Department to deliver the conference report.
Good evening to one and all. The Department of Medical Surgical Nursing of Sree Abirami College of Nursing has successfully organized a national conference titled Cancer Care, the Next Frontier, exploring innovative approaches to battle cancer. On 25th March 2026, the conference aimed to enhance knowledge, promote innovation and strengthen clinical practices in cancer care among healthcare professionals and students. The registration for the conference commenced on 9th March 2026 and concluded on 20th March 2026. The total of 686 participants registered from 18 colleges for the conference, which included 217 registered nurses and 469 students from various colleges. The overwhelming responses reflected the growing interest and importance of advancement in cancer care. The conference begins with registration at 7:30 a.m. followed by the inaugural session from 8:30 a.m. to 9 a.m. The scientific sessions were started at 9 a.m. covered diverse and important topics such as understanding cancer from risk factor to tumor types. And second one, early detection and clinical identification of cancer. And third, advances in cancer treatment modalities. And fourth one, palliative care and quality of life. And fifth one, cancer prevention and strategies across lifespan. And last one, the role of nurses in comprehensive cancer care. The eminent speakers from reputed institutions across Tamilnadu, Karnataka, Kerala and Puducherry delivered insightful sessions enriching the knowledge of participants. The conference provided a platform for academic and research excellence through paper presentation and poster presentation. So 9 participants for paper presentation and 12 participants for poster presentation from various colleges. Participants presented innovative ideas, research findings and evidence-based practice related to cancer prevention, diagnosis, treatment and patient care. And best posters and papers are awarded with shield and certificates. The conference concluded with a valedictory session from 5 p.m. to 5:30 p.m. where the contribution of participants were appreciated with 7 TNNMC credit hours and certificates were distributed. The national conference was a grand success, achieving its objectives of disseminating knowledge and encouraging innovation in cancer care. It provided a valuable platform for healthcare professionals and students to learn, share and collaborate in the fight against cancer. Thank you.
Now I request Dr. Renuka ma'am, Principal of Abirami College of Nursing, to kindly present a memento to Professor Sarla ma'am for organizing such a wonderful conference.
Now I would like to call upon Manimegalai ma'am from KMCH College of Nursing to provide the feedback of today's session.
The respected dignitaries.
Good evening to respected dignitaries on the dais and off the dais. This is Mani Meghli from KMCH College of Nursing. I'm also the alumni of Sree Abirami College of Nursing. So I did my M.Sc over here. It was like I'm feeling very emotional standing here, seeing my students as faculties and my old principal ma'am, Ms. Renuka ma'am, and our dean sir, ex-dean sir, Arvind Babu sir. It's very happy to be here as a part of Sree Abirami College of Nursing as well as KMCH College of Nursing. Today's session, there was 7 sessions. Each session was really wonderful and perfectly organized. I would like to congratulate the organizing secretary, Ms. Sarala ma'am. It was a best so far national conference related to cancer. So it was a best. Thank you so much.
Any student volunteers from any college?
Good evening everyone. I guess this conference was really impactful. I really loved the way teachers taught us stuffs, and then what I thought is that at the last, like the suggestion is that at the last side we didn't actually listen to whatever, like it was not audible, so we were not actually listening. That is the problem. And then another one suggestion is that okay if we say the suggestion? So I guess the tea break and the interval time should be increased. That is the only thing. Otherwise the session and the lecture and the clinical takeaways and the practical takeaways was good. Thank you so much.
Prizes and certificate distribution. Now we move on to the one of the most awaited moment of this valedictory session, the prize and certificate distribution. I request any one representative from each college to come forward and collect the certificates. First, I invite RVS College of Nursing. Any one member from the class can come and collect the certificate. I request the principal of Sree Abirami College of Nursing to distribute the certificates. College of Nursing. Students, kindly maintain silence. Next, I invite Sree Ramakrishna Institution of Paramedical and Science. I repeat, I invite Sree Ramakrishna Institution of Paramedical and Science. Next, I invite Royal Care College of Nursing. Volunteers, come forward. Ma'am? Ma'am? Okay, ma'am. I request Royal College, KMCH College of Nursing. Okay. Next, Ph.D. College of Students, get ready. Ph.D. College of Nursing. Volunteers, be ready. Next, I invite Nehru College of Nursing. Ph.D. College. Ph.D. College of Nursing. Next, I invite Hindustan College of Nursing. Volunteers, be ready. Next, I invite Sree Sai Ranganathan College of Nursing. Next, I invite GKNM College of Nursing. Next, Ganga College of Nursing. Ganga College of Nursing. Next, it's Tamilnadu College of Nursing. Next, it's Karpagam College of Nursing. Volunteers, come forward. Next, I invite Sree Abirami College of Nursing and School of Nursing.
Students from 3rd semester, Abirami College of Nursing. Anyone volunteers? Thank you, ma'ams. We shall now proceed to the prize distribution for the paper and poster presentation. For paper presentation, first we started from second prize. Sweta Gopinathan from Sri Ramakrishna College of Nursing got the second prize for paper presentation. First prize goes to Ms. Kanmani from Sri Ramakrishna College of Nursing. For poster presentation, the second prize goes to Ms. Jwala and Ms. Jacqueline from Sri Abirami College of Nursing. And then first prize goes to Sri Manju from GKNM College of Nursing. Congratulations to all the participants. Thank you, ma'am. Gratitude is not only the greatest of rituals, but the patience of all others. On that note, it my privilege to invite Dr. Christy ma'am to deliver the vote of thanks and express a heartfelt appreciation to everyone who contributed to success the national conference.
Gratitude is the fairest blossom which springs from the soul. A very blessed evening to one and all. I am Professor Dr. Christy and I feel deeply honored and privileged to stand before you to propose the vote of thanks for this enriching national conference on cancer care, the next frontier. At the outset, I would like to express our sincere and heartfelt gratitude to the esteemed management for the constant guidance, encouragement and generous support. This conference stands as a reflection of your vision and commitment. With great respect, I extend my thanks to our beloved principal for the inspiring leadership and unwavering dedication that made this event possible. I take this opportunity to convey my deep appreciation to the distinguished resource persons. Your insightful sessions and valuable time have truly enriched our understanding and inspired us in the field of cancer care. My sincere thanks goes to all our faculty members for their dedicated efforts, thoughtful planning and teamwork in organizing this conference so smoothly. I would also like to extend heartfelt gratitude to the respective principals of various colleges in and around Coimbatore for kindly permitting their faculty members and students to be part of this academic gathering. Warm thanks to the faculty members and students from other institutions for your enthusiastic participation and valuable presence. A special word of thanks to our dear students for your energy, curiosity and active involvement which brought life to this conference. I also wish to acknowledge the technical team for the seamless support and efficient coordination throughout the event. Grateful thanks are extended to the administrative officer, supervisors and all the supporting staff whose effort behind the scenes made this event possible. I also sincerely thank our non-teaching staff for their cooperation, commitment and valuable support throughout the conference. Finally, I express my humble gratitude to each and every participant for being a part of this meaningful and contributing to its success. With deep gratitude and respect, I conclude by thanking you all once again. May we continue to learn, grow and serve with compassion in the field of cancer care. Thank you.
Thank you, ma'am.
I just want to clarify her suggestion, okay. See, in case if at all we increase the time of your lunch or break time, this would have not been completed so soon, okay. So that is the reason, due to the constraint of time, we have limited your lunch break as well as tea break, okay. So we'll try to take up this suggestion in the next forthcoming conference. Thank you.
Thank you, ma'am. As we come to close today's section, let us stand united in pride and respect for our nation.
Janagana